Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. I hope you enjoyed the first day of our conference yesterday, and it was a long day. Today will be our second day of the 9th International Conference in Pediatric Emergency Medicine. I would like to have some announcement for the questions of yesterday. Actually, we received all the answers, and it will be in the area of chat icon. Okay, and we'll leave the answer and questions icon for today. Okay, so you can review your questions of yesterday with the answers in chat area. Okay, this is the first announcement. And if you have any question from yesterday, you can put it in question and answer area. The other thing, I received a few calls from some of our participants, and they are asking today, there is no need for, if we can actually make the question and answer break from 12 to the same like yesterday. I need your comment, please, in the question and answer, whether to continue or to cancel the question and answer. I mean, the break after the first and the second session. I need your feedback, please, whether to cancel so we can finish early today. Now, I really have the pleasure to present Dr. Marianne. Yes, I have the pleasure actually to present today our speaker, Professor Marianne Goshi Hell, professor of clinical emergency medicine and pediatrics in David Geffen School of Medicine, Harbor UCLA Medical Center, Department of Emergency Medicine and Pediatrics. She is the executive director of Academic and Clinical Affairs, the Linguist Institute in Torrance, California. Dr. Marianne Bushi, she is a well-known speaker, and she is actually the chairman of the scientific committee of this conference. She's been working with us for the last 15 years, and I would like to welcome her today to talk about important topics, and which is dysrhythmias and cardiac arrest in children, critical response strategies. Dr. Marianne, you can start, please.
Hi, I'm Dr. Marianne Gauchi-Hill, and we're going to be talking about dysrhythmias and cardiac arrest, critical response strategies. Let's get started. First of all, I think we're all familiar with the chain of survival. Obviously, the first two require public recognition of a cardiac arrest. We'll talk about that, as well as alerting the emergency response system. High quality CPR is critical for every step of this chain. Advanced resuscitation by EMS. Post-cardiac arrest care is critical, especially rehabilitation. And I'm very interested in the first minutes of post-ROSC care, and that is generally in EMS. About 40% of patients rearrest within the first 5 minutes, and then finally recovery. So we're going to start with some cases, and we'll get to the chain. of survival as we talk about this and what the strategies we need to consider. So this is a 12-month-old boy found on the bottom of a parent's pool. Paramedics were called and responded within 2 minutes. The patient is unconscious and the pulse is weak and thready. So this is pediatric bradycardia, and really it's symptomatic bradycardia. And so one of the things to consider is simplifying the algorithm. Really the thing that we think about for most of these cases is oxygenating and ventilating. So oxygenate and ventilate goes a long way, not only for newborn resuscitation, which is dry, warm, and stimulate first, but in pediatric advanced life support, oxygenation and ventilation is critical. So with symptomatic bradycardia, you can see the algorithm, and the question is the cardiopulmonary system compromised? And so you want to first start supporting airway, breathing, and circulation, and then reassessing the need to do chest compressions. So where you have a weakened, thready pulse, there is a concern. I would begin immediately oxygenating and ventilating, and a reassessment within about 30 seconds to a minute to see if there's a need to do chest compressions in this case. So if the heart rate is under 60, children typically are not perfusing, so you might want to consider doing that. Again, I like to oxygenate and ventilate and then reassess. If the bradycardia persists after doing that, then chest compressions and epinephrine can be given, and we'll talk more about epi in just a bit. Finally, transvenous pacing could be considered. So anyway, when we think about oxygenation ventilation from cardiac arrest, this is symptomatic bradycardia, but some of the same principles apply. Is excessive ventilation has some deleterious complications, such as causing decreased cerebral perfusion. It decreases coronary blood flow, overall reducing cardiac output. So through increase in intrathoracic pressure. So really key not to overventilate these patients. And during CPR, it's 6 to 10 times a minute. Without cardiopulmonary arrest and with symptomatic bradycardia, I would still do squeeze, release to slow down the ventilation rate, but I would try to keep it around 20 if indeed the patient has a pulse. So if truly the patient is unresponsive to oxygenation, ventilation, and medication, so after epi is given, so it's oxygenation, ventilation, medication, and then pacing. So the key is you want to shoot for a heart rate about 30 beats above normal, so approximately 100 for a child. In adults, we typically use 70 as a cutoff, but in children, it would be 100. So doing transcutaneous pacing, this is something we typically don't do commonly in children. In fact, trying to think the last time I did pacing, I've done overdrive pacing for tachycardias, but when you think about for symptomatic bradycardia, most of the time just oxygenation, ventilation, and then in rare circumstances, epi, and then even rarer is pacing. But you can put the pads forward and back. You activate the device. You want to shoot for around 100 if the patient is under 12 months. Set at 40, or you can just start dialing up on the milliamperes until there's capture. And once you get capture, you want to go a little bit above it, about 10 milliamps, to ensure ongoing capture. And if indeed the current is increased without capture, you can reposition the pacer pads to upper right and lower if indeed they're not touching. So symptomatic bradycardia, oxygenate, ventilate, then medicate with epinephrine, transcutaneous pacing, and then obviously consider the causes. And we'll get into the H's and T's in a bit. In terms of epinephrine, there are a number of apps that can be used to tell you how much to give in terms of medications. We developed one in Los Angeles County. It's a free drug dosing app based on age. Something to consider. We're in LA County. We're involved in a trial now looking at age-based dosing for children with seizures. It's called the Paediatric trial, but you can still utilize the drug dosing app, and it's free. And you want to avoid calculating in a crisis. Okay, it looks like an outline of LA County. All right, next case is a 10-month-old girl with irritability. Paramedics are called to the home. Patient is alert to Kipnick, normal skin color, no murmur, no liver edge, no scar. That's my quick, do they have congenital heart disease? So again, no murmur, no liver edge, no scar. And you can see it's very fast. Also, there's no history of fluid loss like vomiting, diarrhea, fever, just irritability. So really the key is determining, is this SVT with aberrancy or VTAC? Is this SVT or is this sinus tachycardia? And that's really part of the algorithm. In most instances, the large majority will be sinus tachycardia. And I've seen kids with sinus tachycardia in the range of 220. So think about that. Above 220 for infants, it's much more likely it's of cardiac origin. We often see, as we see in this rhythm strip, that it's almost 300 beats a minute in this middle rhythm strip. So with tachycardia, you want to know, is it probable sinus tach or is it something else, right? And you want to look at, is it narrow or wide? If it's narrow, it's probably SVT. If it's wide, it could be VTAC, it could be SVT with aberrancy, although you're going to treat it more like VTAC. And again, if it's monomorphic, I would consider adenosine. It can work in SVT, monomorphic VTAC, or it may be SVT with aberrancy. The other thing is some forms of VTAC do respond to adenosine. So again, this is something to consider. SVT we'll get into whether it's stable or unstable, and then sinus tach, obviously it's going to be fluid resuscitation and consider the cause. So how do we distinguish sinus tach from SVT? For SVT, its compatible history is either vague or nonspecific. Baby just became irritable. There was no history of fever or fluid loss, diarrhea, that type of thing. The P waves are absent or abnormal. The heart rate is not variable. It's very, very constant. With respirations, okay, children have a significant variation in the beat to beat interval just with respirations. So the fact that a heart rate isn't variable at all makes it more likely to be SVT. Abrupt onset for infants greater than 220, as I just told you about, and then children greater than 180. So the management, you can do vagal maneuvers, which is you can put the ice to the face. That is a vagal maneuver, and that may be safe. We don't do basically rubbing of the eyes because that can cause any pressure on the eyes can cause bradycardia. So we don't do that. We don't typically do carotid sinus massage in kids, so it's just ice to the face or go to adenosine. What I find is sometimes when you just put the IV in to do adenosine, the SVT breaks. So Generally, the American Heart recommends 0.1 milligrams per kilo. So 6 milligrams up to 12 milligrams is a typical dose for adults. So with kids, 0.1, you can go as high as 0.2 with a maximum of 12. And then finally, with extremis, you want to go straight to cardioversion. All right, that is SVT in a nutshell. Let's go to our next case. A 3-month-old boy found unresponsive by parents in the morning. Was alive in the evening when the parents put the baby boy to bed. Paramedics confirm cardiopulmonary arrest, and it looks like it is asystole, which is about 80% of all the arrests in children present as asystole. And the key thing is an organized approach with the resuscitators and EMS, somebody's starting chest compressions while the other is doing back mask ventilation, and same in the emergency department. So in terms of the scope, about 20,000 children, infants and children have cardiac arrest per year. Adults, it's about 360,000 cardiac arrests a year. Most are in the hospital, about 5,000 to 7,000 are out of the hospital. And you can see the survival rate is variable. So 5% in infants, 13% in children, 17% in adolescents. And the reason it's different is that the etiologies are different, because in adolescents, you may see that if they have either an abnormal coronary artery, it could be QT prolongation syndrome. So something to consider where they were normal and then had the arrest. In infants and children, typically it's a progression, either sepsis, respiratory failure, etc., to cardiac arrest. So something to think about. And this is why early chest compressions are going to be so important to support perfusion and perfusion of the brain and the coronary arteries during the time that the patient has cardiac arrest. How do you know when to start chest compressions? You can use similar to what we do for dispatch pre-arrival instructions. It's called no, no, go, and that is the patient conscious? No. Are they breathing normally? No. Then go, begin CPR. So no, no, go, something to consider, and you can communicate that via dispatch as well. So 5 main elements of high quality CPR: good chest compression, depth, and full recoil, a rate of 120 a minute. High compression fraction, meaning you're minimizing interruptions. Now with see-through CPR, you can see the underlying cardiac rhythm while you're doing chest compressions instead of stopping chest compressions to do a rhythm check. You want to go a full 2 minutes before checking at all, and then avoid excessive ventilation. Those are called the H-bombs, and we'll get to that in just a bit. Keys to survival are early chest compressions, high quality CPR, and good post-cardiac resuscitation care. So here's the algorithm. Obviously, there's going to be a shockable side and a non-shockable. Again, the non-shockable are far more common. Then you'll see PEA, and then which is non-shockable. And then the shockable will be ventricular fibrillation or VTAC without pulses. And really the key thing for shockable is to defibrillate. And you want to do that as quickly as possible, and we'll get into that in a second. And with the non-shockable, it's going to be good, chest compressions, obviously, and getting epinephrine on board. Ideally, the American Heart says within 5 minutes. I think the sooner the better. And you see for non-shockable at the bottom, the H's and T's to consider: hypovolemia, hypoxia, basically acidosis, which is more hydrogen ion, hypoglycemia is a rare cause, I wouldn't waste my time getting a glucose. I would start chest compressions, and then once you've done other things to establish goals of care, you can check a glucose. Toxins are rare as well, and some of the others, tension pneumothorax and a PE, right? Pulmonary embolism or a myocardial infarction, very rare in children, but again, with congenital heart disease, other things you want to consider it if they're at high risk. It should be considered. So when we look at what needs to be done for shockable BVM, chest compressions, defibrillation, epinephrine and amiodarone, and then non-shockable BVM chest compressions and epinephrine should be given every 3 to 5 minutes is a consideration here. The key thing is BVM chest compressions, defibrillation, and those are the top three for both shockable with defibrillation and non-shockable with epinephrine. All right, what about airway management issues? I couldn't help myself but bring this up, since this is an area of research interest for me. And really, we don't know, even in the in-hospital setting, what the best thing is. Early endotracheal intubation decreases survival, turns out, in in-hospital cardiac arrest as well as out-of-hospital cardiac arrest. So the key is doing good oxygenation and ventilation and avoiding early, especially hypoxic insults that can occur with endotracheal intubation. And then timing of advanced airway. So these are several studies, an observational study of data from US hospitals and Get With The Guidelines registry. And of the over 2,000 patients, 68% were intubated during the cardiac arrest. And you can see survival was lower in those intubated compared with those not intubated. Survival, looking at, okay. And so, one of the concerns, this is an older study, but one of the concerns, obviously, you may need to intubate them at some point. But at least in the initial phases, you really want to establish goals of care, good chest compressions, oxygenation, ventilation, defibrillation, or other maneuvers to address why the patient arrested in the first place. In the out-of-hospital setting, we still have only one large randomized trial looking at that. That was our trial in LA and Orange County now over 20 years ago, looking at 830 children who got BVM, or at least every other day was BVM versus BVM plus ET. And there's several other studies since my study. There's looked at really over almost 4,000 out-of-hospital cardiac arrest cases. This is retrospective analysis, and the odds to survival for hospital discharge for endotracheal intubation of BVM was highly significant, favoring BVM. I will say, if we did that kind of analysis in my trial, we'd show the same thing, because getting endotracheal intubation is not a successful endotracheal intubation is not independent of the prognosis, meaning you're more likely to successfully intubate somebody who's in full cardiac arrest. So I don't know, we need to really strongly consider this. This was Matt Hansen looking at this as from the CARES database. And I think it just is important to understand that there may be some bias there. I would also think about, especially if you don't intubate children a lot, to have at your disposal a supraglottic device, either an LMA or an iGel. And this is indications for iGel. And when we might consider it non-shockable, but you want to make sure you get that first epi in first, and for shockable, at least 2 defibrillations. Again, here's the path. going forward. And then what about weights? Well, gurney weights are great. You can use gurney weights if you don't have a gurney that takes weights reliably. Then you can use the Broslow tape, and it's not perfect, Broslow or any length-based resuscitation tape. Here's the H's and T's. These are potential causes, typically of non-shockable cardiac arrest, but hypoxia, hypovolemia being by far number one and number two, and then would consider these other things. Again, establish goals of care, and then for this, really strongly consider based on what the story is of the history, the pre-clinical history. So compression to ventilation, 30 to 2 if you're alone, 15 to 2 if you have a colleague who can do the bag mask ventilation, and 120 a minute. With advanced airway, you can do continuous breaths. Avoid excessive ventilation for the reasons it increases intrathoracic pressure, intracerebral pressure, causes issues, can cause coronary vasospasm and other things. So don't do this. Ventilate, just say squeeze, release, release, and then switching rescuers as needed. What about defibrillation? The dose is 2 joules followed by 4, followed by 4. You can consider going as high as 10 joules per kilo, or the adult max for whatever device that you are using, either monophasic or biphasic. Capnography, and I would say waveform capnography. This is, I'm demonstrating colorimetric device, but I would use waveform capnography here in the slide to look for, you can see times when there's ROSC very early on just through capnography, and it can be very useful to help with your ventilations, post-ROSC especially. And then, for instance, in children with cardiogenic shock, early expert consultation is recommended. Get your cardiologist involved. And for cardiogenic shock, it's reasonable to use these types of vasoactive infusions. So post-cardiac arrest syndrome is important. There's anoxic brain injury, myocardial dysfunction, there's ischemic tissues, and there's reperfusion injury that can occur. And then any precipitating pathology. So something to consider when you develop your approach. The key thing is good oxygenation, ventilation. You want to maintain at really normative values and not either have too low or too high. As an example, hypoxia, you'd like to maintain about 94 to 99. Hypotension, you don't want the patient to be hypotensive. Obviously, these are the H-bombs here. And so you want to shoot for above 70 for infants, and then 2 times the age plus 70 for kids older than 1 year of age. Hypo or hypercarbia, you'd like normal carbia, so 35 to 45 millimeters of mercury, and then normal glycemia. All right, in terms of oxygenation, maybe again 94 to 99, as I said, and avoid hyper or hypocapnia. Here's the target. And again, avoiding hyper or hypocarbia, so normocapnia. Hypotension, I mentioned you want to, for infants, you'd like to stay at 70 or above, neonates 60 or above, and then older children 2 times the age in years, avoiding hypotension. Any one episode of hypercarbia, hypocarbia, hypoxia, or hypotension decreases the likelihood for meaningful survival. So with hypotension, you're going to give fluids 20 mils per kilo. You would also consider after 1 or 2 boluses to add a pressor In the field, we use push-dose epinephrine. So you take 1 ml of cardiac epi to 9 mL of saline. And then, so that creates a 1 to 100,000 solution, or 10 micrograms per milliliter. And you'd give 0.1 per kilo up to 10 kilos, and then just 1 mil after that. We use 1 mil every 1 to 5 minutes in adults. And lastly, family presence. Data demonstrates that giving parents the option to be there is really the key thing. Some parents may not want to be in the room, and you can pull them back in as needed. But I do believe that offering them and then assigning a staff member to really talk with them, and so that they understand what's going on during the course of the resuscitation, and also to see that it may be time to stop. So we've talked about a lot of things. We talked about the no-go. We've talked about various dysrhythmias and what the treatment is. We've talked about good early chest compressions with oxygenation, ventilation through bag mask, and then really a consideration for when intratracheal intubation, or you could use a supraglottic device to support the airway oxygenation and ventilation going forward. And with that, thank you, and we will stop the recording. I'm going to stop share first. And
Good morning. Thank you, Prof. Mariana. It's a very excellent and very important topic. It is needed to be familiar how to deal with the patient resistant shock, how to manage. Next speaker will be Dr. Arian Jensen, who will be talking about very important imaging in the pediatric trauma patient. Welcome, Aaron. The mic with you. Thank you.
Well, hello, and thanks for having me today. I was asked to talk about pediatric trauma imaging, and really what this talk gets down to is weighing the risks and benefits of ionizing radiation in kids versus the possibility of a missed injury. My hope is to provide some framework for selecting the appropriate cross-sectional imaging for children and trying to minimize the use of ionizing radiation when it's not needed. I do not have any disclosures. By the end of this session, I would hope that all of us can describe the risk of induced malignancy from abdominal CT, and also to describe indications for advanced cross-sectional imaging in trauma patients. Let's start with a case. don't know about where you live, but where I live, these trampoline parks are quite popular amongst kids, especially for birthday parties. Um, as a parent of a toddler and an older child, I get great anxiety whenever I take my children to these parks. These have elevated trampolines, which actually sit about 6 to 8 feet above the ground. And kids jump all over and sustain all kinds of injuries at these parks, but they're a lot of fun. Our patient that we'll talk about today is a 3-year-old healthy girl who had an unwitnessed fall from about 20 feet off of the back of a rock and jump play structure. She somehow had got herself all the way up here, and there was a hole in the netting, and she went over the back of the apparatus, which here is about 8 to 10 feet, and add another 8 feet below that, and it's quite the fall. Now, her dad was concerned about her, so he jumped off, following her to try to make sure she was okay, and he actually landed on her. Neither the dad nor the child had loss of consciousness. The patient's brought to your trauma center is tachycardic with a heart rate of 138 and is crying. Otherwise, vital signs are otherwise normal, except a blood pressure that's a little bit high for this patient's age. There's some bruising and swelling to the head and face. There's head bogginess, and there's some tenderness over the scalp. Also, some abrasions seen at the right costal margin, but otherwise, the patient's examination is normal. So what should we do next? What do we expect to happen? We have a 3-year-old with a 20-foot fall whose father fell on her, and neither of them have loss of consciousness. We have some tachycardia, and we have some obvious head trauma. But the exam is otherwise normal, and the patient is neurologically intact. What should we do next? Should we get plain x-rays? Should we proceed to ultrasonography, CAT scan, or none of the above? This patient doesn't need any imaging. I'll have you think about that for a moment. How would you take care of this patient in your trauma bay? Well, this particular patient hit the jackpot, we would say, in the United States. And shortly after arrival, about 30 minutes after arrival, she was transferred to radiology for a whole body CT, otherwise known as a PAN scan. No chest x-ray was obtained, no C-spine x-ray was obtained, and labs were obtained, but results were not back yet. So this patient was transferred for whole body CT based on mechanism alone. And we ask ourselves, why might this be a good idea, and why not? Well, to answer that question, we have to think about mechanism of injury and what is high mechanism trauma. We know that patients that have high energy mechanism of injury are at higher risk of traumatic brain injury, spine injury, and torso injury, such as intra-abdominal solid organ injury. These are defined in children as 2 to 3 times body height of a fall, or motor vehicle collision with a death in the same compartment, ejection, or intrusion into the passenger compartment with the dimensions shown below. Also, children who are hit by a car while walking down the side of the street, or bicycle crash, ATV crash, also are considered to be high risk energy mechanisms. And the reason that this is important is because when you're involved in a mechanism like this, you have to think about occult injuries or asymptomatic injuries, and these children need to be screened. But just because they need to be screened doesn't necessarily mean they need to have a CT scan. I will point out that throughout the rest of my lecture, I will not be talking about child abuse patients. These are for patients with witnessed traumatic mechanisms. Remember that child abuse patients, you don't know what the real history is. The caregiver who brings the child to the emergency department does not want you to know what happened, so the history is unreliable. So for non-accidental trauma, the algorithms that I'm going to present next probably don't apply universally. So benefits of routine whole body CT are well known in the adult trauma population. I've put the photos of 2 adjacent adult trauma centers that are near my pediatric hospital, where we take care of kids only. And these 2 hospitals generally take care of adults. And if a patient is brought in with a high-risk mechanism of injury, there is a routine automatic whole-body CT scan. And there are 2 reasons for this. Number 1, faster time to diagnosis. And number 2, fewer missed injuries. In adults, there's a lot of radiographic artifact and baggage from chronic disease, particularly in skeletal disease, and it can be hard in order to see if something is a real injury or not a real injury, and injuries can be missed when you rely on plain films alone. In children, however, the anatomy is pristine on plain x-rays, and also there are downstream effects of the radiation. So we do sacrifice time to diagnosis a little bit in order to avoid ionizing radiation in kids. If it's possible to take a little bit more time and perhaps avoid CAT scan, that is beneficial. And the reason is because there are downsides to ionizing radiation with whole body CT. We have to talk about deterministic effects, which are pretty rare, which is an induced malignancy at the time of ionizing radiation. But more commonly, we see the stochastic effects, which are downstream induced malignancies, which can occur many, many years after the initial radiation event. And it's these cancers that we worry about because children who are very young, particularly this 3-year-old that I'm talking about, they have 80 years to develop that cancer downstream. And this is from injury to mismatch repair genes and other cellular and molecular mechanisms that can lead to malignancies downstream. And if we look at one great example of this, it's a study that was done in South Korea on patients with appendicitis. South Korea has a single healthcare system, so they know who had CAT scan and who didn't have CAT scan to diagnose their appendicitis. They had 825,000 patients who had appendectomy, and 300,000 of those patients had a CT scan, and the other 500,000 did not, presumably having the diagnosis of appendicitis with ultrasound or clinical diagnosis alone. These patients are in their mid-20s, but they looked at a general adult or older adolescent population of young, healthy people, and they looked at downstream induced malignancies, primarily hematologic malignancies such as leukemia that might occur within 2 years of exposure, and secondary outcomes such as abdominal pelvic sarcomas that occur within 5 years of exposure to the CT scan. And what they found was a 1.26-fold increase in hematologic malignancy, specifically leukemia, in the CT exposed group, and also a 1.07-fold increase in intra-abdominal solid malignancy. So 26% and 7% increase in these cancers. And these are directly attributable to the CT. There's no other differences in these populations. Now, if you do the math and you look at the number of CT scans, this turns out to be about 1 in 1,000 CT scans will have an induced malignancy. So the CT caused the secondary malignancy. Now, that doesn't seem like a lot, but I'll probably order 10,000 CT scans in my career. And that's 10 kids that I'm going to have to tell their parents that they got a cancer from that CT. If I can decrease that to 5,000 abdominal CTs over the course of my career, that's 5 kids that won't get an induced malignancy. And I think when you think about things in terms of other people's children and potentially saving that family the strife of having to deal with chemotherapy and other treatment for malignancies, it really drives home the importance of us thinking twice about ordering CT scans that may or may not be necessary. Certainly, if the scan is needed, we should do it. The risk is low. But if the scan's not necessary, we should think twice about ordering it. I live in Northern California. There are 5 pediatric trauma centers here. We did a 5-center review of whole body CT of all of the kids that were transferred into our center after undergoing a PAN scan at an initial treating center. We had over 400 children that were aged 2 months to 18 years of age, and the median ISS was 9, so moderately injured population of children. We found that of all of these kids that were transferred in, 83% of the whole body CT were unindicated. Only 17% of the whole body CT scans were necessary. 17%. That's a very low number. And this also doesn't include patients who had a whole body CT scan at other hospitals and didn't have injuries and were sent home. So we're probably underestimating the overuse of whole body CT. We found 75 children in this cohort that had a whole body CT scan that did not have an indication for any single body region CT, which was 18% of the cohort. So whole body CT is overutilized in California in the United States. I'm sure it is where you live as well. We look at the red boxes, and those are the body regions that were overscanned. And mostly it is the neck and the chest. Abdomen, pelvis, and head have a fair number of unnecessary scans, but not quite as frequent as the chest CT. And if there's one scan that we probably don't ever need, it's the CAT scan of the chest, except in very rare circumstances. And we'll talk about that in a little bit. So who should get a whole body CT scan? So we adapted the definition from the ACS TQIP Best Practice Guidelines in Imaging, which does have a section on pediatric imaging in each of their body regions. And they say that the whole body CT is generally used for polytrauma patients with severe neurotrauma that impairs the ability to obtain a reliable physical examination. It should not be used to screen asymptomatic children with high risk energy alone. This should be used for the kid with an impaired GCS, where you don't have a reliable exam and you need a fast time to diagnosis because these patients have a high likelihood of needing to go to the operating room for craniotomy. It's a really small and narrow population that we should be using whole body CT for. So what about specific body region CTs? We have created one-page visual diagrams that you can follow to identify patients that can be screened with clinical criteria and a CT scan not obtained versus patients that have definitive indications to have CT. And this was done for multiple body regions, including head, C-spine, chest, and abdomen. These are available online. I've put a QR code if you'd like to access the EMSC Innovation and Improvement Center, where all of these algorithms have been posted free of charge. I'll start first with the head CT. So these are the PCARN head injury rules, very well accepted within the United States. These have been validated on over tens of thousands of patients over many years. There are two algorithms, one less than 2 and one greater than 2, which really means verbal or not verbal. And they stratify patients into high risk, intermediate risk, and low risk. In this first box, a patient who presents with a GCS less than 15, signs of a basilar skull fracture, or altered mental status after minor head trauma or major head trauma should definitely get a CT scan. High risk, 4.3%. However, if you don't have any of these high-risk criteria, you do not need a CT scan necessarily. We look at secondary criteria, which we call box 2, and all of these factors, scalp hematoma, loss of consciousness greater than 5 seconds, mom says the patient is not acting normal, or a severe mechanism of injury, these confer a risk of approximately 1% of a clinically significant TBI. Now, if you don't have any high risk or low risk criteria, you do not need a head CT because your risk is less than 0.02%. However, if you have box 2 criteria, particularly if you have more than one, as these are additive, the more of these factors you have, your risk goes up. But if you're in box 2, you certainly can get a CT scan or be observed for 4 hours in the emergency department. And if you don't have neurologic decline, you can safely be sent home with return precautions. Quick note, you should not be giving Zofran during the observation period because that will mask one of the symptoms, vomiting, which would trigger a CT scan if a patient has persistent headache, vomiting, or decline in mental status. Next, we come to C-spine imaging. This algorithm is new. It was published last, I believe, in March of 2024. And this is the PCARN cervical spine injury screening guidelines. This is really most useful if you're able to screen kids out and not get any imaging, which is the green box at the bottom. Again, this is stratified by risk factors. 12% chance of injury if you have any of the high risk factors, which is a GCS of 8 or less, abnormal airway breathing or circulation, or focal neurologic deficits on examination. The intermediate risk box is 2.8% chance of injury, and this is altered mental status, but a GCS greater than 8. And the reason for that is it's thought that that GCS should clear with time. Self-reported neck pain or tenderness on examination, and substantial head or torso injury. If you don't have any of these high or intermediate risk factors, you go down to the low risk factor, which is less than 0.2% chance of injury, and you can clinically clear that patient with physical examination, assessing for range of motion and point tenderness along the cervical spine. Now, I'll point out that all of these high risk factor patients probably need a CT arteriogram of their neck, and more data is forthcoming on indications for CTA. But in my center, if your GCS is 8 and you've had significant mechanism of injury, you're getting a CTA of your neck. Also, if you have focal neurologic deficits on exam, you're getting a CTA of your neck. I'll also point out that a normal CT scan in a child in the presence of neck pain or an unreliable neurologic exam is not enough to take a collar off. So getting a CT scan in these patients does not obviate the need to either get an MRI or keep the collar on and wait for their exam to improve. We should not be getting CT scan just for neck pain alone in the absence of other high-risk factors. And in my center, we send a number of patients home that have normal plain films. We send them home in a collar and bring them back a week or two later in clinic, and their neck pain is usually gone and they can be clinically cleared. So you can skip the MRI, and the CT doesn't really add much in these cases. Next, I'll move on to chest CT, and I'm going to start again with an illustrative case. 15-year-old backseat passenger head on MVC at a very high rate of speed. He was in this white car, hit by this black car that went into the side of this black car. And it was not clear if the patient was restrained, but there was a fatality at the scene. There were 4 other critical adults, and this patient was transported directly to the Pediatric Trauma Center, hypotensive with a GCS of 11. On arrival, the GCS was 13. The patient was quite combative and now hypertensive. His breath sounds on the left were diminished and he had a tender abdomen. He was intubated in the trauma bay and had a chest x-ray, which you'll notice here has a widened superior mediastinum. The FAST exam had free fluid in the right upper quadrant and in his pelvis. He remained hemodynamically normal. And at this point, we elected to proceed with a whole body CT. But this patient also, if it was examinable, this patient would have met criteria for a CTA of the chest based on the widened mediastinum. This chest CT showed a hemothorax as well as a disruption in the thoracic aorta, better seen on the sagittal view, consistent with a blunt aortic injury with a contained pseudoaneurysm. This patient was treated with a thoracic endovascular stent graft and did well. But what that brings us to is the algorithm. A chest CT is almost never necessary in children after injury because the regular chest x-ray is so pristine. Unless you have an abnormal mediastinum on your chest x-ray, you probably don't need a chest CT. A chest CT will uncover more injuries in the chest than a regular radiograph, but those those injuries generally do not require any additional treatment. You may find an occult pneumothorax, you may find some small contusions, you may find some small amount of fluid in the chest, but all of these injuries, again, generally do not require any treatment. And in kids, the anatomy on the chest x-ray is so pristine that you will almost always, at least that's what the data says, almost always pick up a mediastinal vascular injury based on screening chest x-ray alone. If the x-ray has a normal mediastinum, a CTA is not necessary. Now, I'll also point out that little kids who present with a wide mediastinum but don't have any mechanism of injury for a blunt mediastinal injury don't need a CTA either. 2-year-olds have a large thymus, and they oftentimes are uninterpretable. But if you don't have a deceleration injury from a motor vehicle collision, a kid fell off the slide or fell at the playground, but they have a wide mediastinum, just use some common sense about whether or not you need to get a CTA of that chest because they don't have enough energy in their mechanism in order to do that. Next, we'll talk about abdominal and CT imaging. There are 2 different algorithms that have been validated. Both of them are very high performing, and we found that they're actually quite complementary of each other. The first is the PCARN algorithm. The second is the Pediatric Surgery Research Consortium algorithm. But all of these say you should not get an abdominal CT scan for mechanism alone in the absence of symptoms or other signs. High risk factors such as abdominal tenderness, abdominal wall bruising, a seatbelt sign, a GCS less than 13, hemodynamic instability, or concern for child abuse should prompt an abdominal CT scan after high mechanism trauma. However, most of these patients are going to need to be transferred to a pediatric trauma center anyway, just based on the symptoms that you're getting the scan for. So I would not delay the transfer to a pediatric trauma center in order to get imaging. You should initiate the transfer process, and if there's going to be delay due to the unavailability of transport assets, then potentially you can get the CT while waiting with shared decision-making with the pediatric trauma center, particularly around the use of contrast and contrast timing and how the CT should be done. Now, if you don't have any of these high-risk factors, we have to think about other screening mechanisms because it's high mechanism trauma. Is there evidence of thoracic wall trauma? Is there any complaints of subjective abdominal pain? Not tenderness, because tenderness is the high-risk box. Subjective abdominal pain without tenderness. Breath sounds that are diminished, or any history of vomiting after the imaging, which maybe is related to abdominal trauma, but it also could be related to the concussion. These are very sensitive predictors, and if you don't have any of these predictors in box 1 or box 2, you probably don't need a CT scan of the abdomen. However, these box 2 factors are quite sensitive and potentially overly sensitive and are likely to lead to too many CT scans if any of them alone trigger the CT. So if you have a positive box 2, we would suggest looking at an AST, ALT, amylase lipase, hematocrit, and a chest x-ray. And if any of those are abnormal, then consider getting an IV contrast-enhanced CT scan in order to facilitate potential discharge from the emergency department if that scan is normal. I will point out that FAST exam in hemodynamically stable patients should not be used to rule out intra-abdominal injury. If you don't have another reason to scan the patient, free fluid alone on a FAST exam is going to likely lead to additional unnecessary CT scans. I often get asked about the cutoff of an AST or ALT of 200 and whether or not this is too high or too low. Our group went back and looked at this, and we found that the degree and elevation of AST and ALT has a linear relationship with the grade of injury. And we found that if you use very low cutoffs, you'll pick up all the injuries, but you'll also get a lot of unnecessary CT scans. If you use cutoffs of 250 and 200, you will catch all of the grade 2s. And even if you push your limits of AST and ALT up a little bit higher to 400 and 200, you'll have a 96% sensitivity for identifying grade 3 and above injuries. So really, we do use this higher threshold of 200 or even 250 in order to screen for blunt abdominal trauma, because a grade 1 liver laceration or a grade 1 spleen laceration, those don't really matter because they can usually be sent home from the ED. They never bleed. And if they don't have significant pain or tenderness, then if you don't diagnose them, it's okay because there's no long-term consequence. I often get asked about a role for trending AST and ALT. The trend is always going to be down after imaging, so you should not trend them. It's a screening test. Now, if you think that the AST and ALT are high because of medical causes or some thrombotic event, then yes, you should trend them. But really, if you're using it just for screening, you should expect the AST and the ALT to go down after injury because that is the natural history of this disease. Finally, a word about FAST exam. What is the role for FAST in hemodynamically normal patients? This is a study done here in California. 460 patients randomized to FAST or no FAST. And the treating physicians were asked before they had access to the FAST results if they were going to get a CT or not get a CT. And then they gave them the FAST results and they asked about whether or not that changed their decision. 19 of the patients in this study had an intra-abdominal injury. 5 of them had a positive FAST. 14 of them didn't. So FAST did not pick up clinically significant injuries in many cases. 10 patients who had intra-abdominal injury had a negative FAST exam, and 4 of them were indeterminate. But more importantly, 25 patients had changes to their CT scan after the FAST exam. 13 patients, the provider decided not to get a CT scan, so the negative FAST changed their mind. But 12 patients changed their mind. Before they got the FAST exam, they were not going to get a scan. But after they saw the FAST exam, 12 of them decided to get them. And one injury was noted in this group, which was a jejunal perforation, which it's hard for me to fathom why that patient did not have abdominal tenderness if that were the case. So really what this study concludes is that if you're using FAST exam to decide whether or not to get a CT, it's probably going to lead to unnecessary increase in CT ordering and not catching any additional clinically significant injuries. In the 465 patients who were randomized to standard care without FAST, there were no missed intra-abdominal injuries. So finally, back to our case. Our 3-year-old who fell 10 feet off of the rock and jump structure fell 2 to 3 times body height. So this does meet criteria for high risk mechanism of injury and does need screening for brain, spine, chest, abdomen, and pelvis injuries. She's alert, she's examinable, her GCS is normal. She does not need a whole body CT scan. She's clinically stable and we have time to sort this out. And we can start to look at individual body regions and decide what body region we need to CT. If we think about the head, she has a non-frontal hematoma and a high-risk mechanism. She has approximately a 1%, maybe a little bit higher because she has 2 factors in the intermediate risk criteria. And this is a patient who can safely be observed in the emergency department for 4 hours or can undergo a head CT. I generally recommend head CT for patients who have 2 factors in the intermediate criteria box, but many providers recommend for 3. Certainly for 1 factor in that intermediate risk, I probably would not. But in the presence of a high-risk mechanism and a non-frontal hematoma, I generally would recommend getting a head CT. Her C-spine was low risk by PCARN criteria. She had no pain, no tenderness, no altered mental status, no alterations in her breathing or circulation, and her neck can safely be cleared clinically. She does need a chest x-ray because this is quite a big fall. She's unlikely to have a wide mediastinum, but she may have pulmonary contusion or pneumothorax or other spine injuries. So a plain film of her chest would be indicated with a 20-foot fall. And finally, she needs an abdominal examination and labs. A fast is not indicated with normal hemodynamics, and it should not prompt a CT scan, even if fluid is found but no other symptoms. If her labs and her physical examination are normal, she can be observed for 4 to 6 hours, given a PO challenge, and can be discharged home with return precautions for worsening abdominal pain. So this particular patient who got a whole body CT scan based on mechanism alone, at most, should have had a head CT, and that even is debatable. She could have been observed and potentially not had any CT scans whatsoever. So in summary, we need to weigh the risks of induced malignancy versus the risk of missed injuries. We don't want to delay transfer out to another hospital in order to obtain CT scans. We should be using CT when indicated, or clinical prediction rules to facilitate a safe discharge from community emergency departments. Whole body CT does have a role in pediatric trauma, but really only in those patients who have neurologic injury and an unreliable physical examination and a high risk of needing to go to the operating room urgently for craniotomy. Head CT rules are ubiquitous in the United States. Hopefully this takes on internationally as well. They are very well validated and have been studied over and over again, and the PCAR and head injuries work. C-spine rules are new. The data is strong. I think it's 17,000 patients that they were studied in. I do suspect these will evolve over time as people use them and implement them. Almost nobody needs a chest CT unless the mediastinum is abnormal. And finally, abdominal CT should not be performed for mechanism alone. It should be used for abdominal tenderness, abnormal labs, or worsening pain over the observation course in the emergency department. I'd like to thank you all for the opportunity to present here today. I believe there will be a Q&A session in a little bit. Thank you.
Thank you, Dr. Adam. And will be any question for the first two doctors, you can post this one in question and answer box, and will be promised to be try to find the answer and post this one in the same box. We'll go for a break for 30 minutes. We'll back to the second session, inshallah, around 9:30. Thank you.
Greetings. My name is Dr. Richard Cantor. I'm a PEM attending and a toxicologist from Syracuse, New York. And I want to thank you for taking the time to watch this presentation. The title of this is a PEDS-EM Lit Review. It's a whirlwind sort of tour of great articles that have come out. As a point of explanation, for ASAP, the American College, every year I do a lit review presentation that's about 45 minutes to an hour long with the past year's great articles. Now, I haven't spoken to you folks in a long time. I visited your country years ago at the first meeting of PEM for the Saudi group. So what I decided to do is put together the last couple of years good articles that are helpful, specifically in terms of the fact that we have 30 minutes only, and I can go on and on. So what I'm going to show you are what I think are some of the better articles. Now, why am I doing this stuff? Now, I've been doing PEDS-EM and EM for a long, long time. If you Google EM docs, and this is a real deal, live Googling, we are, according to the world, the general population, we are stupid, we are idiots, we are dumb, we are rude, and we are called triage officers. We don't get a lot of respect in emergency medicine, and that in and of itself is a lecture I love to give on how to get respect. But what I'm alluding to here is the fact that there is a secret weapon we have against the people who don't understand what we do. And I'll defend us to the death. Our secret weapon is knowledge. If we're the smartest person in the room, we win. It's quite simple. If we know the most about our patients, we win. If we do the best for our patients, we win. But knowledge in a vacuum means nothing. But if you apply that knowledge, it's true power. So enough preaching. Why did I choose these articles? Number one, sometimes there's new stuff that you need to know. That's good news. Mostly, they're going to confirm and validate what you're doing already clinically, which I like to do. And then some of them are just so stupid that I like the titles, and I'll show you a few of those. So let's get started. Hands down, one of the most influential articles came out about managing fever in young infants 8 days to 60 days. And now I used to have about 15 slides going over this article. It was a huge study and a huge algorithm was developed, and here are the algorithms. Okay, the first focus here, the algorithms. These are kids 8 to 21 days, quite young. What do? Basically, you hospitalize them. There's not much to talk about here. You initiate parenteral antibiotics, you observe, and that's it. You treat for HSV and other bacterial diseases. Inflammatory markers are not big here, and they aren't a deciding point, so let's just move on. Infants 22 to 28 days, and they subdivided this group out, and I don't know why. I mean, I do know why. There was some data, but not in my mind. I think they should be grouped as 28 days and under. What jumps in here, besides an automatic septic workup, and when I say septic workup, I mean spinal tap, blood, and urine cultures, is the concept of inflammatory markers, or IMs. And basically, they're telling you if there's abnormal IMs, you should do an LP. And I reject that. I think you should do it on anybody under 30 days. I'm allowed to differ from the studies based on experience. But IMs are jumping in here. Use it at your risk. I think you're crazy under 30. When you get, and here's the bigger algorithm for that group. It's an IM-driven LP. If the tap is negative, you can send them home on antibiotics. I still think it's a risky group, and I think hospitals are built for a reason, and that's observation. Okay. You guys can take a look at that. Then the mixed group where the kids get developmental milestones, you can see if they're sick, the immune systems come to life, and immunization may have happened. These are kids 29 to 60 days. Again, inflammatory marker-driven workups for the LP. If everything is normal, you can send them home on oral antibiotics. I'm not going to dive deeply into this group. I think the first tipping point is they're not sick looking, God bless. Second, are they not meningitic looking? Don't tap them. Number three, you're dealing with bacteremia versus UTIs, and you have other labs and markers you can do. And that's pretty much it. Now, I just totally summarized an article that I could do 20 minutes on, but you need to pull that and read it. So let's move over to a subset of fever called simple febrile seizures. And back in 2011, I'll show you what our research does, and I'm going to give a shout out to my specialty. PZM is the ultimate research group. We work in an uncontrolled environment. We don't screen what we see, we take what we see. So in essence, everybody that comes in, every patient is the beginning of a randomized, double-blinded, non-controlled study. And if you look at research development, everything in the world starts with a case report, then case reports, and then case collections. And then somebody says, we can study the finer points of this new illness or the cases that come in, and we'll do collaborative studies and longitudinal studies. And then there are more studies, and then they become Cochrane reviews, and then they're done. We've done this, and I pride myself and my people I work with. We are investigators. We are observers. We have the front seat into the clinical chaos that is our lives. So I want you to keep that in mind. Hold on a second here. I'm just looking at the time. So with febrile seizures, there was a time where we used to do tremendous workups on these kids. But this article came out and said, direct your attention toward the cause of the child's fever. Meningitis should be considered in the differential, specifically when there is no immunization record for H. flu and pneumococcus. And I'm not going to get into the politics of not immunizing your kids. I think that's craziness. But that's when you consider it. And so the conclusion here is get an LP if they're pre-treated with antibiotics, but don't do imaging. Don't do anything more than that. It's not indicated. Just work the fever up. So if you look at the money you can spend on these kids, everybody says just say no. So that's 2011. So let's put this into practice. And I'm so happy about this. 2021, trends in managing these kids. So we just resurveyed all these EDs that were doing too much to see if they've amended their protocols. And take a look at this. This is the study period from 2005 to 2019. CBCs way down. Chemistry's way down. Urinalyses way down. I mean, it's very impressive. LP's almost gone. I'm very happy about that. And then CTs out the door. And last but not least, admissions. So this is when research gets translated into action. And to me, that's the best form of medicine you can have. And we will retest this in 10, 20 years and see everything should be the same situation. So we did a good thing here. Okay, moving on. Let's talk about UTIs. Now, every once in a while, like I said, a Cochrane review comes out, and this was in Peds Journal about managing UTIs in kids, and it's pretty much a gold standard. It's definitely worth your time to read it, but let me summarize it for you. I can't overemphasize the importance of looking, finding, and treating UTIs in babies, right? So let's look at differentiating UTIs from upper and lower tract diseases. Now, the first thing I want you to realize is that in infancy, a UTI, a positive urine culture, is not cystitis. 75% of those positive urine cultures indicate pyelonephritis, which is why we worry about damage as well as bacteremia from it. Back in the 80s, they did studies with labeled white cells with UTIs where they wanted to see if the kidneys were involved, and they were. So there's a lot at stake here. So how do you distinguish between cystitis or an acute pyelonephritis? And it's kind of easy. Pyelos have higher fevers. Pyelos have flank pain, but 2-month-old can't tell you that. But they basically have systemic degeneration. In cystitis, E. coli is the most common bug in both of them. Urinary findings, the hematuria doesn't happen, but urine culture works, okay? You'll get a nice diagnosis. So let's look at the UA, and this is all a review. So they've put together a lot of articles on this, and they found the following. The leukocyte esterase test is the most widely used screening test, and it's not reliable in a lot of these babies. Now, a word of caution. Getting a urine, we'll talk about getting a urine in a minute. These babies, certainly under 6 months, but under a year, they don't concentrate their urine very well, so you're going to have to look far and wide to find bugs on the gram stain or any sort of chemical abnormalities like nitrites and leukocyte esterase. So leukocyte esterase, not so good. Microscopic urinalysis has only marginally better than a dipstick. If you want to increase your return, make sure they centrifuge it. If you take a look at the scan here, look at the crappy sensitivity and specificities of leukocyte esterase nitrites, and if you combine them, they get better. We've been circling the wagons on this for a very long time, but the rules of thumb never change. You get a urine culture, you do not treat presumptively, and you do a microscopic urinalysis with or with dipsticks, of course, and hopefully you'll see some white cells or certainly bacteria on the UA. Now, I know in the adult literature, nobody does any of this, but these are kids. Urine specimens. They should be collected either by a cath or suprapubic aspiration. If you get a dipstick a bag urine is positive. The only indication for a bag urine on a kid is to induce anuria. They will never pee. Trust me on that. So what are we doing to kids? Now, I'm old enough, and I feel very guilty about this, for doing suprapubics routinely on babies. We used to do them. And they're sort of invasive, and I feel very badly that I put these kids through that. But we cath babies. We all know this. This is how we roll. Now, caths are no fun. They're no fun. So what do? Another reasonable alternative to cathing is what's called the quick wee method of urine collection, developed by our Canadian neighbors up north. I just don't understand why they came up with quick wee, but let me show it to you. It's a two-person operation, three people actually. One person holds the urine cup. One set of hands frogs the kid's legs and taps and crudates the bladder, while the other hand is rubbing L234, massaging it. And this kit, in their study, gave them a urine under 6 months and 70% of the time. The child starts voiding, and you can get a midstream collection from that. How nice is that? Now, with that being said, and try that. You've got nothing to lose. It's non-invasive, and boy, it feels good to not cat someone. What about the degree of white cells in the urine? Is it ever indicated or not indicated about a UTI? This really freaked me out when I read it. UTI with different organisms give you different degrees of pyuria. Enterococcus, Klebsiella, and Pseudomonas, they just don't send white cells down there. That's just not fair. And these are odd bugs, but actually Klebsiella is not that odd. So again, you really need to wait for the culture. What about biomarkers? Now, I mean, I've lived my life long enough to know that biomarkers are both a blessing and a curse. We're talking about, how much they're helpful. Now, in my mind, there's only two evidentiary things with biomarkers. One, the only happy biomarker is a normal one, and we'll get to that. And the other is, that's why the studies are so weird. They have to combine abnormalities in biomarkers, SED rate, CRP, procalcitonin, and there's 40 others, to get sensitivities and specificities. But evidence suggests maybe that if the CRP or procalc is up, it's suggestive of a pyelo and not a cystitis. The SED rate does nothing, so don't bother with that. But you're going to get it, but don't depend on it. Okay. What about antibiotic choices for a well-appearing child with a UTI? In children who are not febrile, it's more reasonable to use a first-gen cephalosporin. My favorite is cefalexin, or trimethoprim sulfa, or nitrofurantoin. Basic, these drugs, and they're harmless, basically, okay? Most uropathogens, unfortunately, are resistant to aminopenicillin, so Amox is out the door. Forget it, and don't use Augmentin. At the time of this writing of this article, most and all of the uropathogens are sensitive to third-generation cephalosporins. So you've got that sitting on the table at your disposal. Now, that's UTIs in summary. Let me say it the right way. The standard of care has never changed. Get a reliable specimen, wait for the results, and treat accordingly. And follow-up is the key. Okay. Now, there were a bunch of articles last year, it comes in waves, about septic joints and septic bones and SED rates and who knows. But somebody did a nice study on osteomyelitis. Is there a risk score we can depend on? And again, like I just mentioned earlier, when they start doing biomarkers, they start combining them to get odds ratios to find the illness. So take a look at the method here. This was a retrospective. Right away, it's not the perfect study. Case control kids older than 3 months, younger than 18. That's a bit of a group. 23 PZDs. Big study. The results of this was there were 1,135 cases of hematogenous osteo matched to controls. They did a logistic regression analysis, and they found 10 clin lab features that independently predicted acute hematogenous osteomyelitis. Okay. They derived a 4-point risk score using sick for more than 3 days, fever over 38, C-reactive protein, and SED rates. Like I said, it's conglomerative risk-taking. And here's their big chart. And there you can see the duration of the fever had a p-value that was quite nice. And the highest temp has a good p-value. And then the markers as listed. Okay, so we're looking and we see it. Now, let's get to the point here. You can put a score together for a septic joint. The Kocher or Coker criteria do that. And why does that matter? It matters for the consult. You can't manage an osteo nor a septic joint alone. You need ortho. And ortho's diagnostic interventions, when you call them, are invasive. Tapping a hip, for example, or getting an MRI for a bone infection. You need them to sign off on that, and they depend on these scores, okay? So keep that in mind. That's why I put this in here. If you pursue a definitive diagnosis, you maximize the accuracy, and if you don't have any of those factors, you don't have osteo, and that's totally not helpful because you wouldn't even be working them up. But that's, in a nutshell, the conclusion here is get the markers. If everything's off the trid, then pay attention to it and work accordingly. Okay, this came out of nowhere, but I love it. It's about lumbar puncture in babies, rethinking what we do to these kids. Now, pop quiz, who is the most important person with regard to success of a spinal tap? And the answer is the holder. We know this. The holder is everything. With bad holder, you might as well go get something to eat because you'll mess it up. So then God made sonography. Now, in my day, we had a holder that was so dedicated to it that the decubitus position, she'd fold the baby up where the foot actually went into the carina. It was crazy. But I always got the tap. But somebody took another look because we now had sonography. And, sonography is heaven and hell. I mean, don't forget your physical, but they started doing sonos on the backs of the kids during taps in different positions, either sitting upright or decubitally, to see where do you get the best access. Okay? With that introduction, there's a bunch of studies, but this is a Cochrane review here. They included 5 studies, about 1,500 participants, and they had a battle. Should they lie on their side or sit? And it turns out that the decubitus position increases hypoxemia and bradycardia, and it doesn't help with the tap. In other words, sit them up. And this was one of the first studies. Take a look at the drawings. And basically, I'll show you the arrows. In the upright posture, you only need to flex the hips. Don't flex the neck, just the hips. More importantly, if you're going decubitally, do not flex the neck. It does nothing to the interspace. These are direct measurements with sonography. So sit them up, lay them down, don't flex the neck. And then the last thing is, a shocker to me, decubital access is not as good as sitting. There's bigger spaces and more fluid to go for. So what's the take home here? Sit them up. Enjoy what they said. And you can just go with that. I can't overemphasize how much this changed things for me. Stop laying them down and sat them up. Okay, moving to respiratory stuff. There's tons of stuff out there, but I wanted to talk a quick and dirty study they did comparing different types of steroids with reactive airway disease. And this was a battle between a single dose dexamethasone versus 2 doses. And it's important because compliance matters. This prospective, thank goodness, randomized, I love it, single center, unblinded trial in kids 2 to 20-year-olds with mild asthma exacerbations. They got either 1 or 2 doses of Dex, 0.6 per kg with a max of 16 mgs. Just for the record, 16 milligrams is an extraordinary amount of dexamethasone, but good luck with that. Primary outcomes were, did they bounce back and did they stay sick? And the secondary outcome were persistence of symptoms, missed school days, and adverse effects. The results are listed. 308 patients in the study. There was no difference between the groups regarding returns, symptom resolution, staying out of school, or vomiting. And basically, this is a big deal. And the conclusions is there's no difference. So 1 single dose in the ED will do it. By far, the most important thing you can do for these wheezers is get them back into their primary care physician for continual management at home with inhaled steroids or other modulators of reactive airway disease. But this was kind of encouraging. We used to put kids on 2 to 4 days of prednisone, which worked, but that's a compliance issue as well. All right, let's keep moving. What about anaphylaxis? Now, some of the smartest people in medicine, in my experience, are the allergists, because they know everything about immunity. And peds allergists are just great people. I love going to their lectures. I learn something all the time. Most of our allergic exposures in the PED are twofold. They're cutaneous with eczema, or number two, anaphylaxis. And here's the clinical question. Are we doing any good with anaphylaxis? Well, the first thing is they've been surveying this in their literature, and this is from anaphylaxis article, and it's going way up. Anaphylactic or anaphylactoid presentations are increasing. We live in an allergenic world, and you can take a look at this fairly recent study. The methods here was retrospective under two in a 4-year period from 2003 to 7, and then again 13 to 17. They got standard information on triggers and things that went. They increased 3.6 to 6.2 per 104 population with the greatest incidence in babies. This freaked me out. Anaphylaxis severity increased, failure to administer an EpiPen was reduced, and I'll get to that in a minute, and food was the leading anaphylactic trigger, which is developmental. It's worsening with time. And basically, this article was why I brought this up here, talks about the variation of what people do for anaphylaxis. And we suck. I'm sorry for the word. We need standardized protocols for this, because the simple matter is they looked at guidelines, and there are nationally published guidelines for people that meet the criteria for anaphylaxis, and every single one of them starts, stops, and begins and ends with an EpiPen. And we, for some reason in PEM, are like, we skip it. We just go to a steroid and an antihistamine. And I'm preaching to the choir here, but don't be afraid to give an EpiPen. Read these articles. You'll see where the evidence lies. The underuse of the EpiPen is a fact, and we need to use it more. Okay? Done preaching to you. Okay. I want to give you my first case report. I've just found a case. I didn't do an article on this, but this is how it always begins. I found an underreported form of intussusception, and most of this illness occurs in most of my consults who are a pain in the butt. And if you take a look at it, this is called craniocolonic intussusception. In other words, head up your butt. And that's my consults. That's my bad joke. Okay, let's talk about sedation. We own it in PEM. We own it. We made it. We recognize kids have pain. We recognize they should have pain. We recognize there are meds that take away pain. We recognize that meds that take away pain are safe, actually safer in kids than adults, and it's criminal not to use them. And it's amazing the development of anesthesia and pain management in our specialty, and it's one of my most proud and prideful moments because we own it. So this is a survey article in Peds Emergency Care done by my good friend Sharon Mace, who is terrific, about 15 years experience with sedation for these kids. Okay, we're getting there. It's recorded over 15 years. They looked at everything. What drugs were used, what doses, who got sick, what were the side effects or the absence with regressive analysis. The results are listed. There were about 3,300 consecutive procedural sedations. Mean age was 8.7, black, white, boys. You can do what you want with that, okay? 870 were certain categories, ASA 1, 2, and 3. Take a look at the numbers there. The results are as follows. The indications that they used them for: fracture reduction, dislocation, suturing, LPs, incision draining, foreign body removal, the bread and butter of pediatric emergency medicine. The sedatives they used, and look at this, we use them all: ketamine, propofol, benzodiazepines, etomidate, which is strange, and barbiturates, which should not be happening. But we used a lot of drugs. Okay, sounds good. 47% received an IV opioid, which totally makes sense for pain management. Okay, success rate was 100%. Side effects included, nobody ever died from half of this: nausea, vomiting, itching, rash, an emergency reaction with ketamine, some myoclonus, 2 cases, paradoxical reaction, unusual, hiccups, you'll live, and a cough, which was pretty good. And the success rate, sorry about that, was very high. So the conclusion is the adverse events in kids and children in a general ED are low and comparable to a PEDS ED at a children's hospital. In other words, everybody can do this. Just keep your charting up and your monitoring up, and the world is at your fingertips. And you can do it safely by non-PEDS EM people, general EM people. Enough said, enough preaching. Use the meds, get familiar with the meds, learn the side effects, chart it carefully, monitor the kids, and you have done a good thing for the children you take care of. Okay, so this came up and I wanted to throw it in. Ketamine, okay, I hope you all know about ketamine. Can you use it in babies? Now, when would you use it in a baby? I'm going to tell you, I use it for spinal taps, who the holder is great, but ketamine's a good holder. And somebody finally started looking at this under 90 days old. Now, this is a very small study. I want all of you to start thinking about using ketamine in young kids and charting it. It's an 8-year review. They looked at how they gave the ketamine orally, intramuscular, intravenous. It's just the beginnings. 14 were identified and met criteria, and the median days is a month and a half. Indications were procedural, rapid sequence, or post-intubation sedation. It's not much to talk about here. The average dose amount listed is 10 per kg for oral, 4 per IM, and 2 per IV. That's pretty much standardized. And they found that there were really no bad effects from this. But again, this is a real seminal study, 14 patients. But I want you to consider using ketamine in kids because we really haven't had a red flag on it. And it seems like a perfect drug to not have to titrate in this situation. So stay tuned. All right, we made it. Let's summarize our lives. Summary points. Number 1, there are new fever guidelines. Number 2, be simple with simple febrile seizures. Just say no and don't work them up. Pay attention to UTI guidelines. Sit them up for spinal taps. Get single dose Dex. You don't have to put them on a week's worth of it. We're under treating anaphylaxis and EpiPen for everyone. And procedural sedation is safe and effective in kids. And start thinking about ketamine under 90. Now, if this talk was much longer, I could have droned on and on, but these are some fun studies that came out. And I read everything every year. And hands down, there's some strange articles. I didn't want to get too comedic here. But there's an article I couldn't make up, and it's been sitting in my box forever. And it's by far the dumbest article title to date. Title. Here it is. Children with asymptomatic short stature. Now, back up. Everybody take a breath. What the hell is asymptomatic short stature? I mean, the only way you can figure that out is you don't meet the height requirement when you're 12 years old at Disney World, or you're walking past a window in a department store and you see how short you are. But not every article is perfect. But the ones I gave you, I hope they're helpful. I think I can't thank you enough for paying attention to me. I wish you all the best. I'm just so happy you're all taking care of kids. And maybe next time we'll do this meeting in person. So I wish you well. Thanks so much.
Thank you, Prof. Richard. It's really excellent point needed to be updated in our emergency department. Next talk will be by Prof. Muhsin Sayyid Najad. He is a professor of emergency medicine and pediatric in David Govan School of the Medicine, UCLA, director of the Institute of Health Service and Outcome Research. He will be talk about very interesting topic about how to make good management for an approach for that patient with agitated pediatric patient with the behavioral health emergency. Welcome, Prof. Muhsin.
Hi, everybody. I hope everybody is enjoying your conference so far. I'm very excited to be here with you. I'm sorry I couldn't be there in person, but hopefully next time. My name is Dr. Saidinejad. I am a professor of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. I also serve as the director for the Institute for Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation at Harbor UCLA. I'm very excited today to talk to you about approaches to an agitated pediatric patient with behavioral health emergencies. I have no relevant financial disclosures. So learning objectives for this session is going to be to recognize the various underlying etiologies of agitation. We'll talk a little bit about the environment of safety in managing an agitated child. We review verbal and behavioral de-escalation, as well as various types of restraint, and we will have a focus on agitated children with neurodivergence. So in terms of background, as many as 10 to 15% of any child who comes in with mental and behavioral health problem, they have acute agitation. Restraint is a very common associated intervention which causes not only a lot of distress and emotional and psychological harm, but it also increases the risk of hospital admission. Both the number of cases of agitation and the severity of agitation presentation to the ER has been increasing over the last decade. For example, between 2009 and 2019, there was at least a threefold increase in the number of intramuscular medications that were given just to calm a child with agitation. And during the same time, the use of physical restraint also increased by about 10 to 15%. Agitation can be caused by a variety of different reasons, and this is very important for emergency department physicians to know. Not all agitation is because of underlying psychological problems. Sometimes, yes, it is behavioral health and psychological problems that are leading to agitation, but agitation can also be caused by an underlying medical or organic cause. It can also be caused by environment. For example, simple things like a child who's hungry or thirsty can become agitated. In terms of risk factors for agitation, there are definitely certain criteria to think about. For example, male sex is associated with a higher risk of agitation. Whether you've had a history of agitation in the past also increases your risk of having agitation again. Also, whether you have been a victim of trauma or you yourself have been a perpetrator of trauma, that increases your risk of being agitated. Bullying, whether you were bullied or you are yourself a bully, also increases risk of agitation, as well as if you've had any issues with communication, having inability to communicate properly in social settings is a very big risk factor for agitation. That includes children who are neurodivergent, for example, ADHD or autism or learning disability. Sometimes also language barrier could be a reason for a person to get agitated because they're not understood. Obviously, having a history of mental behavioral health disorder is a risk factor, but also sometimes children who are living in very unstable environments, for example, those who are in foster care facilities in group home, or children who are incarcerated. And I would add to that sometimes even recent immigrants who are in a completely new environment are at higher risk for agitation. There is a difference, however, between agitation and aggression. We always think of aggression as something that happens suddenly and is under your full control, whereas agitation builds very slowly and over time it escalates. So you almost can see it coming, but with aggression, it's harder to do that. Agitation usually presents with fidgetiness, restlessness, increased body language, increased moving of arms and legs, while agitation is an assault, is a verbal or physical threat of violence. So agitation can be from anxiety or stress or a medical condition, whereas aggression most of the times come from a mental or behavioral health condition, like such as substance abuse or other situational factors. As I mentioned, agitation starts building up very slowly, and over time it escalates. So our goal in managing a child with agitation is try to catch them between the number 3 and 4. While agitation starts, while it's beginning to accelerate, we don't want it to get to the peak because it becomes a lot more difficult trying to manage a child who is at peak agitation. With aggression, there's evidence-based tools that can be used to assess and measure aggression and aggressive behavior. These could involve elements of verbal, physical, or self-directed. One of the common tools that are used to determine the level of aggression that a person is at risk for is the Modified Overt Aggression Scale, MOAS, which has 4 specific domains that it takes points with. This is an example of what that form looks like. As you can see, there's verbal aggression, aggression against property, autoaggression, and physical aggression. And if you see, each one of these items have a different weight when you give it a score. For example, physical aggression is weighed a lot more heavily than verbal aggression, and then you get a total score, and that tells you your risk of aggression. One of the most important considerations as we're trying to manage a child who comes to the emergency department with agitation is that we need to try to use the least possible restrictive means. We want to be gentle. We want to spend the least amount of time to directly involve with them. We want to respect the child. We want to listen to them. We want them to feel like they have some level of trust in us as a healthcare provider. And we also want to make sure that we don't put ourselves at risk by getting into immediate use of physical restraints, for example. These are decisions that are not to be taken lightly. So in terms of environment, it is very important, and evidence suggests that creating an environment that is soothing, that is responsive, is going to be very important in determining how quickly and how easily you can manage agitation in a child. So for example, you have to make sure they have a comfortable place to sit. A nice comfortable chair, for example, would be a good place to start. Make sure they have some water to drink, some food. Make sure that they have some distractions, some tools that help keep their mind off of their current situation. Make sure the room is a good temperature. Make sure the amount of lighting in the room is appropriate. Make sure there's no loud noises when possible. And most importantly, try to make sure not to have a group of people attacking the child with questions and be in the room at the same time. You want to minimize the number of people that are directly interfacing with the agitated child, because that will cause them to escalate even further. So when possible, you want to make sure that the child who's agitated can be in a private room. You want to make sure that you remove all the harmful objects from the room. There's nothing that the child can grab onto that can harm themselves or you or others. If possible, it is best to manage this agitated child in a corner or a part of the ER that is away from the main activity. So it would be nice if it was a private room on a corner rather than a non-private room in the center of the ER. It's also very important to provide, when possible, age-appropriate distractions like an iPad, like a video game, or anything that can keep the child from being more agitated. Also, agitated children, while they're being evaluated and waiting for psychiatry to see them, they sometimes spend quite a bit of time in the emergency room. So it's good for them to have a routine and a schedule, for example, making sure that their meals are arrived at this correct time. If they have to take a walk, you can let them walk. And also, importantly, offering choices is a big element of safety tips for the environment. If you are not, for example, able to let the child leave and the child wants to leave, you say, well, I can't let you leave, but these are a couple of things that I can let you do, or these are a couple of things we can do. And having choices always helps. So this brings me to the element and the importance of verbal de-escalation and behavioral modification. Evidence suggests that as many as 80 to 90% of children who are agitated can simply be de-escalated by just talking to them and having them in the right environment. So in other words, the majority of children do not need either medication or physical restraints. And being able to engage in a conversation to understand why the patient feels agitated and help the patient self-regulate is extremely important and useful way to approach an agitated child. So in a verbal de-escalation strategy, you want to use empathy. You want to have that approach to shared problem solving that, yes, I understand this is difficult. This is a difficult position that you're in. Unfortunately, I can't let you do this, but let's see about other choices, other things we can do, for example. And it's important to consider that before you use any form of restraint. While we are at this, you also have to make sure that any triggers that cause the patient to be more agitated are removed. A lot of times we think the caregiver or a parent can be our team member, can help us with the de-escalation, but you got to be sure that this is not a situation where the caregiver is actually the trigger. It is because of them that the patient is agitated. So if that's the case, removing that caregiver from close proximity to the child is important. So here I have listed the 10 domains of verbal de-escalation, which basically you want to treat the child like a person. You don't want to keep making them feel that they're just a child. You don't want to say any kind of provocative statement, anything that says, well, you did this, or you are aggressive, or you are giving it difficult time for everybody. You're making it hard to work with you. You want to establish a verbal contract where they agree that, okay, if, for example, I brought you water, then we can sit down and have a conversation. Make sure that you are concise with them. You listen closely to what they have to say, but you are in charge. You have to let them know that they can't do whatever they want. This is a situation where you are going to have to decide. And it is important, again, to make choices and provide optimism to the patient. This is a de-escalation tip document that we created through the EMS for Children Innovation and Improvement Center. And there's a QR code in there that you can basically download this. We have it as a big poster in our emergency department, and it can be used as a pocket card. It can be used as a printable flyer, or it can also be used as a poster. It basically goes through the different elements of de-escalation with an agitated child. When you are looking at de-escalation, it is very important to realize that it is important to have one person that is the one that's interacting with the patient. In other words, you have a de-escalation leader. This would work a lot better than if you had 2-3 different people each coming and talking to the patient at the same time. You should have a 2 to 3 member team, but each member of the team should have their own different responsibilities and jobs that they're doing. For example, one person is keeping an eye for when am I going to call security. One person is trying to look and make sure that the pathway to the door is correctly not blocked, but safe. And somebody that can communicate with the rest of the team about what's happening or go get medication if needed be. So it's good to have a team, but only one person should be the escalation leader. So when you're standing as a de-escalation leader in the room, you're standing by the door, but not blocking the door. So in other words, you make it easy for yourself to leave if you need to, but you're not also blocking the child or making them feel like you're blocking the door, not letting them leave. So remember also that sometimes patients are agitated because of reasons that are not under their control. So don't keep pushing them on why they're agitated if you don't think that they have insight into it. And there becomes a time where you realize that your efforts are not going to be successful and you're going to move on. But like I said, the majority of times, if you connect with the child, you have a good chance of de-escalating them without the need for using any kind of medication or physical restraint. This is, again, a QR code to the resources that are present at EMS for Children Innovation and Improvement Center. This is a complete package or a bundle that has everything you need to know about verbal de-escalation. About agitation management in general, there's a medication table in there. There is the de-escalation tip sheet that I showed you. There's also an interactive learning module. And we're currently working on a workshop that can be used by residents or medical students to practice different cases of the escalation of agitated child. Sometimes just doing verbal de-escalation becomes really difficult. So for example, a child who has an underlying organic cause, somebody who has encephalitis, and the reason they're agitated is because they are not able to comprehend what's going on around them. Children who are neurodivergent, like I said, like an autistic child or a child with learning disabilities, or children who have their stressors sitting there right next to them. As I mentioned before, if a family member is a distraction and is a stressor, you cannot de-escalate them with that person being present. And also, it is extremely difficult to de-escalate a child when multiple people are trying to do this at the same time. Neurodivergent children are a very specific group requiring sometimes specific intervention, although I would say we can look at an agitated child who's neurodivergent the same way as any agitated child. But there are some important things to consider. A person who is neurodivergent, it is 80% of the times they are likely to also have an associated anxiety. The anxiety is in fact what is leading to agitation. They have challenges with normal social cues. They don't understand others. They are much more sensitive to noises, lights, tone of voice, and people. Sometimes their caregiver is also anxious themselves and may not be able to be as helpful. Other times, the caregiver might be the perfect person to partner up with and try to figure out what works. Neurodivergent children like constancy, they like familiarity. So even though sometimes giving somebody more stimulation by having a movie on or something like that is not a good thing to have, but in this case, if a child who's neurodivergent is given an iPad and in there is a cartoon that they know and they're familiar with, that can actually help them de-escalate. Also, neurodivergent children tend to be easily triggered by simple things like being hungry, being thirsty, being cold, or being hot. They are much more sensitive to that, and it is something to consider. So when the time comes that behavioral modification doesn't work and you have no choice but to use some kind of a restraint using a medication because the child is getting close to being an immediate risk of danger to self or to others, you have to consider what is the safest, smallest dose of medication that I can give. What is the one medication that I can give as a single agent rather than multiple medications? Is there a medication that the child prefers that has worked in the past that they can choose? We can let them have that. And when possible, try to give the medication as an oral dose rather than a painful intramuscular or intravenous dose, if that is possible. This is a medication table that we developed again as part of the same package on agitation. I told you that there's a QR code here. You can also find that in the same bundle. We did a very large literature review and evidence synthesis through our Evidence Synthesis Center at Baylor College of Medicine in Houston, Texas, looking at all the evidence for the different medications that are used. And here's the list of medications that have been deemed to be acceptable for managing agitation in a child. And most often, the atypical antipsychotic like olanzapine is the preferred agent, especially children's hospitals like to use it a lot. But there is considerations and contraindications for when you're using different medications, and I have them listed here for you to know which ones is a better medication for what time. Also, different etiologies of agitation work better with different kind of medication. Again, I'm not going to go through all of this. This is again in that bundle package that you have the QR code for already. Every time for specific type of patients, you do have a specific medication that works better. For example, patient who have agitation due to delirium, Probably a best choice is a different medication than somebody who comes in with withdrawal or intoxication. Also, now don't forget that pain sometimes is a cause of agitation, and managing pain might in fact relieve the agitation altogether. Physical restraints always should be a last resort. It is basically when you physically block the patient from being able to move, you're basically preventing their arms and legs from moving around, and any natural body movement is going to be prevented that way. It should really be the last resort. It should be if there is absolutely immediate risk to harm self or others. And in general, only about 6 to 10% of all agitated patients may end up needing a physical restraint. I think we're using physical restraint a lot more often than that, but in general, less than 10% of all agitated children need to have physical restraint. Because physical restraint can cause more harm and injury. They can cut skin, they can make bruises. But besides that, the psychological harm that you get from having a physical restraint could be tremendous. And there's not a lot of literature on this, and that's still poorly understood, especially long-term effect of being in a physical restraint. When you use physical restraint, it should be for as short of a duration as is humanly possible, and it should be reassessed frequently as the laws of the jurisdiction requires. Different countries have different laws. In the United States, different states have different laws for how much restraint you can use and how often and for how long. There's also the consideration for hard restraints were made of leather. It's really, really hard to get out of, versus soft restraints, which allow a little bit of mobility, and probably soft restraints are preferred over hard restraints whenever that's a possibility. So as I said before, always the least restrictive means. Use a soft versus hard. Use a 2-point restraint versus a 4-point restraint whenever possible. Consider using a calming medication to help, because when the medication kicks in, you are more likely to end up not using the physical restraint anymore. That allows you to take the physical restraint off faster. Restraint should be placed by a trained and qualified person. It shouldn't be something we do without consideration. Every patient who is physically restrained needs to be closely monitored. And in many, many jurisdictions, you have to document the reason why you put the patient under restraint and all of the activities that happened around the time of restraint that it required it. You also have to document when it was placed, how many points of restraint, and how often does it need to be reevaluated, because that patient needs to be evaluated often. In neurodivergent children, generally speaking, for both pharmacological and physical restraint, you have some differences. Children who are neurodivergent respond pretty well to low dose of benzodiazepine via the oral route. They also, if oral route is not possible, seem to work with intranasal or intramuscular benzodiazepine as an alternate choice. In general, antihistamines tend to have paradoxical effect because they're anticholinergic. Sometimes they actually cause agitation to get worse. So I would not recommend antihistamines as an option for neurodivergent children. Specifically in the United States, the Food and Drug Administration has approved both aripiprazole and risperidone for agitation in neurodivergent children, and that could be a medication that is used. When it comes to physical restraint, it's extremely difficult with a neurodivergent, especially a very high-level autistic, low-functioning autistic who is severely developmentally impaired. They would not understand the meaning of being put in a physical restraint. So a lot of times that makes it extremely difficult to be able to have them in restraint. This is a policy 347A from the County of Los Angeles, Harbor UCLA, where I work. As you can see, the area in the red box tells you what your rules are. So for example, an adult patient can be in a restraint for 4 hours before the order has to be renewed. a child between the age of 9 and 17 years can only be in physical restraints for 2 hours before the order has to be renewed, and the children under 9, which hopefully we never have to put them in a restraint, can only be in a physical restraint for 1 hour before the order has to be renewed, which means you have to have a very good awareness of when the patient does not any longer need to be in a restraint. As soon as that moment comes, we need to take him out of the restraints. And just to summarize what I spoke to you today about, just understand that identifying the cause of agitation in children is very important, because agitation can be treated only if you understand what the cause of it are. The majority of agitated children can be managed without medication or resorting to physical restraint. That is about 80 to 90% of them. Behavioral de-escalations are specific techniques. They're evidence-based, and they exist for the safety of the patient and the safety of the staff. When medication is needed, try to use the lowest dose possible, the easiest route possible, and single agent when possible. Physical restraints should be used as a last resort in a child who is immediate risk to self or others, and they should be removed as soon as they no longer need it. And this is a list of some resources that I have for you that will really help you with managing acute agitation in children. Thank you very much. I really appreciate you spending this time with me. And if you have any questions, please feel free to contact me, and enjoy the rest of your conference. Thank you.
Thank you, Prof. Mohsen. Really, it is a very important point you speak about. Difficult situation can be faced in can encounter in our emergency if the patient present with agitation, and how to manage like this situation. Now we'll be moved to next talk with Prof. Richard. Richard Cantor is a professor of the emergency medicine and pediatric. He is retired director of the pediatric emergency service and the director of the fellowship program in the pediatric emergency medicine. He is the emeritus medical director of the Upstate Poison Center in New York. He will speak about very important topic about patient and what's the emergency in the first 3 days of life. Thank you. Welcome, Prof. Richard.
Greetings. My name is Dr. Richard Cantor. I'm a toxicologist and a pediatric emergency medicine physician in Syracuse, New York, and I'm very happy to be able to spend some time with you today to present one of my favorite topics, stabilization of young infants under 60 or 30 days of life. We have 30 minutes together, so I'm going to move fairly quickly, but the slides are self-explanatory. If you take a look at this this bell curve of illness, if you take a look at the left group, the well-appearing group, these are easy for you. Wellness is an easy diagnosis to obtain. On the other end are the super ill-appearing babies, and I'm not going to go through that immediately, but they're quite simple because you have pre-programmed activities you have to put forth. The harder group, where you make your money, so to speak, are the children who are sort of on the cusp of illness, but with appropriate interventions, you can reverse things, which is the beauty of pediatrics. So that's what we're going to focus on here. Some general management principles, and I feel very strongly about these. The ABCs of unstable infants. Number one, the secretions are obstructive, and don't forget chin lift and jaw thrust. They're often neglected, And it's quite embarrassing to fix this in 5 seconds with a simple maneuver. In terms of breathing, one of my pet peeves is getting OSATs on sick babies. They don't really indicate ventilation. You have to use your stethoscope. Please use it. You bought it. Good SATs don't equal ventilation. Children are non-smokers. Don't depend on it. And grunting is a very bad sign. It's auto PEEP, and you have to do things beyond oxygen to help these kids. In terms of circulation, these are very important points. Number one, every sick infant deserves a bolus of 10 to 20 per kilo, which we'll get into. Every sick infant under 30 days totally, but also 60, they're candidates for presumptive antibiotic therapy after you obtain blood and urine cultures. Don't wait to do the spinal tap. You've got time for that. In terms of vascular access, I'm not going to insult you. Look in the hands, look on the ankle. Don't forget the scalp veins. They're very important in this group. They're sitting right there. You can shave some hair. I know that's a bit invasive, but it's helpful. And if you take a look at this diagram, you see the equipment is sort of primordial. It's a piece of tape and a rubber band. And I've gotten 22 or 20 gauge catheters in the temporal vein, and they've lasted 2 days with taping and wrapping. So don't forget the scalp. In a dire situation, under 14 days, the umbilicus is still available to you for cannulization. This is really an amazing thing to take into account. If you take a look at the diagram here, if you have an umbilical access tray, and I hope you have one in your PGDs, you can easily access the vein, which is very dilated and very easy to locate. And you really don't have to put it in very far to get blood return. It's below the liver, and it's essentially a central line. So please don't forget this. And as a last resort, you can use intraosseous access. I'm sure that all PEDS EDs have the equipment available to do this. And don't forget this as an access point, and almost any and all chemicals, medicines, or whatever can go through it. So don't forget it. Okay, so that's the IV. In terms of airway issues, I can't emphasize enough that the earlier the better you intubate, the better things will turn out for 2 reasons. One, you protect the airway and aspiration and you ensure ventilation. Number two, there is no one happier in the PICU than someone who gets to extubate a patient rather than rush to intubate. So feel free to indicate earlier, use cuffs, regardless of age. Don't give them a little Valium or benzos. Rapid sequence intubation drugs are indicated. All drugs have been accepted for use. And as I said, don't be a wuss, really go at it. And then most importantly, the airway itself, this is not an airway course. The larynx is much more anterior and superior in young infants. So look high, look higher, and look highest to find the chords. Okay, another thing that we overlook, and this is a big deal. A lot of these kids are sick and they get bagged, and you dilate their stomachs and they can't ventilate. They have no tidal volume. So get the air out. The nurses always remind me to do this. Other pitfalls are you must identify hypoglycemia at the bedside. It's critical. Number two, make sure their body temp doesn't drop. Have warmers and towels ready. And I am telling you, if things are going well and then they turn south, it is always, always, always a problem with the airway. That magic tube that you got in that you were so thrilled about often gets dislodged. You only have 4 centimeters of forgiveness, and recheck it. And don't be shy. Extubate and redo it. It's always the airway. Okay, so with all that intro, and a lot of that's more important than what you do, let's do some quick cases in the time we have. The overview is we're going to do a shock case, a blue case, a seizure case, and a lethargy case. This is pretty much the gamut of what's going to get you very nervous when dealing with this age group. Here's the first case. I call it What the Hell Happened? And if you come to a fork in the road, take it. In other words, pick the right thing to do. And you'll see it. These are real cases, and I'll show you my pitfalls of things I could have done better. This is a case of a 1-week-old with only a single day of poor feeding and apparent respiratory distress. Excuse me. If you look at the vitals, the heart rate is high, the respiratory rate is high, The blood pressure is soft. The sats are 90% in room air. Not good. The cap refill is 6 seconds, which we know in peds is more reliable than the blood pressure because of vasoconstriction. Grunting with retractions and poor entry. So this is the picture of the child. 1 day history, 1 week old. There's not much else to talk about here. No murmur. Now, don't kid yourself. With a heart rate of 180, you're not going to hear a murmur. Don't try to convince me that you are. Just be happy if you don't hear a dysrhythmia. Okay, the case discussion. Number one, this kid is in an uncompensated shock. Intervention is indicated. There's no detailed history here that's going to help you. You must act. Number two, I don't know the etiology. I don't need to do grand rounds at the bedside. Is he septic, hypovolemic, cardiogenic? At this point, it doesn't really matter. You have pre-programmed events that you have to be part of to change the outcome here. And accompanying all this, he's having respiratory failure, shock and respiratory failure. So where should therapy begin? The first thing is the airway's fine, the breathing, profound work of breathing. Number three, circulation is unacceptable. So we flunked 2 out of 3, okay? With regard to circulation, the question remains here, could this be, I'm moving my icon around, distributive or septic shock? There's no history of volume loss here, okay? It's unlikely that it's hypovolemic shock. It's a 1 day history of falling apart. After you got blood cultures, antibiotics are indicated. It's often a 3rd generation cephalosporin, and then the addition of ampicillin to cover listeria in the rare case. Okay, other circulatory things. With undifferentiated neonatal shock, as I said earlier, volume is indicated. 10 to 20 per kilo of normal saline push. Don't be shy. And you can repeat this up to 60 per kilo. However, there's a caveat here. You have to consider the heart size as a rough estimate of vascular status. You can sono this or you can get a chest film before you give more than 20 per kilo, because it's a tipping point in the algorithm for managing these kids, and you'll see where this goes. Okay, case progression. I gave this child 60 per kilo of normal saline. He got sicker. He breathed harder with less outcome and output. Number two, his liver enlarged. His chest film was shown here, and he has a huge heart. What I have done here is uncover a case of not hypovolemic nor distributive shock, but cardiogenic shock in this young 1 week old infant. The heart size is the giveaway. This is not cool. All right, should I intubate this kid? Well, in my career, and this is my guilt confession, most of the babies I've intubated, I should have intubated them sooner. We often get spoiled in peds because a lot of illnesses turn around. But earlier better than later for intubation. I've said this about 20 times already. If you don't intubate, they also develop acidemia from lactate generation, and nothing works well in that chemical environment. No drugs you give, no pressors, nothing. You must fix acidosis. Always use the paralytic, as I said, and always empty the stomach. All right, with regard to circulation, could this be congenital heart disease? Well, it is, because he's a week old. Kids under 30 days, part of your differential for almost anything that's wrong with them, vomiting, no bowel movements, seizures, lethargy, whatever, you have to think of a malformation because you're in the tip period where things that are built wrong are going to go wrong and have a presentation you can rock to. So could it be congenital heart disease? Probably. Number two, it is not the cyanotic variety. Usually they present right in the delivery room. We're going to go through this in the next case, but they would fail the hyperoxia challenge, which we'll also go over. But most likely in this case is what we call a ductal dependent lesion. Now, what am I talking about here? I'm talking, my cursor is moving. The ductus, when it remains open, allows circulation to blend. And if there are any obstructive phenomena, specifically in the left ventricle, it gives you a bypass to survive. However, when the ductus closes, nothing good happens. To break it down with 2 slides, and I apologize to my peds cardiologists for this simplification, about failure. I want you to divide anomalies, congenital heart anomalies, into 2 groups. The first group are the blocks. These are left ventricular outflow obstructions, aortic stenosis, coarctation, interrupted aortic arch. The holes are what you would expect, anything wrong with the septum. ASD, VSD, PDA, and then, of course, an AV canal. Blocks and holes, okay? If you take a look at what this means clinically, the blocks are ductus dependent with LV outflow obstruction. And they get sick early when the ductus closes, often in the first week. And when that ductus closes, they are basically in immediate shock, and they often have poor perfusion, and they will present just like this child. The holes, however, don't get sick for a longer period of time because it takes a while for the LV or the LA, the atrium, pressures to rise high enough to send blood to the right side of the heart through the hole, I hate to simplify, and then down to the pulmonary artery and annoy the lung and end up in failure with that regard. So the timing is very different here. It takes a couple of weeks for this to show its true colors. So that's peds congestive heart failure for dummies. Excuse the word dummies. All right, case resolution. This kid's in failure. Given a dose of prostaglandin E1, it's okay. Perfusion normalized, and echo demonstrated a cohort as a ductal dependent lesion. Prostaglandin E1 opens the ductus. It has very few side effects. The only one everybody cares about is apnea, but you're ventilating him. He's intubated, so not to worry. And this is basically what you're dealing with in this situation. And he was repaired surgically at a later date. So this is a ductal dependent lesion. The take-home message is kids under 2 weeks who present in shock deserve consideration of volume loss, not in this kid, he got sick in a day, sepsis, anybody septic at that age, or a ductal lesion. And you can't go wrong with antibiotics and the consideration of prostaglandins. And made simple, this is the slide to take away. Get pre-treatment cultures, give antibiotics, like I said. Next step, give 20 per kilo rapidly. If you want to give 10, have a nice time. If they get sicker, I want a film or some sono of the heart. I want to take a look at the heart. If the heart is enlarged, I want you to think failure from a ductus. Give prostaglandins. If it's not enlarged, I want you to think of more fluids. Now, I went up to 60 per kilo here before I checked, and that was my bad. But if the vitals get better after another 40 per kilo of saline, consider volume loss or distributive causes, and you'll treat other etiologies. And if you really, again, have to have a history of volume loss, vomiting, diarrhea, bleeding, etc., to call it hypovolemic. Other easy steps, if the vitals don't get better, start pressors. That's not the point of this talk. One caveat, there are kids who have hemolytic anemias or anemia of infancy who have a pallid shock. And if you gave them crystalloid, you are not their friend. You will lower their hemoglobin. So I want you to consider not volume loading them if they're pale and getting a stat hemoglobin because packed cells may be indicated. Okay, that's shock. You made it through the first case, all right? Most of these kids do very well. Prostaglandins are a miracle. Let's take the second case, the definition of insanity. Insanity is defined as doing the same thing over and over again and expecting a better result. And that just doesn't work. All right, take a look at the history. This is a call midwinter, RSV season. There's a 3-week-old male who's coming in respiratory stress, midwinter. He's described as sick, mildly cyanotic with good perfusion. Wheezing is heard, and as per pre-hospital protocols, we gave him a nebulized albuterol treatment en route during his short transfer to our facility. The vitals are listed. He's afebrile, he's tachycardic, his heart respiratory rate is elevated. His pressure is acceptable. His cap refill was good. However, his sats were 50% in room air. Now, besides being completely unacceptable, that's strikingly abnormal. And obviously, we've all done this. You'll check both sides of the body for the sats as if one side's going to be doing well and the other isn't. That's crazy talk. But his sats are 50% in room air. In general, he's crying loudly. He's very blue, and he's retracting when he's crying, excuse me. Listening to his chest is moving great air. I mean, I don't hear any wheezing. He's got no murmur, but let's be honest, with that heart rate, not going to be very easily noticed. His skin is blue. His pulses are normal, bounding actually. And I got a blue kid who's breathing fast and moving air. That's kind of striking. The data points here, we got a CBC and he's a little anemic, but that's not the point. If you take a look at his ABG, you take a look, his PO2 on 100% mask, tight fit, was 50 with a mild-based deficit, okay? So there you go. He failed the hyperoxia test. Didn't budge his PO2. His EKG showed a sinus tach, and his chest film, and it's a bedside chest film, and we know that we don't love them, showed cardiomegaly. All right, real-time case progression, interventions. We gave him albuterol because it was RSV season, and you never know if you have subclinical bronchospasm. We gave him a bolus on principle, and we gave him antibiotics. In retrospect, why not? But I don't think this was a case of ceftriaxone deficiency. By the way, that was a joke. But we gave him antibiotics. Okay. I took him to the trauma room at the early point of his hypoxia to get a better look at him and really get him out of the regular room. And a crowd showed up because pediatric critical care cases, unfortunately, people have an interest in it. So it's a crowded room. Nurses are holding a mask up to his mouth, really pretty much, I know, delivering 100% O2. And I decided to intubate him because this is ridiculous. I'm not budging. And we took care of that pretty quickly, but not much happened here. There was no improvement, none whatsoever. So this is where the insanity comes in, the reality-based outcome. Here I am doing the same things that are just not working. So his SATs on 100% are still 50%. He's still screaming. The room is getting smaller because people are getting very worried about how this is going to happen and transpire. And there were more people watching the case. And everybody's looking at the monitor. His SATs, sorry, still 50. Okay. Here's this film. It wasn't helpful. It was good ruling out free air or a pneumo or a bad pneumonia and things like this. But I can't give you any of the fancy, funny shaped hearts from this. And you'll see what I mean in a minute. It's not helpful. So it's time to earn your money. So this is when I realized if it's not working, just stop doing it. But I kind of knew where this was going, and I knew what this was. And you'll see how I sort of figured this out. I decided I was going to get this kid calmed down. We were just beating him up. We gave him morphine, and as I said, we decided to intubate him before, right after that. And all of a sudden, he got obviously very quiet. We paralyzed him, and his respiratory rate went away, and his OSATs went to 98% on room air. And my heart rate dropped below 200. I was very pleased with that outcome. So I'm thinking, all right, back up the tape here. His SATs were 50. I fixed him by basically getting him sedated. I didn't even know what that meant. And I was thinking back to all the lectures I went to about common cardiac lesions. And if you remember, it's the 5 T's: tetralogy of Fallot, transposition, truncus, tricuspid atresia, and total anomalous pulmonary venous return. Now, I can never remember mnemonics. I never remember what the letters stand for because I'm too old. But I remember it by the 5-finger thing. I'll try to get this on screen. The 5 fingers. The first finger, I'll do it upside down. Okay, got that one, is a truncus. The 2 fingers are basically transposition. The 3 fingers are tricuspid atresia. The 4 fingers are tetralogy. And the 5 is total veins or totally screwed. None of this matters because you're not going to fix this at the bedside. The only thing you can fix here is the tetralogy kid, because there are well-known therapies that work, and I'm not going to get into that. That's way too complicated. But to be quite honest with you, the other 4 T's probably don't make it out of the first 24 hours of the NICU. They're going to show their true colors, i.e. blue and cyanotic, in the neonatal period. But they can lie in wait for you. There's a nice picture of tetralogy, which you can review. And TET spells are usually self-limited. It's a whole discussion point, and they're more common in the morning in older kids, but this was a neonate. What you do to treat them is you bring the knees up to the chest to increase cardiac return. You give them morphine to slow the respiratory rate and give them less return. Fluid resuscitation, bicarb to stop the, acidosis. And then you can use an alpha agent to increase the resistance in the systemic vascular system and propranolol. This is way above the scope of this discussion. If you had any concept of this, you call a peds cardiologist and they'll walk you through it. All right, the take-home message is, let me get it down here. This take-home message is one, don't complicate life. There's only 3 ways you stay oxygenated. You breathe it, lungs, you pump it, heart, and you carry it, hemoglobin. That's it. Got it? The hints, use the hyperoxia test. OSATs that are in this 80s, mid 80% range, for some godforsaken reason, are usually methemoglobinemia. And I'll talk about that when we do the poisoning lecture. But breathe it, pump it, carry it, okay? Cyanosis made simple. This is for dummies like me. Administer oxygen. There you go. Number 1, if SATs go up, it's probably lung disease. That's your first hyperoxia tip point. Number 2, give them O2. If the SAT doesn't go up, you got a branch point of either is it heart or can't they carry it? How do you break the tie? You look at the gas. If the PO2 jumped up and the stats stay low, it means you can dissolve it in the blood, but you can't carry it, and that's methemoglobinemia. Okay? You need to understand this because you can't memorize it. More algorithms. If you give them that same supplemental oxygen and neither the PO2 or the SATs move, it's heart disease because they can't even dissolve it because the blood's not getting near the oxygen. And that's the branch point. This is my favorite table in the world, the hyperoxia table. If you take a look at it, it's on the, there's my cursor. This is room air, 21%. This is 100% O2. The normal person has a PO2 of 70 with SATs of 95 in room air, and they go crazy when you give them 100%, okay? I think we got that. Lung disease can have any sort of PO2 or SAT, but it responds, like I said, the hyperoxia test to 100% O2. And methemoglobinemia, they have a low SAT at 85 and low PO2, but when you give them supplemental, the PO2 goes up because you're dissolving the oxygen in the blood, but the SAT doesn't, meaning you can't carry it. And then cardiac is a mixed bag of nothing getting any better. So that's the blue kid. Okay, we're moving along here. The odds of a TET making it out of the newborn nursery they're slim but real, and they sometimes have their first TET spell in the first week, and you have to be prepared for that. But by and large, cyanotic heart disease is not going to show up in the ED very often, but if it does, you know what to do. Okay, here's a seizure case. Now, ped seizures, they're going to have some more talks on this, are often very complicated. Neonatal seizures, we're talking about young baby problems in this lecture. I was going to give you a case of, and for the sake of, usually if it's a longer lecture, I do it, a case of a child who had congenital adrenal hyperplasia with abnormal genitalia and a hyponatremia. But what I wanted to focus on in this is the most current recommendations for seizure management in status in young babies. And there's an article here, it's 7 years old, but it's the most recent one, talking about evidence-based guidelines for the treatment of convulsive status epilepticus in children. And I summarized it for you. The stabilization phase, the first 5 minutes, basically it's ABCs, and don't forget the dextrose, okay? Simple, basic. Number 2, the initial therapy phase. They recommend a benzo, and we often, in most surveyed people are fans of Ativan for its penetrance to the CSF. Most people favor 3 doses and before moving on to another one. And that's fine. Have fun with that. But the second drug here is quite interesting. It's barbiturates, normally phenobarb. Now, I'm an older physician in peds, and phenobarb was a mainstay of seizure medications for status because 2 things we knew to be true. It always worked. And the worst sequelae was apnea and hypoventilation. But that gave you the opportunity, quite frankly, to tube a child. And a lot of these small babies should be tubed because you're going to be doing a lot of stuff to them, and it's a stabilizing factor. So barbiturates are indicated. Remember this. The next stages get a little weird here. Now let's take a minute and look at fosphenytoin. Fosphenytoin was created to replace phenytoin or Dilantin for the brand name. Now, Dilantin intravenously had a rate limit on how fast you could give it because its diluent was propylene glycol, which was cardiotoxic. So you had to do it over 20 minutes. And when a child's twitching in front of you, that's a maddening event. Then they invented fosphenytoin, so they didn't use that diluent. But it's kind of a lie, the rapidity of action here, because you've got to dephosphorylate the phenytoin to make it active, and that takes 15 minutes. So don't be shy if it doesn't work right away. Valproate, I don't want to even discuss. That's really not a big indicated drug. And then Keppra, or levetiracetam, which most neurologists can't even explain to you how they work, but it's well accepted as a status measurement. The last and final stage of status are kids that go on continuous EEG monitoring to rule out electrical seizures, and they're usually paralyzed, but that's way beyond the scope of this. So that's pretty much seizures. It's ABCs, airway. Make sure you give a benzo and then move on. And what I do is phenobarb. If I need to tube, I tube. And then I'll push Keppra because the neuro's going to order it. And generally that controls things. Remember, the neonate, the kid under 30 days with seizures, often has structural crazy stuff, shaken baby, malformations. They may have hyponatremia. They could have hypocalcemia from the Georges. All hell could be breaking loose. They present in status, not simple seizures and such. So that's seizures, okay? And I'll end with this, the lethargic child. And the differential is real. And these are my steps for not screwing up. Number one, easy steps. Check and fix the glucose if necessary. Number two, give them Narcan. The only person in the world that doesn't want Narcan is an addict. And I don't think a small baby's got that problem. Unless you have a withdrawal kid, for the most part, Narcan is safe. You're going to have to image them. Don't do the PCARN rules. These kids are suspect for shaken baby or malformations. And then if you're thinking meningitis, like I said at the beginning, draw your blood and urine, push an antibiotic. You got a bunch of hours to do the tap, and you'll do very well. These are non-negotiable actions. You got about 20 minutes to get this done because you can fix what's fixable. Other easy steps, use this mnemonic, AEIOU tips. And it's been very helpful in my career as much because I always forget alcohol exposures. I always forget intussusception because the intussusceptors often present with lethargy. And I often forget the fact that it's part of ingestions, but psychiatric events and such. So that's a good mnemonic. So here's my final points, and I think we made it in 30. Number one, the shocky infant. The majority of these kids respond to early tubes, quick volume, antibiotics, and pressors. If the volume worsens the clinical status, think of the heart, as I said. If it's in the first week or two, think of prostaglandins. If it's after 30 days, think of a septal defect, and you may need Lasix or other diuretics. In terms of cyanosis, use the hyperoxia test. If they get better with oxygen, it's the lung. If the SATs stay low, but you dissolve it, it's its inability to carry and methemoglobin. If the SATs stay low and the PO2 stays low, it's probably heart disease. And the kid in status, I can't say it enough. Use your stethoscope to assure ventilation and status. SATs don't mean anything. Standard epic drugs are published. Use them. If you tube them, you're not stepping backwards. It shows that you care. It's a real nice thing to do for these kids. And then if things are out of haywire and you got to use a lot of antiepileptics, think of metabolic or structural issues that are at play. And we made it. And I want to thank you for listening. You're going to do well with these kids. I want to thank you specifically for caring about children. I want to applaud Mohammed for this conference, and I only wish I could be there to take questions and be with you. But take good care of each other. Thanks so much.
Thank you, Prof. Richard. Really is very interesting coverage for all that emergency cases can be faced or encounter in the emergency for the first 2 months of life. So it is very important approach how to deal for all that cases. We'll move for next topic will be presented by Prof. Mariana Goshel. She is a professor of the clinical emergency medicine and pediatric in David Given School of the Medicine and Harvard UCLA Medical Center Department of Emergency Medicine and Pediatrics. She is executive director of the Academy and Clinical Affairs of the Landerquist Institute, Torrance, California. She will be going for non-traumatic surgical emergency and how to will be approached in emergency department. Welcome, Prof. Mariana.
Hi there, Dr. Marianne Gaushi-Hill, and I'll be talking on navigating non-traumatic pediatric surgical emergencies. During this talk, we're going to identify non-traumatic abdominal surgical emergencies in pediatric patients. I'm going to use some case studies just to illustrate things. We'll understand the methods of diagnosis of these, so diagnostic imaging in particular, and kind of the clinical scenario that makes sense. And then we'll talk about initial resuscitation measures, and I think very important just because time may be valuable in certain situations. So let's go ahead and get started. So case one is a bilious emesis baby, which always rings fear into the mind and soul of pediatric emergency physicians when the mom says the baby is spitting up green phlegm or material. So this is a 2-week-old female brought to the ED for bilious emesis and lethargy. The pediatric assessment triangle, which is a paradigm that uses visual cues to understand the immediate needs of resuscitation based on creating a general impression, shows that the baby has abnormal appearance, so appears lethargic, abnormal breathing, and that could be tachypnea. In this case, it's grunting, that sound that they make. We'll talk more about that. And the color is pale or mottled. So vital signs show a heart rate that's high, borderline high respiratory rate for age, afebrile, O2 sat is 94, could be higher, and the weight is 3 kilos. So this is our pediatric assessment triangle. We look at appearance, work with breathing, and circulation to the skin. And when there are abnormalities in all of these, it's generally something very serious. It could be shock, it could be respiratory failure, or frank cardiopulmonary failure. And then grunting that can be due to respiratory, meaning trying to create auto PEEP, or it's secondary to pain in the abdominal or thoracic cavity. In this case, it's likely the latter. So when all 3 arms of the triangle are normal, then that's a patient that's stable. You can continue your assessment. If there's abnormalities in work with breathing alone, this is respiratory distress. These are kids who are able to compensate. You'll see it in asthma, bronchiolitis. Respiratory failure is when appearance and work with breathing are wrong. It could be appearance, work with breathing, and circulation. Like a child appears cyanotic or pale as well, but typically appearance and work of breathing are off, and that you're going to need to add supplemental oxygen and potentially support ventilation. Shock is when the metabolic demands exceed what the body's able to produce. Can be due to sepsis, and generally what you see with shock is circulation is off, so they may be pale or mottled, and you also generally with decompensated shock, you have alterations in appearance and often in work of breathing. CNS metabolic, such as seizures, toxins, the appearance is off, and work of breathing and circulation may be normal. And then finally, cardiopulmonary failure, which I'm really worried about in this kid, but the bottom line is all 3 arms. There's some abnormality, and you position the head, make sure the airway is open, consider whether you need to support ventilation and oxygenation with supplemental oxygen and bag mask ventilation. Reassess for a pulse. If there's no pulse, you begin chest compressions, or you continue your assessment and determine that there's hypotension. You may also consider doing chest compressions. Well, in this case, I'd begin cardiorespiratory monitoring, supplemental oxygen, consider securing the airway. I would obtain vascular access. If you need to do IO, you could do that and begin fluid resuscitation at 20 mils per kilo. Now, I will tell you the reason I have a saline flush here is in these little babies. So for this baby weighing 3 kilos, I would really like to see 60 mils, so that's 6 syringes. So that's the way I keep track. I ask the nurses to go ahead and inject, put a syringe down, go ahead and inject, put a syringe down. And this way, I really keep track of the amount of fluids that the child is getting. Imaging, and we'll talk about that in a second. And has been some changes relative to this. And I would get surgical consultation. I'm going to have the clerk call or someone call while I'm resuscitating, but we're going to get the surgeon on the line, pretty quick. When we think about differential for critically ill neonates, the misfits can be used. It's a mnemonic that talks about a lot of different things. What we're talking about are intestinal catastrophes today, but you always got to think of inborn error. There's metabolic causes, congenital heart disease, like a single ventricle issue, although those kids generally present pretty quick. But the key thing is these are the things that you might consider when you have a undifferentiated, really, really sick child. And I think it's helpful. It's a great list, and you don't want to narrow your differential too soon. So this is a case of midgut volvulus with bilious vomiting. You have to rule it out almost at any age. And, the issue that always comes up, if it's green, it's a slam dunk. If it's yellow, it could be gastroenteritis or something else. You'll have to look at the clinical picture. But green under 1 month of age, you have to rule it out one way or the other. And 75% before age 5. But not all do. I had a friend whose uncle presented with midgut volvulus at age 80. So it can occur at any age, but presentation-wise, bilious emesis is the most common, and like our patient, lethargy, dehydration. I've seen it in toddlers too, in which they present with vomiting and intermittent abdominal pain, and you think it may be intussusception. But the good news is that ultrasound or color Doppler ultrasound can be incredibly useful here. So consideration for screening on some of these kids in which you want to rule out the most dire diagnosis, which would be this. So imaging wise, you can use fluoroscopy, upper GI. It really was the gold standard. You see spiraling around the middle mesenteric artery, or superior mesenteric artery, excuse me. I don't know where I was going with that, but superior mesenteric artery. And but it can be hard to do. You need to bring a specialist in to do it. And with the ultrasound, it's been shown now to be very sensitive and specific and may be the best option. And so what you see with the color Doppler, again, is that spiral sign. Some call it a whirlpool sign, or spiraling. And then abdominal x-rays, you can get it if you're considering neck, back, or necrotizing enterocolitis. Older patients sometimes get CT, and it can be diagnosed on that as well. And then workup, key things here, get your labs. These aren't critical. I would just say a type and screen or cross is critical, but imaging, again, upper GI or ultrasound, and ultrasound's probably preferred in this day and age. What I do very, very quickly is I get the surgeon involved. I would fluid resuscitate, NG tube for decompression, and then antibiotics, because many of these kids have microperforations at this point. So what's the outcome? I mean, obviously the child's very distended. Just a couple points here. I didn't bring this up earlier. I will say that a number of these kids have normal abdominal exams in the very beginning. This child does not, but very important to a normal abdominal exam does not rule this out. And this child was operated on and actually did well, had to be hospitalized for a number of weeks, however. And ultrasound showed the whirlpool sign, which is that spiraling. All right, let's do our next case. This is a bloody stool baby. We're going to have several with bloody stools and talk more about what that looks like. This is a 7-day-old born at 35 weeks, so premature via emergent C-section, presents with bloody stool and lethargy. When we think about bloody stool, what is the differential here? And you can see anal fissure, swallowed maternal blood, infectious diarrhea, milk soy protein intolerance, which we see much more commonly. Intussusception is not uncommon. Neck, based on the age, generally necrotizing enterocolitis presents within the first week of life. So this child would qualify there. And then malrotation midgut volvulus, we've already talked about. Hirschsprung's, early onset inflammatory bowel, and vitamin K deficiency. So this is a case of necrotizing enterocolitis, and this is where the bacteria invades the intestinal wall, leading to necrosis. There's gas formation in the intestinal wall, which creates this either targeting look in the bowel, railroad track look, but basically is causing pneumatosis intestinalis, which it is caused. And in severe cases, you get air in the biliary ducts. And 10% of cases occur in term infants. So just because it's a term baby, this baby was not. Remember, under 37 weeks is considered premature. And as I said, the majority present in the first really week of life has been my experience, but under 2 weeks. Here's some more x-rays showing the pneumatosis intestinalis. You see on the left, you see intrahepatic air and air in the biliary ducts. And again, this is pretty remarkable to see this pneumatosis intestinalis, which can be quite striking. I mean, ultrasound can be used. It's not perfect. We'll get into that in a second. Let me just talk a little bit about clinical presentation. It may present very nonspecific, so poor feeding, vomiting. You can have abdominal distension. Has been something that I see pretty commonly with this. Lethargy, dehydration, so things to consider, but again, it's nonspecific. So imaging-wise, you can see the pneumatosis intestinalis here. You can get a AP and lateral. I would probably get an ultrasound as well. Once you establish the pneumatosis intestinalis on X-ray, ultrasound may be less useful, but ultrasound really to rule out other abdominal catastrophes like midgut volvulus. So it's in this case, ultrasound is not a great test. So you get abdominal x-rays. We do our typical laboratories. You may want to get a lactate here as well, just because these kids can get septic. NG tube for decompression. You want to check for glucose for sure. I'd begin with normal saline and then quickly add a D5 normal. And then consult neonatology. Not all these kids are going to require surgery, of course, and there are specific indications for that. That includes frank peritonitis, so abdominal rigidity. The ones that I have seen, at least my personal experience, has been abdominal distension. They do have tenderness, but generally not rigidity. When you see the rigidity and frank peritonitis, if they are very acidotic, they have high lactates or portal venous gas, which is an indication clearly that there is perforation. So what happened with this one, this little baby, and this was posted online by a family, fluid resuscitation, the radiograph showed pneumatosis, there was surgical consultation, Amgen and Flagyl were given, and then eventually the child was able to eat on their own and went home. So pneumatosis intestinalis, an abdominal emergency, sometimes surgical, most of the time medical, that occurs generally under 2 weeks of life, but maybe even under a week. Okay, case 3. This is the hungry vomiter. Now this is a severe case of this. If you note, there is tenting. So when you pinch the skin, as it were, it doesn't immediately go back. That is very unusual. This is a sign of severe dehydration. And so a 4-week-old male presents with persistent non-bilious, okay, very important to say non-bilious here because that changes the differential, and poor weight gain. The baby's really hungry, but tachycardic and has signs of pretty bad dehydration, but still wants to eat. The peristaltic wave is pretty classic. So what that is that there is a peristalsis that occurs, but really stops. It goes across, but then stops at the level of an obstruction at the pylorus. So this baby's pretty tacky, respiratory rate is not bad, not hypotensive for age, pulse ox is good. So the key things here are going to be fluid resuscitation. I would get laboratories just to make sure there's no abnormalities, and there often is once you get to this state of severity. And then you want to check a glucose, and in this baby, the finger stick glucose was 25, so D10 would be given. And again, you want to consider the neonatal period, it would be 5 mL per kilo. So the differential for non-bilious emesis or vomiting is pretty broad. You can still have malrotation. You can see all the different things. Pyloric stenosis, I would consider under the first couple months of life. Typically, it's really under 6 weeks. It's not in the first 2 weeks because it takes a little bit for the hypertrophy of the pylorus to develop. So just be aware that this is a situation where it's typically not in the first 2 weeks, but can occur beyond that, and literally generally presents under 2 months. So you can see here hypertrophy of the pyloric muscle results in progressive gastric outlet obstruction. Sometimes see this more commonly in firstborn males, but it can occur in either sex. Presentation is vomiting after feeds, and what I say is, how do you define forceful vomiting? Well, I'd say if it completely clears the jammies or the onesie or whatever they have on, that could be forceful. Most of the time, spit up just drools on the front of their clothing, but if it literally goes beyond that, it's something to consider. What I've seen from a history standpoint is that the babies present with spitting up, and then it becomes more and more forceful. You can look for the peristaltic wave after feeding, and in olive, it's supposedly occurs, which is the actual hypertrophied pylorus. I've really not felt those. I think you really need to get in a situation where the patient's under anesthesia to feel them, but you'll have to send me a note if you felt an olive in the emergency department. Anyway, the classic laboratory abnormalities are hypokalemic metabolic alkalosis because they're vomiting up the hydrochloric acid. Ultrasound is the way to go, and I think we used to see a lot of these severe cases early in my career, but not now because the availability of ultrasound is so good. You can also use fluoroscopy, but I haven't used that in, I don't know, 40 years. But imaging wise, really the ultrasound is the way to go, and you're looking for the hypertrophied pylorus. For a lot of these kids, they look really well, and they're not tachycardic, they've been vomiting, but the parents are worried, and in those situations, I don't necessarily get laboratories. In this case, was severe dehydration, peristaltic wave, and tinting. 100% I'm going to get it. But in most of these cases, I just send them down for an ultrasound. And again, you might consider an upper GI if you're worried about alternative pathology. Again, with the ultrasound, I would do it a standard ultrasound and then color Doppler just to rule out midgut volvulus. And then monitor glucose, as in this case, with severe dehydration, this child can become hypoglycemic. And then you consult surgery. Now, this is not a time is bowel. Generally, you want to fluid resuscitate and admit, and then they can get their surgery the next day. You want to make sure that they're stable. So this child had some significant abnormalities, but was able to be fluid hydrated. They operated on and were able to go home in about 4 or 5 days. All right, here's another case. We're just going to move right through these. This is the listless child. And this is very, very common presentation of a condition that we generally see in children under 2 years of age. But this 15-month-old presents with intermittent severe abdominal pain. And sometimes parents will describe it as they just start screaming and they draw their knees up. And I had a shift where in the first 4 hours of my shift, I had 4 cases of this, which is intussusception. So I would be remiss, this child comes in listless, has altered appearance. When we think about altered appearance, what could we think about? And the mnemonic AEIOU tips I've used my entire career. Love it. It was developed by AAP and ASAP as part of the APLS, Pediatric Emergency Medicine course. And I really like it because it keeps your differential broad so that you're not going to miss anything. And you'll note that intussusception is the first I for children. And again, you'll see different conditions associated with each letter of the mnemonic, but I find this pretty typical and what you would see in a child with altered mental status as a differential. So this is intussusception. The most common is ileocolic. You can see older in life, it's generally a lead point. As an example, Henoch Schlangen purpura can result in intussusception. You see it in adults too, and again, it's generally associated with the lead point, but in these are more idiopathic, and again, when one portion of the bowel telescopes into another. And the most common presenting time is between 4 and 36 months. It's considered the most common cause of abdominal obstruction for children under the age of 2. The classic triad, I don't see classically. What I generally see is vomiting, intermittent abdominal pain, and lethargy as probably the most common presentations that I see. And about 75 to 80% will have occult blood or gross blood at the time of examination. So imaging wise, ultrasound is it. As we've gotten better with ultrasound, it has really mattered so much in my practice now. It's really changed the way I do things. And given that ultrasound is typically available in almost all EDs, this is fantastic. It's very sensitive and specific. And the abdominal X-ray can be used. You can see targeting, but in actuality, I find that it's not that useful. I mean, if there's a concern or peritonitis, you can look for free air or signs of perforation. Really, the treatment, the diagnostic imaging, everybody's using ultrasound. You could, if it's highly suspicious and the ultrasound is equivocal, consider doing an enema. But this is an enema air contrast or water soluble. It's considered liquid enema, is diagnostic as well as therapeutic. So I get an ultrasound, X-ray if concerned for perforation, radiology consult to send them down. Emergency physicians have looked for this themselves using bedside ultrasound, but I typically send down to the radiology suite to get the ultrasound, or it could be done bedside. And then there would be a need to consult surgery if there's signs of perforation or frank peritonitis. Otherwise, the kids can be discharged home after reduction and just a period of observation as well as a oral trial or PO trial. So air contrast is on the left, the water soluble with the iodine is on the right. We don't really use barium anymore. Barium can be used, but it has higher radiation, lower success rate, and higher complication rate. So we generally will use about over. They did a survey in the US, and I think 54% of the hospitals reported using air contrast. Another percentage used sometimes solely air contrast. Some use air contrast and the liquid enema, the water soluble with the iodine. So in terms of the success, it's my experience is really 95 to 100% successful. Perforation is not common at all, but recurrence is common. So you really need to, if a child gets sent home, we need to give them instructions about if the pain recurs, because they can recur. And generally, if they'll recur pretty quickly within the first 3 days. The other thing, if you've had an interception for greater than 24 hours, is puts you at higher risk. So this kid, after fluid resuscitation, underwent an air contrast enema, and intussusception was found and reduced. And then the lethargy quickly disappeared, and took the infant, really a toddler, took oral fluids and was discharged the following day, but could be sent home on same day. This is a great case. This I bring it forward. This was reported by some physicians at Brown. I mean, I've seen a lot of diapers, but if I saw this, I would want to immediately think about a blood transfusion. But this was a great case that was reported. A 6-month-old presents with pallor and bright red blood per rectum, with more than a clot, as far as I can tell, that I can see. When we generally think of bloody stool mimics, that looks just so compelling for blood. Obviously, you can do guaiac testing, but things that Play-Doh, antibiotics, certain drugs, dye ingestion, cake frosting, certain candies, beets, licorice, iron, and spinach, all have been shown to show either bloody or black stool. When we think about the differential, the most common that I see are anal fissures. You can see swallowed maternal blood, but in breastfeeding, obviously infectious causes and inflammatory bowel disease typically presents later, and then HSP can do it. And so something to really consider, something like that, this I'd be very worried. Typically it's painless, bright red blood would be a Meckel's diverticulum. And there's a rule of twos, which don't hold true all the time, I can tell you, is 2% of the population is twice as common in males. That part, most of the cases I've seen are males, 2 feet from the ileocecal valve, 2% complication rate, meaning obstruction, appendicitis-like symptoms, perforation, peritonitis, and then bleeding. Most are symptomatic before 2 years, although I've seen adolescents present with this, and 2 types of tissue, including actual ectopic gastric mucosa. So its presentation typically is painless GI bleeding. In this case, it was painless GI bleeding. And recurrent, you can see it. It can be a lead point for intussusception, and it can cause a diverticulitis like or mimic appendicitis. Imaging-wise, we use the Meckel scan. It's good sensitivity and excellent specificity. For kids, all the cases that I've seen with this are children or adolescents. And what it does is identify this ectopic gastric mucosa using pertecanate. It's a radionuclide scan. Angiography could be used, and then CT could also be used as a diagnostic. Typically, we would do the Meckel scan. That's considered the gold standard. So CBC, Quag studies, and Meckel scan, again, if available. If not, CT scan could be done. Transfusion for anemia, and to consult surgery for operative management. So this is, in this case, this is pretty bad. The patient was pale, but had bleeding, and ultimately required obviously surgical intervention. In this particular case, you see something unusual associated with an intestinal duplication cyst, but the one was Meckel's that we see in the upper left, and patient did well and was taken to the OR. So in summary, necrotizing enterocolitis presents under 2 weeks of age. Malrotation, typically it can be a month, but up to 5 years of age, although you can see it in adults as well. So frank bilious emesis should really make you concerned. Pyloric stenosis, most common after 2 weeks, but under 2 months. So between 2 and 6 weeks is really the sweet spot. Our patient was 4 weeks, very, very common at that age. I think 3 to 4 weeks is the most common presenting age. Intussusception, intermittent pain and lethargy. In the case, that shift I told you about with the 4 cases, the youngest was 4 months of age. That's the youngest I've ever seen intussusception, and then it just ranged from there. And I think the oldest was actually over 2. And then Meckel's diverticulum, most present under 2 years of age, but that's not universally the case, as with everything in medicine, it seems. But painless bloody stool is a hallmark of that condition. All right, I think I might have gone a little bit over. Please email me if you have questions, or join me on social media at mgauchihel. Thanks so much, and take care.
Thank you, Prof. Mariana. It is a very comprehensive review for all that cases can be present as non-traumatic surgery case. And this is very important and point mentioned by Prof. Mariana about how to approach and how to manage. Next and the last talk for before the break will be by Prof. Mohsen Said Najad. She will be speak about very important topic can be facing in the emergency department, how to be understanding seizure in pediatric patient, and a comprehensive approach for that patient. Welcome, Prof. Mohsen.
Hi, everyone. I hope you are having a great conference. It is my great pleasure to be here with you. And I'm sorry I couldn't be there in person. I'm going to pull up my talk here. Okay. So I'm Dr. Saidinejad. I'm a professor of emergency medicine and pediatrics at David Geffen School of Medicine at UCLA. I'm also the director for the Institute for Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation at Harbor UCLA. And I'm very excited to speak to you today about understanding seizures in pediatric patients. And I have no relevant financial disclosures. So just in terms of learning objectives, the goal is to understand the epidemiology and etiology of seizure in children, to review pre-hospital management of active seizures, to learn about emergency department management of children with status epilepticus, and to look at dosing and routes of administration of anti-epileptic medications, and also to discuss what is the decision point for emergency department, either discharge or admission to the hospital after the patient with a seizure has been treated. In terms of epidemiology, seizures are kind of complex. They're a heterogeneous group of neurologic conditions. On average, their frequency is about 5 to 7 cases in every 10,000 children. And of those children who've been diagnosed with seizure, epilepsy affects about 0.5% to 1% of all of them. So epilepsy becomes the most frequent chronic neurologic condition in childhood and a cause of many, many emergency department visits. For most part, etiologies of epilepsy are not known. However, in about 25 to 50% of the cases, some underlying neurologic condition can be found. If it were a CNS malformation that was congenital, if it was a result of a head injury, if there was infections within the CNS, some kind of a metabolic disorder, or other genetic factors, that may account for 25 to 50% of underlying causes of epilepsy in children. I also wanted to go over some definitions because it is important in a sense that we treat the seizure really based on what we feel that the problem itself is going to be. For example, status epilepticus used to be a seizure that lasted at least 30 minutes, but that definition has changed over the recent years. But now status epilepticus is in continuous seizure activity that lasts 5 minutes or more, and or is electrographically apparent on demonstrated EEGs, or any series of small recurrent seizure activities without return to baseline. So that's more of a newer diagnosis of status epilepticus versus what it used to be. Then the term refractory seizure, again, the timeline of refractory is not clear. However, refractory seizure is a seizure that continues despite using the correct and effective dose of at least 2 anti-epileptic medications. In terms of duration, there isn't any clear guideline of how long a seizure goes before it's called refractory, but if you seize more than 30 minutes, you start getting into the risk of irreversible neuronal damage, and that will be an important element that is associated with a refractory seizure in terms of how aggressive you have to get in trying to stop it. most common seizures that come to the emergency department are usually your general tonic-clonic seizure activities, where you both have the stiffening of the muscles and you have these fast rhythmic movements. In other words, we call them tonic-clonic, which is again a new terminology, which used to be grand mal seizures. Now it's tonic-clonic seizure activity. So that convulsive seizure is an important element of status, because non-convulsive seizures, they might be able to go longer without a problem, but convulsive seizures, 5 minutes is the place where you need to start thinking about interventions very quickly. Classification of seizures, which was developed by the International League Against Epilepsy, and this was published in 2017, is now based on how the seizure started. If it started as a focal onset, if it started as a generalized onset, or nobody knows where it started. In general, we say focal onset seizures are where you have some recollection, awareness, and level of consciousness, although you can have a loss of alertness and level of consciousness with focal onset as well. With generalized, what you're saying is that the patient does not have a memory of it, is not aware of it, and has a loss of consciousness. With unknown seizure onset, again, depends on what the cause was. So in this realm, you have both motor and non-motor that are involved in either types of these seizures. And another way to look at this is the classification based on the same International League Against Epilepsy. As you can see here, the generalized onset is the motor, which is the ones we're used to seeing, the tonic-clonic, clonic, tonic, myoclonic, etc. And then there's the non-motor general, which is absence seizures. So absence seizures are still generalized seizures, but they're non-motor. So it is important to consider that you should not have awareness during an absence seizure, no matter how brief it is. A specific category of seizures are febrile seizures. There's still a lot of information about febrile seizures that's not clear, but in general, febrile seizures occur between 2 to 5% of children between 6 months and 5 years. And this varies by region. There are some studies that looked at various regions within Asia, where as many as 12% of children in this age group have had at least one febrile seizure activity. So it does vary. It is the most common time of seizure that in childhood, and is one of the most common presentations of seizure that we see in the emergency department. Although the range is between 6 months and 5 years, peak years are usually 12 months to 18 months. And generally, these are simple seizures. They have low risk for any kind of epilepsy or long-term complications. The usual way to treat a febrile seizure is treat the fever that caused the seizure. So if a child is at a young age where they're at risk for UTI, they're at risk for bacteremia, then you have to work those up. But a lot of times, if the etiology of fever doesn't bother you, then the febrile seizure itself, unless it was complex or status, it should not be a problem. Also, if family asks you about that, typically risk of recurrence on average is about 25%. So if a child who's had one febrile seizure has a 25% chance of coming back to the ER the next day with another seizure activity. And because the most common is the first 24 hours after the first seizure. And I have to tell you, you probably know this already, but there's nothing as scary as watching your child seize. So I don't blame these families for coming to the emergency department and calling the ambulance and coming in every time their child has a seizure. But it is reassuring to know febrile seizures are not typically harmful and dangerous long-term unless they were long and atypical appearing. This is just a diagrammatic kind of look at first episode of febrile seizure, whether it's simple or complex. Bottom line, again, the red part here is the complex one, identifying the cause of fever. If you're worried about a serious CNS infection, you have to do LPs and you have to get different biomarkers. You have to do imaging, EEG. But this is one thing that was interesting that I had not seen before, that it actually has a risk of recurrence categorization. So you have 4 risk factors. One is the age. One is history of epilepsy or febrile seizure in the first grade relatives. first episodes being complex, or being in the seizure that happened in school or community attendance. So if you have none of these, you have 12% chance of recurrence. If you have one of them, then you have the average 25%. But if you have 3 to 4 of those risk factors, your risk of recurrent febrile seizures is up to 80%. And I'm not sure what the level of evidence here is, and I haven't seen other studies that corroborated this, but this is a very interesting finding that I feel like if I have more evidence with, I'm going to start quoting to families. Now let's switch gears a little bit and talk about pre-hospital seizure care. What do paramedics do when they get called to a scene of a child that's actively seizing, and what should be their approach to management? So this is based on looking at the various level of evidence. So the following that I'm going to tell you, they all come with the highest level of research evidence, which means the research that was done is high quality research, probably large scale, multi-center, and probably has some randomized control elements in it. And that high evidence says that the first medication that should be given in a pre-hospital setting is midazolam, given as an intramuscular dose, particularly if there's no IV available. The initial dose, however, needs to be double what the IV dose is. So it should be 0.2 milligram per kilo with a maximum dose of 10 milligrams. So once you hit 40 kilos, you've maxed out. Above that, you just get 10. The alternative to that is a dose of intranasal midazolam at the dose of 0.2 milligram per kilo, again with a maximum of 10. So IM and IN are similar. And if there is an IV established, then your first dose could be IV or IV midazolam or IV lorazepam at a dose of 0.1 milligram per kilo. But that one maximizes at 4 milligram for the lorazepam. So midazolam we can give up to 10, but lorazepam dose maximizes at 4 milligrams. So in the beginning, there was some hesitancy in accepting intranasal dose of midazolam as equivalent to a intramuscular, especially there are studies that looked at the fact that intranasal midazolam causes more redosing. But a lot of those studies were based on the 0.1 milligram per kilo, not the 0.2. But there is still more evidence that's favoring intranasal midazolam as an equivalent to intramuscular dose. So that we're getting there, but right now there's still a question of whether intranasal midazolam causes you to have to give more doses. And if an IV is established, lorazepam IV can be good for using an active child. One of the things I like about IV lorazepam is that it does last longer, and therefore it has a longer potential for keeping somebody seizure-free. However, IM lorazepam is not as effective. So if you have to give it intramuscular, the problem with lorazepam is that it takes too long to work, has a depot effect, and is not really good for immediate stoppage of seizures. Another alternative, which is level B evidence, this is not as high as level A evidence, but level B evidence that says buccal midazolam can also be used as a alternative. An important consideration is that if you give one dose of the preferred medication, which in this case would be IM or IN midazolam, and the seizure continues, you can still repeat that first-line drug. You don't have to go to a second drug, I'm sorry. You can use the same medication a second time so that you don't have to jump off of that first line just because you had to give multiple doses. So for the pre-hospital transport, obviously a patient needs to be on a cardiac monitor and needs to be monitored the entire time that they're being transported. They should give supplemental oxygen. As a matter of fact, a lot of the patients that come to our emergency department, they are either on some kind of an oxygen by nasal cannula or by a simple mask, or somebody has that bag mask sitting on them and getting free flow oxygen coming through it. So it's a very common thing for paramedics to give oxygen. Also, it's important that if the patient does not have active seizure anymore, then you may not necessarily have to give any additional dose of medication and just transport the patient. In general, again, this is a level C, kind of the lowest level of evidence, but there is some studies that looked at febrile seizure being any different from afebrile seizure, and the recommendation for paramedics generally is to treat them the same, use the same kind of medication as a first and second line. Blood glucose check used to be very, very routine, and everybody did that. But more and more agencies who are transporting patients via the paramedics are not doing routine blood glucose. Again, the use of routine blood glucose is a level C in terms of evidence. And the same thing with cooling measures, cooling blankets and things like that. There is not tremendous evidence that they're going to be useful. Now, for the medication that are currently being given, there has been some concerns, some papers that are coming out and have been published in the last few years that perhaps when paramedics use the weight to give the 0.2 milligram per kilo dosing of the midazolam, perhaps that weight is not a good way to give the dose, because we're noticing a lot of patients who need multiple doses of benzodiazepine en route. Many of them come to the ER still having active seizure, and even the ones who have stopped seizing, there's a number of them that begin having a second seizure in the emergency department. So the question is do we have the best way to dose our medication? So there's currently a study in progress by the very large network of Pediatric Emergency Care Applied Research Network, also known as PECARN. The study is called PEDidose. It's Pediatric Dose Optimization in Status Epilepticus. It involves 20 national centers. My center is one of them. Most of the centers are major children's hospitals in the United States. The research question for the study is, does the pre-hospital use of an age range-based dosing improve time to seizure cessation and decrease in seizure recurrence? In other words, should we use age range rather than weight to decide the dose? And this is one of the little infographics that we have on the PEDidose study that actually looks at this. As you can see, for example, patients who are greater than 12 years of age, they get a straight dose of 10 milligram. We're not going to do milligram per kilo. They get 10. After between 6 and 11 years, they get 5. After 17 months to 5 years, they get 2.5 milligram. And we are currently doing the dosing for a 0 to 16 months as a milligram per kilo, but this is soon going to change. We're going to change that to 1.25 milligram for a straight dose, so you don't even have to use the Broslow color-coded weight in order to give the midazolam dose. So that is kind of the study that's currently in progress. And what happened was these centers, they start by doing the old way, which is the weight-based dosing, and at some point, each center is going to get randomized to switch over their protocol to this one that you see here on the screen now, which is the age range based. And our center already got randomized, I think, a while back. So understanding seizure in the ED is a very important thing. Upon arrival of the patient to the emergency department, the first question is, if the patient is not seizing anymore, was it actually a seizure or was it something else? And if it was a seizure, was it a prolonged one or was it a brief one? In other words, did it at least last 5 minutes, meeting the definition of status epilepticus? Also, if the patient is currently actively seizing, or are they post-ictal, or are they back to baseline? So an evaluation of their level of consciousness and looking for any signs of convulsions. The other thing to know is, was this the first time the patient had a seizure, or is it a known seizure disorder? Because that also affects the way we're going to manage this. Fever and many other etiologies of seizure need to be looked at. So for example, a patient that has a seizure who's very hot to touch, is it a febrile seizure or is it fever with their seizure, meaning that they had a seizure disorder that the presence of fever increased their threshold of having a seizure baseline that's activated? Is there any kind of metabolic or genetic factors related to this seizure? And this you have to work up sometimes in the emergency department. Is this patient somebody who is ingested, maybe older kid, ingested, toxicology related, or withdrawal from some substance? Is this a patient whose dose of seizure medication has not been adjusted in a while, or they forgot to take, or they're not compliant? Is it a medication reason? Is it perhaps a serious CNS infection? Is there a structural abnormality in the brain, or is it oncological, a mass? Or the patient have a trauma, and this is a post-trauma. So the etiologies of seizure are extremely diverse. First place to start would be, is it first time or not? If it's not a first time, then is the seizure consistent with whatever known etiology that the patient has for their seizure? One area that's extremely challenging, at least to me, I've done this for like 22 years. I'm still kind of not 100% sure every time upon arrival of the patient with the ED. Are they still actively seizing or are they not? Because there's no outward sign of convulsion. They look like they have stopped seizing, but I can't always tell the difference between somebody who's subclinically still seizing versus somebody who is postictal. Because unless you had your gold standard, which is you have an EEG, you're monitoring the patient, you see seizure waves or not, otherwise it will be very hard. So some potential ways that one may look at this that might be useful. If the patient, for example, is tachycardic or tachypneic, they're probably more likely to be still having subclinical seizure. But oxygen saturation is not going to help because in both cases you can have oxygen saturation that are low. You can check the jaw, see if the jaw is clenched and hard to open the mouth, or is it relaxed? Because if the patient is subclinically seizing, it's more likely their jaw is kind of clenched. They may even have a fixed eye deviation. Their muscle tone may be hyper. And another thing to do is to see whether this is, if there's a patient in between seizure activities, chances are this is still subclinical seizure versus a patient who stopped seizing a while back and hasn't continued seizing. That might be, again, a person who's postictal. But these are just some potential ways to help you. They don't always necessarily represent 100% certainty. It's just some of my own experiences that these things do sometimes help. But the best way is to actually do EEG monitoring. For the PD dose study that I told you about, one of the things that we're doing is upon patient arrival to the ED, our goal is to try to apply a portable EEG device to them within 20 minutes of arrival. It's called a Cerebell device. And we're comparing our own physician impression of whether the patient is actively seizing or post-ictal with what the Cerebell says. And I'm really interested to see how we do because this study is still going on for another year or so. But after that, it'll be interesting to see how often are we in agreement with the EEG recorder that the patient is either actively seizing or they're post-ictal. So in terms of initial management of the patient with seizure, same, the usual things, monitoring, oxygen as needed, give the first dose of benzodiazepine as early as possible. If they're having fever, give them some antipyretic, check their electrolytes, blood gas, LFTs, anticonvulsant drug levels. If they're already on anticonvulsants and there's drugs that the levels come back quickly, then you can do that. Some of the newer drugs, my institution, for example, there are send-out labs and it takes several days, so they're not going to help us with any kind of management decision. But certain, one of the medications, we do get levels back and we can decide whether the drug levels are too low and potentially cause of the problem. This is from one of the documents that I'm going to share with you later, but again, it's just a way to summarize what I just told you. The only thing I hadn't told you before is the glucose check. If the paramedics get a glucose en route and it's low, that there's a way to treat it with D25. But like I said, not all agencies are checking glucose all the time. So, but if you have glucose, that's one of the ways to do it. One other thing that I want to mention here is that we are trying to stop the seizure within 20 minutes with the first 2 doses of benzodiazepine. So we don't want to really exceed more than 2 doses of benzodiazepine before we start heading into the next level, maybe the second line agents. So if paramedics already have given 2 doses of benzodiazepine, it's kind of hard to justify giving yet another. Sometimes we do 1 more dose in the ER, but chances are because it's already exceeded 20 minutes from when the seizure started, it is probably best to move on to a next agent. Speaking of next agents, there are 5 agents that we use in pediatrics as a second line. The first 3 are the ones that we use most often, and these are the ones that have very similar efficacy. There was this study that was published in New England Journal of Medicine in 2019. We actually looked at levetiracetam, phosphonatoin, and valproic acid and found that the absence of clinically evident seizure and improved responsiveness at 60 minutes was very, very similar, almost identical. But bear in mind that the dose equivalence is 60 of levetiracetam, 20 per kilo of phosphenia, and 40 milligram per kilo of valproate. Not the same exact dose, but dose equivalents are 60, 20, 40. And this was, like I said, published 5-6 years ago. So in terms of ER intervention, every time I have a patient who has a seizure activity, if it's not a simple febrile seizure, I always check with the neurologist, and sometimes the neurologist is at a different institution, so we just call them. I want to keep the patient who had a seizure on a cardiac monitor for as long as I'm still worried about more seizure. I have to worry about additional drug doses of the antiepileptics, whether or not I'm going to a second-line agent, whether I'm going to a third-line agent. Consideration is that phosphenatoin or levetiracetam usually run over 15 to 20 minutes, so I don't get immediate relief from them. I have to wait until they run completely before they work. So you have to concern yourself with what if the patient's still actively seizing. And there's some studies that are in the horizon looking at potential agents between the first and the second, like maybe agent 1.5. And we wonder if ketamine may be that agent, but that is still research to come. This is not now. We also have to make a decision, is this patient dischargeable or do they need to be admitted to the hospital? And then we have to work and worry about refractory seizure, which may need much more decisive IV infusions of antiepileptics and therefore guaranteed admission. Refractory seizure, usually in general, you've given your 2 doses of benzodiazepine, you've given your second-line agent already, you're about to start your third-line agents, which are phenobarb, ketamine, propofol, ketofol, and usually they require airway protection, although many of our faculty, if they're using ketamine less than 1 milligram per kilo, or they're using phenobarbital less than 5 milligram per kilo, they tend to not manage the airway for that low dose. But if you're going to infusion and drips of midazolam, pentobarbital, ketamine, these cases require admission to the intensive care unit usually, and especially with pentobarbital coma, and these patients are intubated usually. First-time seizure, or if there's a change in the type of seizure in a person who already has a seizure, may need an MRI or outpatient EEG. The question is, does it need to be in the hospital or not? Sometimes the patient is well appearing enough and they can go home, so that can be done as an outpatient. Upon discharge, do we need to adjust the medication? Do we need to start the patient on a new medication? And those are all decisions that we make with neurology. And each patient with a seizure, we would like to have them have a outpatient neurology follow-up so that they're safe and planned. In terms of ER disposition, it's pretty straightforward. Patients who are stable and have no further seizure activities, had no abnormalities on their labs or imaging, or they were simple febrile seizure with no other considerations, have a good plan for discharge, have a good follow-up. If they need a medication prescribed, it's already prescribed, they should be able to go home. However, patients who've had complex, multiple seizures, very, very young, under 3 months, have had abnormality in the exam or labs or imaging, those who had to do intervention in the ER, such as manage their airway or aggressive oxygenation, or they need to have stat MRIs, or they need inpatient monitoring, of course, those need to be admitted. This, in terms of research, I want to share this with you. This is something we've been working on as part of the EMS for Children Innovation and Improvement Center. There are a series of pediatric education and advocacy kits, and we have one specific with status epilepticus. There's the QR code there for you there. There's a bottom line recommendation to the left and an algorithm to help you manage pediatric status epilepticus to the right. These are all some of these elements I already showed you separately, but these are extremely useful. And these are one page just in time. You can print them, you can make a poster out of them, you can have a pocket card. These are really, really helpful to have. And just to summarize, seizure is a complex neurologic condition, has many different etiologies, so that needs to be investigated. Febrile seizure is a common etiology, may not be a problem unless it's a complex or is an atypical looking one. Pre-hospital wise, midazolam is the first choice. Give it either intramuscular or intranasal as a first line. Try to do decision making to a second line agent once you have used total of 2 doses of benzodiazepine. That's the time to go to a second line agent. Patient who has had a seizure activity doesn't always automatically need to be admitted. However, for those who you're sending home, the consultant needs to be informed. They need to weigh in. They need to be able to follow up with the patient in a timely fashion in order for the patient to be dischargeable. And that's the end of my talk. Thank you so much again for your time and for your attention. Please feel free to reach out to me if you have any questions. And looking forward to having the rest of your conference be excellent and enjoy the rest of it. And please, again, reach out to me if you have any questions. Thank you.
Thank you, Prof. Mohsen. It is really an excellent talk about how to deal with that seizure in the emergency department. Now, this is the last talk before the noon time. So we'll go for break for lunch and prayer about 40 minutes. Yeah, around we'll be back at 12:30. We'll start afternoon session. If you have any question, please, you can address your question in the question and answer box. You will try to answer that question. Thank you for listening. We'll be back, inshallah, at 12:30. Thank you.
بسم الله الرحمن الرحيم. We're going to start, inshallah, the second session, afternoon session, for the second day, inshallah. Also, we have a great speak from Dr. Mohsen Saeed Najad, that is from University of California, Los Angeles. He will speak about understanding of seizures in pediatric patient, a comprehensive approach. Welcome, Dr. Mohsen. I'm sorry, we're going to modify the name of the lectures. It's Dr. Todd Chang. He'll speak about simulation training in emergency medicine. Welcome, Dr. Todd.
Alrighty. Hi, everybody. Thanks for letting me talk about simulation, which is one of my favorite topics in emergency medicine. I'm Todd Chang. I am in pediatric emergency medicine at Children's Hospital Los Angeles under the University of Southern California system. And I'm also the medical director for the Simulation Center at Children's Hospital Los Angeles. It's a small in-hospital simulation center. Always happy to have guests over if you ever visit Los Angeles, California. And I'm the medical director there, entitled the Las Ventrinas Simulation Center, named after our donors that helped us start the program way back in the 20-teens, but finally built after COVID in 2022. First and foremost, many of you are probably familiar with clinical simulation. Many of you do it, but it's important for this talk to essentially recharacterize why we do simulation. And I really want to assume that you know what simulation is. We'll go into some of the details, but really I'm here to try and change the frame set of why simulation is important. So I get asked this question a lot, especially if I need to ask for money, for resources, for people's time. Why clinical simulation to justify the simulation in healthcare? I never actually talk about training. I never talk about simulation education. That's always inherent or attached to the idea of simulation, but I actually answer in a very different way. And that is, there is essentially always the difference between work as imagined, what we think we are like when we are performing our best in the emergency department, and work as done, what actually happens. And there's almost always a gap, a big difference between what we think how good we are performing and treating our patient, and how actually we are doing. And oftentimes that gap is invisible. We don't even know that we're actually doing this until it's revealed either with the bad patient outcome, which we really don't want, or a suboptimal bad simulation outcome, which is not as scary. And that's where we tend to learn and change systems based on what's happening. So I approach simulation within this domain between the difference between work as imagined and work as done. And so when we talk about different categories of simulation, then we have all sorts of different ways of simulating, which we'll talk one by one, and you can combine it in hybrid situations. The first one here is the mannequin-based simulation, which I think most of us understand. Some of it's low fidelity and high fidelity. Sometimes you get big rooms, and other times they're not very complicated mannequins as well. And it doesn't really matter the type of mannequin, that's as long as it's chosen for the right purpose, the right learning objectives, the right system objectives. So this is what we're mostly familiar with in the healthcare space with mannequin-based simulation. On the other hand, there's also screen-based simulation, also termed digital simulation, which is getting more and more common, as especially since the 2020 lockdowns with COVID that made training very difficult and different. So screen-based includes video games, types and serious games, and other items that are on virtual reality. And sometimes when they're projected as patients, like in this example, they become standardized patients. Occasionally we'll use human actors, but you can have digital avatars and human actors as standardized patients that are standardized alone, or in the digital form, which could be the screen-based simulations in virtual reality. The fourth version is haptics or virtual task trainers, VTTs. These are ones that are usually coupled with some sort of haptics or surgeries and procedures. And these are also important to think about when we're thinking about simulation. They can be digital, they can be wholly analog, or they can be somewhere in between. And then finally, we actually classify resource management simulations as a particular form and component or domain of simulation. On the right-hand side is a digital simulation of Ebola and how electronically we can actually see what happens with different resource constraints. On the upper left is a mock emergency room. So a brand new emergency room that has not yet been built is recreated in a warehouse, and all sorts of scenarios are practiced in that scenario. And this allowed the team, this was actually in Seattle Children's up in Seattle, Washington. That's the northwest corner of the United States. They were building a brand new emergency department, but they wanted to test out the layout and the architecture and the placement of everything before they actually brought it to the ground. And so they built this fake pretend simulated emergency department in a warehouse and had some of the most challenging scenarios. So mass casualty events, no electricity events, fire events, and really tested the system. And they were able to solve many problems that would have been a huge problem had the building been already there. And so these simulations actually advised the construction and the architecture folks to recalibrate many of the things that they thought were going to work, which has been great. There's definitely advantages to simulation. The 4 big ones are standardization, zero patient harm, logistic, gravity, measurement, and we'll really talk about these one by one. I think most of us can really encapsulate them in our heads on why simulation can be advantageous. And it's particularly good for low frequency, high stakes events or problems, things that really you're not going to see very often, and they're really important. Standardization is a very key component of simulation, especially if you have a very large hospital, large number of trainees, large number of physicians, nurses, and large number of teams with people coming in and out and in and out. You really want a good standard education through everybody. And simulation is the closest way of delivering the standard types of patients, standard types of procedures, and the standard types of situations for all of your learners. The second is kind of the obvious one, zero patient harm. Here's an example of a chaplaincy simulation where folks in the religious side have to deliver services to a family who's lost their family members. So we actually have a family member, which is a mannequin, go through a medical scenario, usually cardiopulmonary arrest. The medical team finishes. The patient unfortunately dies, but then the next scenario begins immediately in the simulation where the religious personnel come over and start delivering the last rites and all the ceremonies that's required for whichever religion that they're part of. And so this is actually a wonderful way of really showcasing and practicing the human side of both the medicine and the art of death and death rituals using zero patient harm. Zero patient harm also applies to other components, including veterinary simulation. This is called the haptic cow. In order to examine cows to make sure that they have a wonderful offspring and that without any diseases, and make sure the health of their pregnancies, the farmers and the veterinarians must learn how to find out how the infants and fetuses are doing through a manual exam, essentially, with their hands. It's very difficult to practice because you don't know it's very rare to have an abnormality to detect. So this is called the haptic cow on the bottom left, where you can actually place your hands and you can feel different versions of in utero problems of the birthing calf. So again, zero patient harm, no matter who the patient is. Finally, logistics and rarity. Simulation is used for rare but devastating events. They can be massive, they can be small. And in pediatrics, especially pediatric emergency medicine, many of our high stakes events are extremely rare. So we would call them unicorns. They're very difficult to find out in the world. And so the simulation allows you to have a best proxy. It's not the most perfect one, but it is the closest thing that you can do to make sure that you practice and see the unicorn enough. And finally, there's measurement. During simulation, you can place sensors, you can record things, you can ask people more questions than you can in real life, in real patient scenarios. And simulation enables much more data to come in about the performance of the medical care that you're delivering. And this can be in the forms of electronic items, this can be in the form of actors who portray patients who are trained to give you feedback and how to tell you about how their character felt. My character felt that there were 2 other medical problems that were being ignored, and they're able to give that feedback because that's how they're trained as actors. And then finally, with digital simulations, everything is scripted and pre-programmed, especially when we're not quite in the artificial intelligence era, and they can actually be used to measure exactly what you're doing. Eye contact, eye gazing, sympathetic changes, and all sorts of other data that normally you would not catch in a regular patient care. So how do you know that a simulation is effective? This is a big one that I get asked all the time. And it's not easy to show that simulation is effective. It's also not easy to show that it's cost effective, but there are smaller methods of doing it. I want to spend a little bit of time here before the end of the talk to really try and answer this question by introducing a paradigm shift. So typically, most of us who are in simulation education really understand simulation in this way. You have a student, a young student, old student, doesn't matter, who goes through some sort of simulation. Maybe it's a serious video game, maybe it's a mannequin-based simulation, maybe it's through actors. They then become smarter, they gain a new skill, they're better, and they encounter a patient. And because they are better, they have the skill or they have the knowledge, then the patient improves and you reduce mortality, you reduce morbidity. And this is how traditionally we would think about education and simulation. It's really about the learner improving their skills, and those skills get used on the next patient. I am here to argue, even though I've been doing simulation for, 17, 18 years, that this is no longer the way you need to think about simulation. This is not how simulation works on the healthcare. Instead, you should really think about simulation as the system of care. So instead of one simulation, you're thinking about an entire program or curriculum for simulation across the entire hospital or multiple hospitals, and all sorts of different types of simulations, which includes all the modalities that you have access to over months and years, which then improve the system, not just one unit or one person, but an entire system of care. Then this system is then introduced to a large number of different types of patients and patient scenarios, which then improves care over time. So instead of thinking of simulation as one person at a time, I'm encouraging people to think of simulation as entire systems of programmatic change. And this is a big paradigm shift for a lot of educators and teachers. We love talking to new students and helping them learn new things. We enjoy doing that as educators. We find good fulfillment as mentors and teachers. But we really don't get very far with simulation if we think in that level of one learner at a time, or even 2 or 3 learners at a time. Simulation works best and has best evidence by incorporating it at the program or system level. And I'd like for everyone in this talk to really think about how this can be expanded longitudinally with more programs, more disciplines, more specialties, longer periods of time, and longer periods of seeing effects and evaluation. That's where the investments will be. So here's a couple of articles to really spur your thinking. We know that simulation-based training works, but really the simulation-based training over a long, repeated period of time is exactly what makes the changes. So in this particular case, we actually could address level 1 outcomes, which include satisfaction, confidence, lack of anxiety for rare procedures and systems. And this is something that we tried with pediatric trauma resuscitation, where we started on a near monthly basis. The first couple of times was okay, but it really got to year 1 and year 2 before we started seeing better and better confidence and less anxiety over the trauma patients that we saw. So this is one of our trauma simulations that we used to do. This is during the COVID era. As you can tell, everyone's still wearing masks. And with these, we had multiple different people come each time. And over time, the entire system started improving. Again, 1 or 2 simulations will never cut it. It's really about the program that you're improving. Here's one that's closer to home. This is an effective pediatric mod code simulation program. Again, not just 1 or 2 on resuscitation skills and team performance. So now we're no longer measuring just anxiety, confidence. We're really seeing how they actually do in terms of team performance, resuscitation skills, and over time for every single simulation that they do, even if they have new people that join in, the entire team performance starts increasing and increasing. So you can see on the left-hand side, the orange CPR initiation time gets faster and faster. So it goes down appropriately over the first, second, third, fourth, fifth, sixth simulation. And the same thing happens with team performance score, where it increases relative to the number of simulations that they do. Again, these are different people, different learners every single time. It's really the program that's pushing overall system change. And on the right-hand side is the same type of graph, time to epinephrine over the number 1, 2, 3, 4, 5, 6 simulations. And each time they get better and better no matter what. And finally, this translates to true patient outcomes. This is the similar Code program where they were doing monthly and or near monthly programs for pediatric residents and pediatric teams in a hospital. This is a University of Michigan. And over time, the actual survival rates of the patients related to mock codes actually increases throughout the year. So this was a 4-year endeavor where they tracked outcomes. And as long as the mock codes kept going, the incremental progress of improving survival rates of the patients was very evident from this paper. Yes, of course, there's plenty of other things that the hospital is doing to improve care, but this is fairly correlational and associational. It's not just the education, it's the fact that the program exists, the program grows. And as each resident and physician takes the courses, then the entire culture starts changing. And that's what we want as the simulation program. Again, not just 1 or 2 simulations, even though we enjoy those. Think of simulation as a program of improvement. And so this is the big message before we start ending. Simulation is effective at the program and system levels. And I really want people to start thinking about simulation as a giant program, even though from a day-to-day process, it's really about each scenario, and we write each scenario for many of our educators in emergency medicine. So the programs that we do really matter, and you want to have a nice variety, but with the same type of overarching philosophy of making sure that people learn, they come back, and they come back and learn something new every single time. So on the left-hand side was our Ebola and special pathogen workshops. On the right-hand side is preparation for an ECMO training that's here. Here's a mass casualty event training that we've also done. This is the basement of the entrance of our emergency department where people can actually rush in if they need to for mass casualty. We've also started launching some programs that use digital simulations or screen-based simulations. This is a collaboration of a simulated pediatric emergency department called Vital Signs that's available and commercially from our producers. Let's see, we also introduced our virtual reality training programs, especially during COVID when we couldn't have all the learners in the same place. We started, so this was started in 2018 before COVID, and it stopped for a while, and then we figured out how to actually launch it as well. And our VR program currently subsists as an adjunct to many of our mannequin-based programs as well. So a lot of the research that I do is on the VR side of things. And then this is our simulation center called the Las Matrinas Simulation Center. We have enough of our academic work centered here that we are open to having lots of delegates and visitors from different countries and universities. We even have an international program for observers who want to come and watch and do research with us as well. And then finally, while simulation is amazing, just because you can doesn't mean you should. There are plenty of things that you don't need simulation for. There's lots of things that you can do lectures or just watch real patients for. Just because you can simulate doesn't mean it's cost effective to do it. And again, when you're building a program of simulation, there are many other programs at your hospital, your residency, and your training programs in emergency medicine that are probably just as good at what they do. And so really think about your simulation program to improve care and improve patient outcomes, but at a programmatic level that complements and works with everyone else. So thank you for your time. This is my email if you have any other questions.
Thanks a lot, Dr. Todd, for this exciting lectures. And now we'll have another very exciting lecture about my child has a rash. Is it dangerous? Our speaker is Dr. Yusuf bin Amer. He's a chairman of the Department of Dermatology at King Faisal Specialist Hospital, Research Centers, Riyadh in Saudi Arabia. MashaAllah, Dr. Yusuf, he did training in University of Toronto and McGill University Hospital. And he's right now. He's right now doing also associated professor at College of Medicine at Al Faisal University, and plus he's the chairman of Department of Dermatology. Welcome, Dr. Yusuf.
السلام عليكم وأسعد الله مساءكم بكل خير. Thank you for everyone. I would like at the beginning to thank Dr. Al-Fifi for inviting me for the second year to talk in this group about some dermatological manifestation and diseases that are common in pediatric emergency. My name is Yusuf bin Amr. I'm dermatologist certified by the American board and as well as the Canadian Board of Dermatology, as well as I'm sharing the department at King Faisal. So it's very important to know how to identify an important skin eruptions, and then when to manage in the emergency room, how to manage, and when to refer to either to pediatric dermatologist or to the family physicians. I'm going to go through a very common cases in our daily practice that you will see it more familiar with them. As dermatologists, we are more visual people, so I will depend more on the pictures to seek your attention. So the first one is a 3-year-old boy with this rash. It started 3 days after low-grade fever with runny nose and cough. This is a disease that is sometimes we see it every now and then, not that common because of the vaccination. And this is the measles. And it is characterized by this rash. And if you examine the buccal mucosa, you will see these are complex spots. These are the white or pale area that's surrounded by erythema. And it seems in these cases. And this is differential diagnosis. You should keep it in your mind. If there is a fever, features of upper respiratory tract infection with exanthem, and there is involvement on the mucosa, just keep it in your mind. Not everyone is vaccinated, and we have some breakout, for example, in the US about the measles as well. So it's very important to remember that measles outbreak can happen in any countries. And in 2024, there was an outbreak in Philippines, and this was reported and published about that outbreak. So if you have a fever, cough, which are the features of upper respiratory tract infection with a skin rash, and you examine the apical mucosa, you have this enanthem or complex spots, you think about the measles. And the vaccination is very important. Don't assume everyone is vaccinated. So some people, they are still not vaccinated. The good thing about our vaccination program that it is mandatory. All kids and children in our country that they are vaccinated with these vaccines. The next one is very common. A 2-year-old boy with the fever and skin eruption. If you are lucky, you're gonna see all the 3 features all together. Hand, there will be like small papules, sometimes with vesicles. Also, there will be involvement of the feet, as well as the oral mucosa. So this is the classic hand, foot, mouth disease. And we see it is very common, especially with the change of the seasons. And it is very common to have an outbreak within the same class in the school. Do we need to have an isolation? This is a contagious, and the infective period is maximum within the first week. So the child with the fever and has been diagnosed with hand, foot, mouth disease, he should be isolated for 5 to 7 days till all the features are improving. The problem that the infectivity is also start before the rash appears. So sometimes we have an outbreak despite that the skin manifestation not clear. If you see the vesicles, if you are lucky and see the vesicles on the palms, these vesicles, they are not very circular. You see, these are conical shape. So this is one of the characteristics of the hand, foot, mouth disease on precise clinical examination. If you look at the palms, you will see these vesicles are not very circular. They are conical shape. So, and this is we call hand, foot, mouth disease. Is there any special population they are more prone? Yes, for example, atopic dermatitis with severe atopic dermatitis, they can have coxsackie, the same thing as eczema herpeticum, where you have a herpetic infection on the top of atopic dermatitis. We can have the coxsackie virus on the top of the atopic dermatitis as well. And as we mentioned that if the child has hand-foot-mouth disease, he might be an immune against this type, but other serotypes, he's not immune. This is why sometimes we have more than one attack because he was infected by this specific type, this specific Coxsackie type, and the next time he was infected by another type. So the fecal-oral transmission and direct contact are the primary transmission routes, and it is most contagious within the first week. This is why when you have in the class, there's a child diagnosed with the hand-foot-mouth disease, he should be absent for around 5 to 7 days. Hand-foot-mouth disease involves the 3 sites, usually in up to 2/3 of the patient. However, in around 20% of these patients, they have only oral mucosa, and this will make the diagnosis more difficult because you think also about herpetic infections as well as herpangina. Though we're going to see the difference between herpangina and hand-foot-mouth disease in the oral mucosal involvement. Hand and foot lesions without oral involvement can happen in 10%. Just open your mind that there is some cases that you will not see the classic features. What about the parvovirus infection? This is the parvovirus, or the 5th disease, and it is characterized by the erythema on the cheeks, we call it slab cheeks, and sometimes with the lacy pattern on the trunk. And we see this one sometimes we have to be very careful in people with sickle cell disease or splenemia, where they do not have a spleen because either they have sickle cell disease or they have splenectomy. And these cases, you have to be very careful because parvovirus disease can be like fatal. And also during pregnancy, especially in the first trimester. So the first disease, as we mentioned, is the measles. The second disease is bacterial infection, scarlet. The third disease is rubella. The fourth disease is not anymore exist. The fifth is erythema infectiosum, which is the parvovirus or slab cheeks. And then the sixth disease is roseola infantum, which is characterized by fever and then subsided, and then the rash will appear. It's very common to have macropapular rash, and here you will think, oh, is it a viral induced or it is a drug induced, especially if the child has taken like some painkiller, for example, morphine or something like that. Generally, sometimes the differentiation is very difficult, but there is some features that might help. For example, drugs eruption, for example, usually start on the trunk, while the viruses usually in the cephalocaudal distribution. Moreover, in viral, they will have conjunctivitis, upper respiratory tract infection features, while they are lacking it in the drug, except if you have extensive drug reaction. Itching, we see itching more in the drug reaction, while in viruses, they are less. So if you have a child with macropapular rash that is not itchy, you have to think also about viral exanthem. But if the rash is itchy and there is a history of taking of medication, and there is no evidence of any infection going on, then probably it is a drug induced. These are ulcers which are on the posterior part of the oropharynx in the soft palate, and these are herpangina. So herpangina, they involve the posterior part of the mouth oral cavity, in contrast to hand-foot-mouth disease or herpetic infection, where they are anterior. So this is one of the differentiation features that hand-foot-mouth disease and herpetic stomatitis involve more the anterior part. Herpangina involves more the posterior part. Does it differ in the treatment? The answer is no. It's the same treatment with conservative or symptomatic therapy. Varicella. Do we still see varicella? The answer is yes, but it's not very common as it was in the before. So sometimes what we see, we start to see a modified form of varicella. So we don't see very common in the children the classic varicella with full brawn. We see sometimes milder cases or atypical case of varicella. Though sometimes also we see shingles. We have seen some cases of shingles or herpes zoster without a history of a clear varicella, but there is a history of vaccinations. So varicella in the era of vaccination, they are milder and less frequent in children less than 10 years because of vaccination. And we have seen more cases that happened after 10 years of vaccination. One of 4 studies has shown an increase in zoster incidence after varicella vaccination in the United States. So if you have a zoster in a child, this is maybe not because of the immune system. This is because he had a varicella vaccine and might have a zoster without a classic or typical zoster, typical varicella. What about if you got a blisters in children? The first question you will ask yourself, are these blisters acute or chronic? Are they acquired or hereditary? If it is hereditary, it's why differential diagnosis. If they are acquired, then you think, is it acute, just a few days, or chronic? Because there is some conditions they do have a chronic acquired blisters, and these usually are autoimmune related conditions. They are not that common. But there is the most common are acute acquired blisters. And the most common acute acquired blisters, they are bullous impetigo. And bullous impetigo is very common, and you will see it. Usually they are very clear blisters. Sometimes they are ruptured, especially in the flexures area. Why? Because the toxin that is produced targeting in the granule layer. The granule layer is the superficial part of the stratum corneum. So when this part of the stratum corneum have been involved, then there will be like blisters. So bullous impetigo, these bacteria will produce toxin. This toxin will target the granule layer. In the granule layer, there is something called desmoglein 1. This antigen located in the granule layer, and the granule layer is in the upper part of the stratum corneum. So the skin generally divided into epidermis, basement membrane, and the dermis. In the epidermis itself is divided into the stratum corneum, the upper part, granule layer, spinous layer. So this one is affecting the granule layer, is just beneath the stratum corneum. So stratum corneum is in the top, and then the granule layer. This granule layer, it does have the desmoglein 1. And this desmoglein 1 is the target in the case of bullous impetigo, as well as in the SSS, Staphylococcus scalded skin syndrome. So Staphylococcus scalded skin syndrome is the more aggressive, more widespread form of bullous impetigo, where they target the desmoglein 1 located in the granule layer. And the granule layer is between the spinous layer as well as the stratum corneum. So the stratum corneum is in the top. Beneath it is the granule layer, which is the layer affected here, and then the spinous layer. Staphylococcus scalded skin syndrome, we see it mainly in children, sometimes in elderly with renal compromise. There is the cleavage at the granule layer with desmoglein 1, and these are due to exfoliate toxin A and B. If you do swab from these bullous impetigo lesion, it will be negative. Why? Because these are toxin mediated. It's not a bacteria itself, it's the toxin released by the bacteria. So in Staphylococcus scalded skin syndrome, they will have fever, malaise, and the skin is tender. If you touch the child, he will cry from the pain, and you will see an erythema. And if you peel off the skin, try to peel off the skin, it will be peelable very quickly and very easily. And this is, we call it Nikolsky sign. Why we have Nikolsky sign? We have Nikolsky sign because the peeling or the cleavage in the granule layer targeting the desmoglein 1. And desmoglein 1, which is located in the granule layer, just above the spinous layer and below the stratum cornea, is very superficial. So if you peel off the skin, because it's superficial, you're going to have the sloughing of the skin. And this is very important that sometimes we don't see the classic blisters. Why? Because it is very superficial and easy to be ruptured. After this erythema, there will be an exfoliation in a few days, and it usually heals without scars. One characteristic of the Staphylococcus called skin syndrome is a sparing of the oral cavity. There will be no erythema, nothing in the oral cavity, and this is in comparison to scarlet fever or, for example, complex drug reaction, where you do have involvement of the mucosal cavity. So, what about scarlet fever? Usually in children below the age of 10 years, and due to group A beta hemolytic streptococci, and these produce toxin A, B, and C. They do have fever, sore throat, but the thing that here you will have this rash starting within 12-24 hours, and usually it is sandpaper-like. That means there is roughness of the skin, almost like goosebump-like skin lesions. After a few days, there will be desquamation of the hands and feet. And then if you examine in the antecubital fossa, you will find these are pasteurline. What are these pasteurline? These are the petechial and the fragile skin. And if you examine the oral cavity, in the first few days, you will have the white tongue, and then in the next few days, you will have the red strawberry tongue with lymph node involved. So, fever, sore throat, and examine the skin, you find the sandpaper, rough of the skin. This could be scarlet fever. More features, you will have oral pillar. There is pillar around the oral cavity, but the oral cavity mucosa is involved. So this is very important features. Yes, there is circumoral pillar, but the mucosal cavity is involved. These are pasteurlines. If you examine antecubital fossae, you will find there is a petechia, small petechial red dot in the antecubital fossae. Why? Because there is rupture of a small capillaries in the fragile area. And these are, we see it sometimes. These are all like helping features to diagnose scarlet fever clinically. So we have the sandpaper-like or goosebump-like or rough skin, and then a few days, the erythema over the skin, it will be desquamate, especially in the palms and soles. So one tip here, if you have a child with a history of fever with desquamation of the hand and feet, think about scarlet fever, think about viral infection, and don't forget Kawasaki. Just keep it in your mind. Hand and feet peeling with redness, scarlet fever, viral infections, and Kawasaki. And if you examine the oral cavity, you will see the white tongue, and in the later on, after a few days, you will have what we call a strawberry tongue. The next infection that you might see in the emergency room when the mom brings her child with this buggy swelling with some discharge on the scalp. This is the classic tinea capitis from zoophilic fungi. So zoophilic fungi, especially Microsporium canis, is the most common fungi that cause tinea capitis. And this tinea capitis mainly involving the scalp, and it is caused by Microsporium canis, and it is the most common in our population. And because the origin of this Microsporium canis is from animals, with what we call zoophilic, when it infects the human, it will induce more significant inflammation. And this inflammation will end up into almost like a discharge and abscess-like formation. So this is not bacterial infection. This is tinea capitis and from zoophilic infection. And for this, you need to treat it with the grossufelvin. The first line therapy for this condition is grossufelvin. There is no topical therapy to treat a hair shaft infection. So hair shaft infection with fungi, that means tinea capitis, is only treated with oral antifungal. The treatment of choice for Microsporium canis, zoophilic fungal infection, the most common in our population and also the most common worldwide, is the grossufelvin due to Microsporium canis. If you don't have grossufelvin, you can use terbinafine. Usually we need higher doses and longer duration. The average duration is 4 to 6 weeks as well. And you need to eradicate the fungi from the pets as well as from other infected persons in the family. We will move now from the infection into the other non-infectious common causes. Urticaria is very common, especially after infection. The most common cause of urticaria in children is post-viral. So we talk about the 4 I's in children: post-infection, ingestion due to something they ingest, inhalation, or injection. In children generally, acute urticaria is mainly caused by infectious, mainly by viruses, and usually these are self-limited. And they are transient, red, pruritic, with demarcated wheals, and they are asymmetric, last less than 24 hours, and usually due to histamine release. How do we treat this condition? You treat symptomatic with antihistamine. Rarely we use oral steroid. Please do not use oral steroid to treat acute urticaria unless it is very severe and very life-threatening. And very rarely, urticaria can be a manifestation of cryopyrin or familial Mediterranean fever or some connective tissue disease. The mainstay for acute urticaria therapy is antihistamine. I would advise you to continue antihistamine for 2 to 4 weeks, but because what we see it in common in the practice that people, they use antihistamine for a few days and they will improve and then they will stop and then they relapse. So I do recommend to use antihistamine with a good therapeutic dose for at least 2 to 4 weeks after the urticaria attack. What about this? You might see it. Oh, this is an urticarial lesion, but this urticarial lesion is around the brown patches. These are urticaria pigmentosa. So these are an urticaria at the site of the accumulation of the mast cells, and this is, we see it in children. They have excellent prognosis. We have to avoid some medications like contrast, vancomycin, amphotericin B, and they are more allergic to venoms and some even anesthetic medication. So urticaria pigmentosa, they, on rubbing of the skin, they will release the histamine from the mast cells and will cause urticaria. Atopic dermatitis, you might have some patient coming to the emergency with a flare-up of atopic dermatitis. The most important that does this only atopic dermatitis, or there is in the top of atopic dermatitis, there is acute infection. We mentioned Coxsackie virus infection, also eczema herpeticum, and as well as impetigo. So impetigo, which is bacterial infection due to a streptococcal infection, it is common in atopic dermatitis. They present with honey crust appearance. So these, they will need either topical or systemic antibiotic to target these organisms. Usually it is a streptococcal or sometimes a Staph aureus. The second one is eczema herpeticum, where you do have these punched out papules over the face on the trunk, and this is usually we treat with acyclovir if the child is more than 1 year orally. If it is less than 1 year with fever and eczema herpeticum, he need to have an IV acyclovir. Why? Because in the less than 1 year, the bioavailability of oral acyclovir is not good, and sometimes Coxsackie virus can involve the skin as well. Does atopic dermatitis caused by food? The role of food in atopic dermatitis is very limited, and just in a few cases, the food, it might aggravate. So please do not advise your patient who coming to the emergency room to avoid a specific food unless there is a clear history about aggravation of the food. Usually, if there is no infection, no bacteria, no impetigo, no herpetic infection, we treat with topical steroid for a few days, as well as moisturizer with sedative antihistamine. It's very important here for atopic dermatitis. We use first generation antihistamine because of the sedation effect. We don't use antihistamine in atopic dermatitis because of histamine. It's not like urticaria. We use it here because of the sedation only. This is what we recommend in the acute setting, and then accordingly they can be followed by either pediatric dermatologist if it is bad, or it is by their pediatrician or family physician if it is mild to moderate, to continue on topical steroid. Usually we use a medium strength, medium potent topical steroid for a few days, 3 to 5 days, as well as moisturizer. So these are the classic features where you have the antecubital fossa involved. This is very common location as well. And what about this? This unfortunate child does have a severe atopic dermatitis, and the family, because of the food issues, they avoid many food. So she got secondary zinc deficiency. So she got acute dermatitis enteropathica on the top of severe atopic dermatitis. Why it is zinc deficiency? Because the lesions are almost U-shaped. She had also a diaper rash. The alkaline phosphatase was low, and this is a clue. If you have a low alkaline phosphatase with atopic dermatitis, Don't forget zinc deficiency. Sometimes parents, they try to do the best for their child by avoiding any special food, any specific food. By this, sometimes they lead to secondary nutritional deficiency. Moreover, this child also has punched out lesions. These are punched out lesion eczema herpetica. So she needs to be treated by IV acyclovir because she is less than 1 year of age. In addition, she has also this honey crust appearance. This is an impetigo. So she will need also systemic antibiotic because it is extensive. So this unfortunate child, she has severe atopic dermatitis, complicated with zinc deficiency secondary, with impetigo, as well as eczema herpetica. And by this, I would discuss just a few slides about how can we be sure that this is atopic dermatitis is a real atopic dermatitis and not to miss others. So if you have a child with severe atopic dermatitis, please do not forget hyper IgE syndrome, Omen syndrome, severe combined immune deficiency, Wiskott-Aldrich syndrome. All these can present with severe atopic dermatitis. So not every severe atopic dermatitis is a pure atopic dermatitis. Could be manifestation of other autoimmune of other immune deficiency disorders, and even could be related to nutrition, biotin deficiency, essential fatty acid, as well as zinc deficiency. So severe atopic dermatitis, you should keep in your mind, am I missing immune deficiency or nutrition deficiency? Sometimes you will see it, the mother bring her child with this sudden appearing of oval-shaped rashes on the body. They are asymptomatic, not itchy, and they start usually with 1 or 2 lesions, and then over 2 weeks they are spread. Usually they will come in clusters. So usually if I have one patient in my clinic with pityriasis rosea, I'm expecting another patient coming today or next day. And it is due to the viral infection, usually due to human herpes virus type 6 or 7. And these usually they are preceded by viral infections. So I see it in clusters. A few people, they will come within the few days. And these present with 1 or 2 lesions, and then within 2 weeks, they are spread. So the family will become very afraid after they are spread all over the body. I'm telling them they will stay for 2 to 3 months, and then they will disappear. Do we need to treat? If they are itchy, we can give topical steroid. Otherwise, we don't need to treat. One of the characteristics that the scales are at the periphery called colored scale. So colored scale means the scales at the periphery, and the lesions are oval and following the line of cleavage. So if you see the back of the abdomen, so the lesions are oval and following the line of cleavage, they give it the description of the Christmas tree. If you have only one lesion, single lesion, don't miss also a fungal infection, Tinea corporis. Tinea corporis present with single lesion with the scales at the periphery. So sometimes if you have one lesion, you need to do a fungal scraping to be sure that you are not missing a fungal infection. But if they are 1 or 2 lesions and after 2 weeks they are spread all over the body, then this is the pityriasis rosea. So this is very important, not to miss a fungal infection in the cases of early pityriasis rosea, because also they present with annular scaly plaques with curved scale. You might have some hemangioma. If you have a hemangioma in children at the vital organs on the lips, on the nose, on the genitalia, on the ears, and the eyes, please call dermatology and be sure that they will be seen within a few days. These are, we need to treat them very early to avoid any scarring or any complications. If you have a few hemangiomas on the trunk, they are less urgent and you can request an ultrasound for liver hemangiomatosis. But the most important hemangioma on the nose, lip, eye, ear, or even in the genitalia, please refer to dermatology right away. There is no anymore wait and see. We have treatment, we can give propranolol and even more aggressive therapies to help these patients. Is this hemangioma? Any blue lesions in any child is not hemangioma until you exclude other. Please, if you have blue lesions in a child or newborn, it could be hemangioma, but don't miss other conditions like what? congenital infection, as well as sometimes rhabdomyosarcoma, neuroblastoma, neonatal leukemia. So not any blue lesions is hemangioma. Yes, hemangioma is very common, but other are possibilities. This is what we call blueberry muffin baby. And by this, I conclude. Thank you.
Thank you, Jazakallah khair, Dr. Yusuf, for a very nice lecture, actually, about skin rash in kids, which is a common question in the emergency. Is it dangerous or not dangerous? Is it emergency or not emergency? I think your lecture had been explained many things. Now we can go to the questions from the audience. We have a questions from Dr. Rufaida, which is asking about how we can differentiate between scarlet fever and Kawasaki.
Thank you for the question. Assalamu alaikum, and thank you for the organizer and Dr. Fifi for inviting me. As you know, sorry, the scarlet fever and Kawasaki sometimes very difficult to differentiate. And usually it depends more on the history and clinical examination and constellation of the clinical finding. So in concept, scarlet fever, it is a new onset of fever that is associated with lymphadenopathy and maybe micropapular rash. Some of the hint of the rash, it started around the neck, in the ear, axillary, and then spread. This is in a nutshell about the scarlet itself. In Kawasaki, the fever, it prolongs longer, and the response of the fever itself to antibiotic, to like acetaminophen and derivatives, is less than in the scarlet. So less response of the fever to antibiotic. This is one of the features. The prolonged duration of the fever, for example, fever for 3, 4, 5 days. The classic definition is fever for 5 days. But what will happen if the family bring the child in the second day? Could it be a Kawasaki and this is the third or the fifth day? The third feature is that in Kawasaki, there is other finding. For example, there is lymphadenopathy, there is like a conjunctivitis. And if you look at the lymphadenopathy, they are less tender than the scarlet. In the scarlet, if you palpate the lymph node, they might be more tender. In the Kawasaki, it's less tender. The fever is prolonged, less tender lymph node. And the rash characteristic of the Kawasaki, it can be looks like a scarlet fever, but if you have a rash, mainly edema of the hands and feet, this is more of Kawasaki. If you have desquamation, especially around the periangual area, this is more of the Kawasaki. And if you have a rash that is like becomes almost like targetoid or like a papular rash over the groin area, also this is more of Kawasaki. So these are features that will help you toward the thinking about Kawasaki. If you are in doubt and you have a fever with some redness in the eye and you are not sure, you can do an echocardiogram, which it might give you some clues. So it's just a constellation of the features, but generally 3 skin manifestations look at these. The location of the start of the rash, if it is more on the neck and the axillary around the ear, is more of a scarlet. Second, edema of the hand and feet, more of Kawasaki. The desquamation around the periangual area, more of Kawasaki. The lymph node, more tender in scarlet fever, and the eye involvement more in the Kawasaki. And echocardiogram can you help? But again, don't miss a case of Kawasaki, and you can do non-invasive tests to help you to distinguish between these 2 entities.
Jazakallah khair. We have another questions from Dr. Yasser. It's regarding the scarlet fever. What is the role of throat swab in ER setting?
You know, throat swab is very important, but let's talk logistic things. If you can do the throat swab and you have the result right away within 1 or 2 hours, that will be a good idea. But to be honest, I haven't seen the throat swab within 1 day. Usually, if you do the throat swab, you have the result after 5 or 6 days. So probably if you're to treat it with antibiotic with penicillins, because the benefit is way more than the risk. And we don't wait for the result of the ASO titer, because at least in my experience, it will take longer than a week to have the result.
There's a question, but from Dr. Hara, investigation, specifically liver function test. I don't know what she means by that question. She can
how can we say
investigation, specifically liver function test.
Maybe what she can, when do we do liver function test with skin rash? Liver can be involved and with any viral example. Any virus can cause liver function test derangement. This is number one. Do we have it in a scarlet? We can have it. Do we have it in simple viral example with any virus infection? We can have hepatitis with anything. So probably if it is the case, it will not help me a lot in the presence of viral exanthem, but it can happen with any viral exanthem. And the same thing, if you have an exanthem, a rash on the skin, and increased liver enzymes, don't forget also medication. Medication, they do have hepatotoxicity and can cause induced skin rash. So this is also one of the possibilities. The next question here is that what can you say about the sandpaper? Sandpaper-like appearance, that means there is roughness of the skin. There is a prominence of the hair follicles and roughness. The skin is not smooth anymore. Sometimes it's easier to appreciate it, especially if the patient is white skin. Sometimes when the patient is darker skin, the papular or roughness of skin is difficult. When you talk about sandpaper, usually sandpaper is a retrospective description. If you have the other features of the scarlet fever, when you see the skin, you will say, oh, this is a sandpaper. But sandpaper is not, that is a big sign that can differentiate many things, because many things can give you sandpaper appearance. Maybe she means liver function test in Kawasaki. Kawasaki is an immune complex disease, so it can involve the liver, but I'm not aware it is very common. It is very, very unlikely to have the liver disease involved in Kawasaki. I'm not sure if it is really involved. It's very unlikely. In case of urticaria, how to convince family to use antihistamine for longer period? I do usually explain to the patient, to the parents, that urticaria, it's like a cell that produces histamine. In a stable condition, in normal people, is in the steady state. It's like this. When you have urticaria, it becomes to be shaky. And then when I give them antihistamine, the shakiness is slow. So if I stop all of a sudden very quickly, the shaking can still persist. But if I stop after a few weeks, the cell itself, it will go back to its position. So it is the time to take for a cell that produce the histamine, which is the mast cells, from irritation position to the stable position. It will take time. I tell them a few weeks. And to be honest, in some cases, I used to give them for a few months. And it depends on the severity of the disease. I tell the parent, and usually they are okay with that. What about rash with meningitis and dengue fever? Thank you. Meningitis and dengue fever. You know that the dengue fever, it is a fever that is associated, it is one of the hemorrhagic fever, and usually they are present with the maculopapular rash. However, in dengue fever, sometimes we have the rashes over the palms and soles. So if you have a rash that is persisting on the palms and soles and some petechial, we think about also petechial rash. The dengue fever, it is one of the, it depends in your local area, how common. For example, in Riyadh, we didn't see much dengue fever, while in the western part of the country, there is some dengue fever case, and even in the south. So probably you see if it is a rash on the palms, that is more, if there's the pain around the eyes, that is more of dengue fever. But generally, if you have from epidemic area with fever and macropapillary rash and some accentuation, more rash over the palms, I will go more into hemorrhagic fever disorders. Is urticaria rash itchy? Yes, urticaria is itchy. If I have a patient with a 2 or 30 Kawasaki, but duration less than 5 days, should I manage him as Kawasaki or ask the family to wait up? This is when I mentioned, usually the family, they'll bring the patient maybe second day, third day. Could it be Kawasaki? If you have other features, for example, if you have a fever and conjunctivitis and lymphadenopathy and some macropapillary rash, you just do an echocardiogram. If you have a fever that is not responding to the antibiotic, or the response is not as good, then probably I will consider Kawasaki. Again, for scarlet fever, usually the response to antibiotic very fast. So if I have a patient, I'm suspecting Kawasaki, I have to do an echocardiogram at least. Okay, and then I will give him antibiotic. And then I will probably observe him after 24 hours or after 48 hours. I could repeat the echocardiogram. If the echocardiogram is stable, his fever is responding very well, then it is unlikely. But if there is progressing of his echocardiogram, or if there is fever not responding very well, then there is questionable. Role of rapid strep in scarlet fever. I'm not sure about how the sensitivity and the specificity of the rapid streptococcal test. If you have this one and a test, you can ask your lab. The problem if you use generally, if you use any test kit, it depends on how accurate and how sensitive is the kit itself. And from one manufacturer may be different from the other. You have to have a control and be sure about the sensitivity. However, if you are in doubt, please don't waste the time and give antibiotic. We are using antibiotic for clear-cut viral exanthem. Many physicians, they are prescribing antibiotic unnecessarily for the condition that is, we know that 90% it is a viral. But if you have a questionable, it is a scarlet fever, and you are not quite sure, your test is not accurate, you have a delay in the result of the test, probably the benefit is way more than the risk. Can we apply the use of long period antihistamine in below 1 year of infant? For urticaria in below year of age, I will use the antihistamine off-label even from the first few weeks of life. And usually when the duration for urticaria, 2 weeks up to 4 weeks, it should be enough. And we used a lot of antihistamine below the age of 1 year. However, if you would like to use antihistamine below the age of 1 year, I don't recommend to use sedative. Use non-sedative antihistamine. This is my recommendation, to use non-sedative antihistamine to shorter period of time possible, for example, for 2 weeks, and then reassess.
Yes, thanks a lot, Dr. Yusuf. I think many questions they're asking about the strep. Should they start antibiotic or not to start antibiotics? As Dr. Yusuf mentions, you can go with the strep score. Swabs to take up to 3 days, from 2 to 3 days to until you get the result. Strep rapid test, the sensitivity is low, maybe less than 40% for that. So maybe this is not many questions about the strep. If you have any questions, you can type it now in the question and answer square. جزاك الله خير دكتور يوسف. Very very interesting. كان أكثر أطباء الأطفال they like to listen to this lecture about the skin rash, and they are confusing sometimes in the emergency, even in general pediatric, about the skin manifestation in the pediatric population. جزاك الله خير.
جزاكم الله خير جميعا, thank you for having me, and see you inshallah face to face in the future soon inshallah.
جزاك الله خير, الله يرضى عليك. Now we will go to the next lectures about the pediatric stroke and stroke mimics from Dr. Shin Fox from University of California at Los Angeles. Welcome, Dr. Shin.
Hello, everyone. Once again, I'm Sean Fox from Caroline's Medical Center in Charlotte, North Carolina. And once again, it's a privilege to be with you here. Over the last couple of topics, we've discussed very classic pediatric conditions and situations. For instance, mitigating pain and anxiety in children in our emergency departments. We've also discussed how to optimize our medical resuscitations when faced with the unfortunate situation of dealing with a medical arrest in the pediatric patient. We've also discussed how to assess and deal with respiratory distress in pediatric patients. Clearly, these are topics that many of us are already very familiar with. Now we're going to discuss a little bit of a curveball in that I bet many of us do not commonly think of pediatric strokes as something that we need to think about in our emergency departments. But in fact, it is a significant condition that we need to be mindful of. And we're going to cover some of the risk factors and some of the things that may make us think it's a benign condition, but in fact is really a stroke. So we'll review some of those stroke mimics because all of this gray certainly matters. Now, we would like to think our jobs and our differential diagnoses come in black and white situations, right? The very clear cut yes, no options, the ones and the zeros of the medical realm. But we also know that that's just not how medicine works or how people are built. The fact of the matter is there's a lot more of a spectrum of gray when we're dealing with any of our conditions, but particularly neurologic conditions that present to the emergency department and explicitly when dealing with pediatric patients. The clearness of the situation is often the most elusive. So trying to figure out how to strategize and discern where we are on this spectrum of gray, I think is really important. So we're going to talk about some of those gray matters and ideally come up with, again, a list of risk factors that we can refine our attention to and pay a little bit more specific attention to with respect to pediatric strokes. And then we'll also discuss some of the mimics that may deceive us into thinking it's a more benign condition when in fact it is a stroke. And then we'll go through a basic evaluation and management strategy and hopefully encourage everyone to go home and ensure that they have a well-defined protocol in their own shop. So risk factors, mimics, and then evaluation. Now, why should you care? Again, this seems like an adult condition, right? Well, we know, one, that there's no condition that really only affects a specific age group. Things can blend and affect across that spectrum of gray. Again, the children that we see certainly can have gallbladder disease and can have kidney stones, which was a condition we used to think of only on the adult side, and certainly children can have heart disease as well. So we need to be very cognizant of the fact that just because it seems like it would only affect adults doesn't mean that it can't affect children. And in fact, stroke is a leading cause of morbidity and mortality in children. It affects 1 to 2 children per 100,000 annually and is amongst the top 10 causes of mortality. And we can see that if you have a hemorrhagic stroke, it's certainly there's a higher mortality associated with a hemorrhagic stroke, but the 10% that's associated with ischemic stroke is not anything to be laughing at. It's certainly still very consequential. And even more importantly is the fact that if we don't have mortality associated with a stroke, we still often have morbidity, not only in the physical limitations, but also many times psychological devastation that can come with a young child now having to deal with persistent neurologic symptoms. Now, we know that time is brain, And when there's poor perfusion really to any organ, that organ starts to die. And we need to be expeditious in not only our diagnosis and treatment of it, but we often fall short of this because only 38% of cases that were later diagnosed with having strokes were suspected on their first visit and their first evaluation. So that means a significant amount of the time I send someone home thinking they had a benign condition, maybe a seizure with a Todd's paralysis. And in fact, that paralysis was not related to a seizure, but rather the seizure was related to ischemia. And I missed it, and now I've led to delay in diagnosis. Ischemic stroke is more often diagnosed almost a day after symptom onset. And obviously, we all can agree that that's suboptimal when we're trying to mitigate the ongoing damage and try to have best outcomes. A lot of this, I think, is probably related to our unfamiliarity with pediatric stroke. Hopefully, this conversation will change that a little bit, but also our bias towards the more common and less severe conditions, which we will talk about as mimics. And children do present with stroke differently. They are, in fact, more likely to have a headache. They're more likely to have a seizure, particularly the young, and they're more likely to present with altered mental status. Those three things don't usually make me think of ischemic stroke when I'm dealing with an adult, but we really do need to think about it when we're dealing with children. What are our risk factors? There's two main types of seizures. There's ischemic strokes and hemorrhagic strokes. Cerebral venous thrombosis also kind of falls in the ischemic side, although they can have some hemorrhagic conversion. Interestingly, ischemic strokes are as common as hemorrhagic strokes, which is different than on the adult population. On the ischemic stroke side of the equation, things that would raise our risk for having ischemic stroke in children would be abnormal blood vessels, right? Arteriopathies, or abnormal cardiac conditions such as congenital heart disease or cardiomyopathy leading to thromboembolic disease. Prothrombotic states, nephrotic syndrome, protein 5 or protein C deficiency, factor 5 Leiden, antiphospholipid, all these conditions increase our risk for thrombotic disease for a number of conditions, DVTs, PEs, but also stroke. And certainly systemic disorders. We many times will probably think about sickle cell disease, which we should, but also other inborn errors metabolism, genetic disorders, or if you're just overtly sick, if you have bacterial sepsis and you're in the ICU, you're at increased risk for developing a stroke. The arteriopathies are going to be the leading cause of ischemic strokes. And if we find that you have an arteriopathy, say we diagnosed you with an AVM, you have a 66% risk of developing stroke in the next 5 years. Cardiac etiologies would be the next most common, and then the other two kind of make up the rest. Let's just take a second to highlight the fact that, again, sickle cell disease is a very common cause of stroke. It's to the point where the hematology clinics will screen children with sickle cell disease using transcranial Doppler when they're young to discern whether they're at increased risk or not, and we'll continue to monitor them for stroke symptoms. We know that if you have sickle cell disease, you're at risk of developing a stroke is 200 times greater than if you don't have sickle cell disease. That's pretty substantial. The sickle cell condition itself not only causes potential for clotting of blood vessels, but it also causes our blood vessels to become abnormal, and you can get like a moya-moya-like disease condition, and it also puts you at greater risk for hemorrhagic stroke. Now, hemorrhagic stroke, as I said, is as common as ischemic stroke, but it's associated with a higher mortality, as we mentioned before. The groups that are going to be at greatest risk for hemorrhagic stroke are going to be the individuals that have abnormal blood vessels, like AVMs would be the most common, but certainly dissections, could also play a role. And then people that are prone to bleed, so hemophilia, or if you've got significant thrombocytopenia. This little cute cuddly guy is a slow loris. He's super cute. He's super cuddly, right? He looks very placid. And why would he be here in this presentation? Because he's actually one of the most venomous mammals on the planet. He has an interesting ability to combine the oil from a gland on his brachial arm. There's a brachial gland. He'll lick it, and then the oil will combine with his saliva, and then that combination becomes a venom. And it fills the grooves of his teeth and his fangs. And then when he bites, which he does vigorously and viciously, the venom is then introduced into the victim, sometimes even another slow loris, which also makes them kind of unusual in the animal kingdom. They use venom on themselves. And that venom will cause tissue necrosis and can even lead to anaphylactic shock. Why do I have him here? Because he's cute, he's cuddly, we think it's fine, we think it's benign, but in fact, it's very deadly. There are other conditions that we need to think about when we encounter them, such as migraines, seizures, that we might think are benign and in fact are really mimicking and deceiving us. We're looking past the fact that it's in fact a stroke. So migraines are the most common stroke mimic, and that's because unlike adults, children will often present with ischemic stroke as a headache as one of their primary symptoms. And that's unusual on the adult side, and except if it's a hemorrhagic stroke. So ischemic strokes on the adult side don't usually lead to headache, whereas on the pediatric side, they may. So we need to be thoughtful and not just always say it's a migraine, particularly if that migraine comes with some other neurologic symptoms. Complex migraines certainly can have other neurologic symptoms, as we know, but complex migraines don't usually have weakness. They usually have numbness. So if we are seeing headache and weakness, we need to think twice before we say that that's a complex migraine. Seizures certainly may be followed by a Todd's paralysis. Unfortunately, this often deceives us as well. Todd's paralysis can be full hemiplegia. Usually it's more isolated, but can be full hemiplegia. And if that's the case, it usually still resolves quickly. I believe within 20 or 30 minutes, if we're still having symptoms after that time, we need to be thinking about revising our consideration of what actually is going on, particularly when seizure may in fact be the presentation of an ischemic stroke in a child. Clearly, we know that Bell's palsy can sometimes deceive us, and we need to be very mindful that your full neurologic exam sometimes is difficult to discern. Is that forehead really moving or not? And we're dealing with a 2 or 3-year-old. So be very careful about saying something's a Bell's palsy if you're not able to get a full physical exam that's reliable on that child. Conversion disorder, certainly there might be some clues if there's a changing evaluation, a changing exam, or give way weakness. But we want to use conversion disorder certainly very cautiously and as a rule, a diagnosis of exclusion rather. Other conditions we would like to think would be more apparent that in fact are presenting instead of seizures, or I'm sorry, instead of strokes. But stroke can be misconstrued and vice versa. These conditions can be misconstrued instead of stroke. So meningitis, encephalitis, demyelinating diseases, brain tumors, traumatic brain injury. So we need to be thinking about these on our differential list when we're considering a patient presenting with symptoms that may be related to stroke or vice versa. What is that evaluation going to look like? Well, first and foremost, we need to get a good history. As with everything in pediatric patients, our history and our exam is going to be the foundation upon which we build our diagnosis list and sort through it. Probably one of the most important keys here is not asking what's the time that all of this started, but rather when was the last known well time? Because particularly parents, but any people can certainly misconstrue timing. And if you ask, when did you first notice this, they're going to give you, mom or dad are going to tell you when they first actually saw it, and that was this morning when we woke the kid up. But that obviously changes the duration of our possible onset of symptoms if it actually began before they went to bed. So when was the last time they were known to be well without these symptoms? And then we're going to want to sort through those potential risk factors, evaluating more cautiously, certainly if we find them, and then start to build our diagnosis list, including all of those items, including meningoencephalitis and demyelinating disorders, and then looking for clues specifically to help sort those out and the other mimics, and being very cautious if we're dealing with someone who presents with a headache and a new neurologic symptom, not attributing that strictly to migraines, or if someone presents with, again, seizures and altered mental status, we're going to want to be very cautious about attributing all of their symptomatology to those conditions alone. The most common symptoms that children will present with will be hemiparesis. So not a medical mystery there. We should be always thinking about ischemia if we have something that's in a anatomic distribution that would make sense with intracranial ischemia or hemorrhage for that matter. They often will also have speech changes, whether altered speech or language. And then remember, in the very young, particularly infants or young children, seizures and altered mental status may be their presentation. So be very cautious about that initial seizure evaluation being solely bent towards your run-of-the-mill innocuous evaluation for a first-time seizure in children. We're going to want to obviously start getting some laboratory studies. In our process for obtaining these laboratory studies, we're going to want to also think about the mimics like hypoglycemia. It never made sense to me how hypoglycemia could cause a focal neurologic deficit, but it has been shown time and time again that it can. So before we send someone off to neuroimaging and having further delay in care, we want to make sure we're not sending them with a glucose of 40. So get that finger stick. Don't rely on the fact that the chemistry is going to bring it back. In my experience, when I rely on that, it always brings it back delayed. So, and then we're going to also want to know particularly what their platelet count is, their coagulation studies, and then if on the list of potential risk factors are metabolic derangements, we're obviously going to want to know what their metabolic panel is. And in addition, if we have a patient who is postmenarchal, we certainly want to know whether she is pregnant, because that's going to change not only her risk for stroke, but also management strategies. Here's one of the most important things I want you to be able to take away from this talk is how we image stroke in children. It is different than how we image stroke in adults. On our adult side, we often have protocols for very rapid assessment with perfusion scans with CT imaging, because it can be done very expeditiously and within a matter of minutes have really great information about how we are or what underlying conditions we might be dealing with, as well as the amount of ischemic area that's involved. On the pediatric side, we don't have evidence for that yet. And at this point, the preference is to get a rapid MRI protocol for ischemia. This gives you diffusion weighted imaging, gives you T2 flare, and gives you vascular imaging as well. It takes about 20 minutes. So it's faster than your standard MRI of the brain, but it also is not a rapid MRI for VP shunt evaluation. Be aware that a VP shunt evaluation MRI, if you have that in your protocols, usually it's on the order of kind of 90 to 120 seconds, which is very nice, because then you don't really have to worry about the timing difference between it and a CT scan, and then we get the benefit of avoiding CT radiation. but the cost of that rapid MRI for shunt evaluations is that there's significant image degradation, and you would never be able to use it for evaluations of ischemia or hemorrhage for that matter. This rapid MRI protocol for ischemia is sensitive for ischemia, and it also helps evaluate the other mimics that we would be dealing with, and it gives us an understanding of some of the risk factors, such as the vasculature. If you went into the evaluation thinking that your highest concern is that the patient has a hemorrhage, maybe they have a known AVM and now have altered mental status, then yes, 100% get that quick study done with the head CT. But know that if your consideration is for ischemia, your head CT is not going to be good enough to be conclusive, and we're going to still have to follow it up with the MRI following that. The MRI, again, as I said, is rapid, but it still takes about 20 minutes. So now we also have to consider the other issues. I'm dealing with a 2-year-old, and are they going to hold still long enough? Am I going to have to deal with sedation needs? And how does that affect their current neurologic status? I'm worried that they have, altered mental status, and further sedating them might cause more problems. So just be aware that it's a rapid MRI for ischemia and stroke evaluation, but it's still going to take 20 minutes, and we need to think about what our strategies will be there. Ideally, your system has a pre-planned protocol that will help you kind of easily decipher this and not have to reinvent the wheel at 3 in the morning when you need to get it done. Now, moving on to what we're going to do if they have a stroke. Obviously, we're going to do our basic, stabilizations, our A's, B's, C's, and D's. Probably most important, but even before I send them to the scanner, I want to know what that glucose is. Again, as I said, hypoglycemia is something we need to be very cautious of and conscientious about evaluating. We're going to want to assess that airway, make sure they're maintaining their own airway, and if they're not, take actions as appropriate. And then ideally, you activate your pediatric stroke protocol. We'll talk about why this is important, but obviously it's going to streamline a lot of things and make your processing of everything easier. On the adult side, many times we will say, if you're at a resource limited region and you don't have access to all of the fancy imaging modalities, get a dry head CT, and if the dry head CT shows no hemorrhage, go ahead, if their presentation fits ischemic stroke, treat them accordingly with TNK or TPA. On the pediatric side, that's not a process that we would go through, because you really want to have better imaging to understand what you're dealing with on the pediatric side. So empiric therapy for pediatric patients is not really part of our protocols that exist out there right now. Now, again, we kind of divide them into ischemic stroke and hemorrhagic stroke. Our main therapies for ischemic stroke are going to be aspirin and heparin, and then ideally involvement of a multidisciplinary team, and then targeted therapies. What are targeted therapies? Well, for instance, if you have sickle cell disease, we're going to want to treat them actually in a different fashion. We would like to get their sickle hemoglobin ratio below 30%. So you're going to transfuse them. Ideally, they're going to get an exchange transfusion. But initially, if you're not in an area that has the ability to do that avidly, or their hemoglobin is below 9, you can start them off by a straight transfusion. I wouldn't give them a full transfusion. I'd obviously be in concert with their hematology specialist. They're probably going to want you to do 5 to 10 mLs per kilo first, because we don't want to make them too hyperviscous. But exchange transfusion would be the main therapy for them. Now, we always need to talk about thrombolytics and thrombectomy. Realize that pediatric patients actually metabolize TPA faster than adults. So our understanding about dosage is somewhat limited still with children, still evolving. On our adult side, we tend to favor tenecteplase. That has been shown to be safe to use in pediatric patients, but still isn't I would say very defined, and I would say using it is somewhat dependent upon your institutional protocols, your local experts, and your local resources, and I would say it's a gray area. Similarly, thrombectomy has been shown to be effective in certain cases, but once again is going to be predicated on your local resources, your local skill set, and tools, because obviously we need very small catheters to be able to do that in very small children. So once again, kind of a gray area and predicated on what your resources are going to be. But know that it is a tool that may be used in specific cases. For hemorrhagic stroke, we're going to want to do basic things like keep their head of bed elevated. We're going to want to prevent them from being hypotensive or hypoxic or hypoglycemic. And then if they're on an anticoagulation for any reason, we're going to want to reverse that. If they have a large intracranial hemorrhage, neurosurgery certainly may be involved to evacuate that as well. So using your consultants clearly is going to be beneficial. Clinical pathways are probably the most important part of this to help alleviate you at your brain stress at 3 in the morning, though. We know that having a pathway, a protocol that involves a screening tool will help expedite imaging, will help ensure they get the most appropriate imaging, and will help improve our timeliness to their diagnosis and help coordinate our multidisciplinary team so everybody's speaking the same language. So if you don't have a hospital protocol where you're currently working, I encourage you to go home and look at ways to institute one, because it'll be certainly beneficial for not only your patients, but yourself when you're facing this scenario. So to recap, we certainly need to know our risk factors of abnormal blood vessels, certainly cardiac disease, prothrombotic states, systemic disorders such as sickle cell disease, or even being overtly sick with sepsis. And then always keep in the forefront of our mind that we may be deceiving ourselves by saying the patient had a headache and therefore I'm sure this is a migraine with some complexity leading to new weakness. That's not a migraine. Migraines, complex migraines, usually will cause numbness, not weakness. So think about our mimics, keep them high on your list of things to consider, and vice versa. If you think someone has a seizure, make yourself go through the mental gymnastics of considering if this is actually a ischemic or hemorrhagic stroke, Bell's palsy, altered mental status, obviously on our list as well. And then our evaluation. Never forget that being fooled by hypoglycemia happens to the best of us, so try to avoid it. Always check that glucose with any change in mental status or any new neurologic symptom. Keep the risk factors and mimics close at hand so that you can quickly assess them. Remember, MRI, rapid imaging for pediatric stroke, is the preferred method. And then ideally you have a protocol, because sorting out all of the spectrum of gray in the middle of your shift when you're dealing with all of the other chaos and complexities can be really challenging. So I think offloading some of that by having a protocol up front will certainly benefit you and ideally the patient. I hope that was helpful for you. I really look forward to speaking with you later. All the best. Thank you.
Thanks a lot, Dr. Shane Fox, for a nice lecture. And now we'll go to the next one with Dr. Christopher Amato about upper airway emergency, swift and effective response. Welcome, Dr. Christopher.
Hello, and thank you so much for inviting me to your homes, your conference rooms, wherever it is that you might be looking at this. And also, thank you so much for your interest and care for children of all ages. My name is Christopher Amato, and I'm a pediatric emergency doctor in New Jersey. And we're going to be talking about upper airway emergencies, and we're going to be focusing on what things we can utilize to determine upper airway issues and then focus on the care of them. I have no relevant financial relationships. I do not intend on talking about any off-label or unapproved approaches. Sadly, I have no financial interests and sponsorship. I have just the love and admiration of my family. So let us begin with the objectives. We're going to first talk about how the pediatric airway is different from anything else that we deal with in emergency medicine. We're going to also specifically focus on the care of croup and other upper airway respiratory distress syndromes. We're going to also look at potential different ways that we can affect the pediatric airway without potentially going to the next level of taking over that airway with endotracheal intubation. So we'll talk about upper versus lower airway disease, and that truly is going to be the most important thing that we're going to talk about today, is differentiating in a matter of seconds, am I dealing with an upper or lower airway disease? We'll talk about upper airway differentials, including foreign bodies, croup, and tracheitis. So why are we here today? We are here because 80% of all cardiopulmonary arrests in pediatrics is due to airway and breathing. Only 10% are going to be shock, and other 10% is going to be cardiac. So the most important intervention that we're going to make as clinicians is focusing on that airway and breathing in these children, because that is the vast majority of what leads to cardiopulmonary arrest. 10% of all pediatric emergency visits are related to a respiratory issue, and that number increases during at least our seasons of fall and winter, where we are dealing with more children hanging out around other children and them sharing their mucus, as well as we find that there's just a higher venue of respiratory illnesses during this time period. At least 20% of all pediatric hospitalizations are related to a respiratory issue. And please remember, vital signs are vital. We do need to remember that the temperature of the child that's presenting can affect not only the respiratory rate, but also the pulse rate. So for every degree above 37 for respiratory rate, we can add 3 to 7 breaths. For the younger child, we can actually add up to almost 10 to 11 breaths for that degree of fever, for every degree of fever above. So if they're coming in with a 40-degree temperature, we can add potentially between 20 and 30 breaths per minute for a less than 12-month-old child. Just an important memory to think about. I hate to do this so early in a lecture. Certainly, I hope that you are not eating at this point, because math always upsets my stomach. But we do need to address the fact that the airway in a child is dramatically smaller than it is in an adult. And there is a direct inverse relationship between the radius of an airway and the resistance of that airway. And if we decrease the radius by half, we are increasing the resistance 16-fold. So clinically, what does that mean? In an adult airway where we're dealing with a relatively large diameter, 1 millimeter of edema only is going to affect about 20% of that airway. So we still have a significant amount of airway that we can affect and control when we are dealing with it. But in a pediatric, certainly in a full-term newborn airway, 1 millimeter of edema can affect half of my airway. I am dramatically affecting it. And we know how responsive and hypervascular that airway is. So children can actually go from completely breathing normally to having almost no ability to breathe through that diameter in matter of seconds to minutes. It is a dramatic difference from the adult airway. When we are dealing with the airway, there's a few other things to remember. Children less than 6 months of age are obligate nose breathers, right? They are also dependent on the diaphragm to breathe efficiently. So when you are dealing with a child in extremis that's less than 6 months of age, please look at their whole torso. If they have a completely distended abdomen, maybe it's actually that distension that is causing the diaphragm to build up and not be able to take that full breath, which is actually causing their respiratory distress. So instead of an endotracheal tube, maybe this younger kid actually requires a nasogastric tube. We want to avoid overextension of the neck. We want to make sure that we open up all that floppy tissue and that omega-shaped epiglottis to keep it open. And we think about good jaw displacement. For those younger kids, because they have such a big occiput, we should also consider positioning them appropriately. Maybe these children need to be placed with a shoulder roll underneath them so we can align those axes between the big occiput and that lower airway, that upper airway, excuse me. So if we're not using chin displacement, then we should certainly be utilizing displacement of that occiput so we can align those axes. The sniffing position, we don't want them in extension. We want them in slight flexion, okay? We want to avoid that hyperextension of the neck, but we want to be cautious about this clinical scenario that we're dealing with. Maybe this is a child that we're concerned about trauma, and maybe there's actually some kind of neck injury. We want to avoid any kind of cervical exposure or extension of that because that will worsen that injury. And we know that when we're dealing with a cervical injury in a child, it's a C2-3 injury as opposed to a 5-6 injury in the adult. So it's a much more significant cervical injury. The last thing that I'll talk about how to improve your ability to visualize the pediatric airway is something called bimanual laryngoscopy. This is where you need a friend to help you. So you're going to utilize their hand to place it on top of the child's anterior airway while you're looking in with a laryngoscope. And you can put a little bit of supraglottic pressure, or at least anterior neck pressure, so that you can visualize that airway, which again is different from the adult airway because it's more anterior and superior. So it's not in the typical place that we look for it. But utilizing that second person's hand, you can manipulate their anterior neck to push those cords better into your view so that you can place that tube much, much easier. It improves your percentage of glottic opening score by 25%. So this is a dramatic improvement in terms of visualizing that airway than in the backwards, upwards, right pressure, or even just direct cricoid pressure alone. You need to use your friends to help you. We want to limit things to the essentials, right? 90% of what I need to know in pediatrics, I'm getting within the first few seconds of looking in that child. I am seeing what they're doing. I'm seeing their ability to be calmed by their caretakers or even their response to me. If they're screaming and trying to punch me, well, that's actually a really good sign. If they're letting me get close and even, dare I say, place sharp objects into them, that is very concerning to me. I have no issues of trying to allay the child's fear and build rapport immediately by getting down to their level. Now, if you guys could meet me, we know that children are not small adults. I am a small adult. The reason I do kids is because I'm their height and their mentality. I am 5'5" at, when there wasn't gravity around. So when I'm walking into a room, most of the times they're on a parent's lap and I'm actually looking at them in their eyes. And I will do whatever I can to distract them or make them laugh while I'm getting that information for the family. By building rapport with the child, I will build rapport with everybody else in that room. If I win over that child, I win over everybody else in that room, okay? We want to avoid doing things in a stepwise manner that we always do it because every child is different. So if I need to do something that's going to be painful or anxiety provoking, I want to do that last. If I have a calm, quiet child, that's the time for me to auscultate their lungs, their heart, their abdomen, whatever it is that I'm concerned about. I want to use that time period well. I want to give the child parameters that they can deal with because a lot of times by giving them clear-cut dynamics, clear-cut parameters, they will actually improve their ability to tolerate my exam. Ears, for some reason, at some point in the child's life, someone has tried to crawl inside their external canal, and that has made them very upset. But I tell them it's going to take me 3 seconds to look in that ear, and I'm done really within 1 second. That's what happens after you do 30 years of this, right? But when I look at the second ear, they know that I'm going to count to 3, and they're much more compliant and much more complacent and allow me to do that exam much easier. So give them the parameters that you're going to be truthful with. Do not give them options that they don't have, and focus on what the goal of your exam is. Okay, this is the most important slide that I'm going to give you during this 30 minutes. The 2 places that you need to place your stethoscope are in the lateral neck and the axilla. Those are the spots that's going to help you differentiate within seconds. Am I dealing with an upper airway issue, or am I dealing with a lower airway issue? And your differential is dramatically different, as is your algorithmic approach. If you put your stethoscope on the lateral neck and you hear nothing, it's clear. But you put it on the axilla and all of a sudden you hear, then you know you're dealing with a lower airway disease. You're dealing with, bronchiolitis, asthma, pneumonia, pulmonary edema, etc. If instead you put your lateral neck and you hear and your axilla and all of a sudden that same sound is louder, well, you know that you're actually dealing with an upper airway issue that is reverberating into the open air spaces, which is acting like a megaphone. So those sounds are being transmitted and superimposed on the lower airway from the upper airway. Okay. That's the most important thing that I can teach you about a kid's airway. And again, in seconds, you have differentiated upper versus lower. Upper, being foreign body, being angioedema, being some kind of upper airway infection versus the lower. So let's deal with this from cases. 3-year-old is being sent in by his pediatrician at 2 a.m. after hearing him cough on the phone. And, the parent said it was barking like a seal. There we go. The child had a little bit of a gooey nose for the last 2 days and then went to sleep well, woke abruptly, and started with this difficulty breathing and wheezing, right? I have had a myriad of patients brought in by my pre-hospital personnel that had been started on an albuterol neb for what they determined was wheezing when it actually was stridor. That's why it's so important to differentiate, am I dealing with upper or lower? In the ED, though, he is febrile. He is running around the room without any stridor at rest. Well, I know immediately because he's running around despite the high fever that this child is going home. My disposition's already been made in my head, but more than likely I have to figure out what I need to do for him, right? So he's awake. He's got an abnormal breathing process, 39 for fever, 30, 100, 99% tachypnea, but he's not in any distress. So let's look a little bit deeper. His airway is patent. He is tachypnic without retractions. His color is good, so cardiac is good. His disability, his quick neuro is good. And external exam is also normal. I'm not seeing any signs of injury. So just quick and dirty, we know that this is acute onset of respiratory distress, maybe preceded by a URI or maybe not. So what do we think this is? This is croup, right? Do we need to do anything for it to determine that we are correct? No. Do we need chest x-ray or labs because he's 39 degrees? Could it be something else? Just say no. First and foremost, we want to keep the child happy and calm. The last thing that we want to do with that resistance issue is add more turbulence to that upper airway. So the exam and the history favors our decision that this is croup. We don't need to do anything more. There's 2 things that we do need to do. Quickly verify that their vaccinations are up to date because epiglottitis still exists out in the world. And then the other thing is that we need to verify that there's no other anatomic issues that we should worry about. You could have upper airway stenosis related to trisomy 21, or being a significantly preterm baby can also lead to that. Those children that have some kind of anatomic narrowing, they're going to fall off that precipice a little bit faster. And the only thing that might do for us is determine whether we should keep them overnight for observation or have some other follow-up with them set up. Therapeutically, mist therapy, cool mist, as long as it doesn't upset the child, generally it's okay, but the Canadians prove that it really doesn't make any difference in terms of outcomes. In terms of corticosteroids, absolutely. We need to provide them oral corticosteroids. If there is a choice between giving a child something orally or an injection, especially when you're dealing with a very turbulent airway, please try and give it to them orally, because the last thing that you want them to do is get upset, cry, and make that airway even worse and potentially lead to worsening respiratory outcomes. All right. We definitely know that a systemic infused medication is markedly better than just an aerosolized or a nebulized medication. So we do not want to provide them nebulized steroids in this situation. My preference is oral. Dexamethasone, the studies initially were 0.6 per kilo with a oral dose, but studies of 0.3 and 0.15 have also been shown to be non-inferior. If they are in really severe extremis, they are retracting in the supraclavicular or suprasternal or even midsternal, if they're hypoxic and they are in severe respiratory distress, let's pull out the racemic epi. It's 0.05 mils per kilo with a maximum dose of 0.5 mils. That varies with your institutions. At my institution, we're a 0.3 mil dose. So if I have an older kid that's a little bit bigger, I might ask them to change the dose, or I will ask the respiratory therapist to give a higher dose. If you don't have racemic, and this is or this is in the pre-hospital world, no issues. We can pull out the L-epi that we utilize for anaphylaxis, the 1 to 1,000. In this case, because it's not racemic, we can actually double or increase the dose by 10 times. So it's 0.5 mils per kilo with a 5 milliliter maximum dose nebulized. Do we need to observe them? Yes, I think most of us do. The reality is that less than, I don't know, when I was training in the 80s, 90s, we would watch them for 4 to 6 hours. Then it became 3 hours. Now it's about 2 hours. But the goal is that we've got the steroids on board first, because the steroids take about 2 to 4 hours for them to start to work, okay? Again, when we're dealing with an upper airway disease, please don't upset them. Keep them calm, keep them comfortable. When we're dealing with dexamethasone dosing, no matter what you choose between 0.15 all the way up to 0.6, it is a 10 milligram dose maximum. We know that glucocorticoids make an enormous difference, and this is actually the Cochrane review for the last 20 years. 45 studies between 1964 and 2021, there is a dramatic improvement by providing glucocorticoids. There's fewer unscheduled return visits and overall decreased length of stay in your hospital ED. Dexamethasone dosing at 0.15 and 0.3 are non-inferior to 0.6. So if you can get away with less, you should give less. What about the kid who needs a second dose of epinephrine? The reality, again, is that studies have shown that a second dose of epinephrine, of racemic epinephrine, does not automatically equate to admitting them overnight. As long as you can provide observation that another 2 to 4 hours after the second neb, they're improved, because by that point the steroid has kicked in, they are safe to go home. Generally, my gestalt, and this is me alone, is that if they need a third neb of a racemic epi, they're buying a bed. I want to watch them overnight because I like to sleep. What if that same kid had a URI for 2 days and they come in and they're worsening breathing, but this kid looks sick. They look toxic. Febrile to 39, tachypnic, tachycardic, no distress, their airway's patent, they're tachypnic with retractions, their color's good, their dexterability is good, there's no signs of injuries. You could get this x-ray, right? This is the classic steeple sign for pediatric croup. But what if we look at the lateral neck? I'm hoping that you guys can see my pointer. And even though there looks like there's a little bit of prevertebral edema here, you're allowed 7 millimeters at C2 and 22 millimeters at C7 when we're dealing with edema. But you see how much goo is back there? And again, this kid is sick. So we've given a racemic epi, but unfortunately, there's been really no response to it. The child is still in extremis. They are toxic appearing. We repeat the racemic, and again, there really is very little response to the therapy. In this situation, we should start thinking about looking at that lateral neck x-ray. And if you look here, you can see instead of now this clear, nice and dark black that indicates air, we have all this goo that is in their airway. This is pretty classic for a bacterial tracheitis. And about 2 years ago, I had 3 of them in the row. The first one was the one that was the most confusing. She was about 14 months of age, and she was satting 96 to 98% when you left her alone. As soon as you started to irritate her or examine her, she bottomed out to the mid-80s. She otherwise did not look toxic in appearance, but because she continued to just kind of vacillate in that airway, we ultimately decided to intubate. And when we intubated, the amount of mucopurulent discharge that we saw in her airway was fairly significant. Now, again, when you're dealing with an upper airway disease, you're looking at your regular endotracheal tube that has a cuff, because all children, except for a neonate, gets cuffed endotracheal tubes. In this kid's case, though, we got a half size smaller and a full size smaller because I wasn't sure how much edema and how much gunk was going to be in there so I could pass my tube clearly. It is more often than not methicillin sensitive Staph aureus, not typically MRSA. HIB used to be the common one with this, but non-typable can be found. And it oftentimes starts off as a virus, so it can present as croup that gets secondarily infected with non-typable H. flu or even Staph aureus, okay? Stridor does not equal croup. We have to think about other things in our differential. So let's take this 13-month-old that comes in mild respiratory distress. So mom found him choking and gagging next to a spilled container of nuts. Your pre-hospital personnel happen to pick him up, and they notice that there is some subcrostal retractions, and overall that his work of breathing is increased, and that there's some decreased actually airflow in his lungs. But again, we listened to his upper lateral neck and his axilla, and lo and behold, we are deciding that this is an upper airway differential. So we think about anaphylaxis. We think about choking or foreign body, which still terrifies me after 30 plus years of doing this. We think about other infectious types. We think about croup. We think about epiglottitis. We think about abscesses. In this kid's case, he's getting worse. He's getting tachycardic now. He's in between 160. He's now much more tachypnic. He's now in 60. He's afebrile, so likelihood of infectious being smaller. And again, we have the history of he was found by a spilled container of nuts. He's got stridor on exam when we listen to that lateral neck. He's got tachypnea with retractions. Circulatory is fine. Disability is fine. And external is fine. There's no signs of trauma. But we have the story. So we asked mom, was there any kind of choking or gagging episode before he had the onset of these symptoms? The most important thing that we can actually find when we're dealing with an upper airway or an aspirated foreign body is this history of choking or gagging. It's got a 90% specificity and a 45 to 70% sensitivity. And again, we already know how to differentiate upper versus lower airway, so we're not going to reiterate. When we're dealing with foreign bodies, 150 to 300 fatalities per year, at least in the United States. But for every one of these fatalities, there are 100 choking-related events, in the pediatric ER. Now, 93% of all kids are seen in general ERs in the United States, so the vast majority of these kids are being seen by general EM doctors, which is not an issue, but I have taken care of toddlers all the way down to 1 year and older, all the way up to 17 or 18 with aspiration events or choking like events. The vast majority of these cases, though, are in children's 2 or 3 2 years of age. 2/3 of these cases are in 1 to 2 years of age. Most of the times we're dealing with less than school age children, less than 5. Unfortunately, the mortality is highest with balloons when we're dealing with a foreign body aspiration. But there's a myriad of things that can be aspirated or choked on. Food, home agents, coins, etc. When we're looking for the foreign body on a chest x-ray, you're looking for that increased inspiration or that asymmetry of those lungs, right? We're looking for that radiolucency because what we're dealing with is a foreign body that is acting like a ball valve. Every time the patient breathes, that foreign body pulls up from obstructing that smaller bronchiole, and the air goes around it and into the distal airways. As they breathe out, the foreign body obstructs it, and that air is trapped. So very similar to our COPDers or our asthmatics, we have a significant air stacking issue. For the smaller child, we need to have a bilateral decubitus x-ray to look at that asymmetry. For the older child that couldn't cooperate, we're going to do an inspiratory expiratory film. If we're dealing with a foreign body in the upper airway, we can actually pull out something called helium oxygen or heliox, because what's happening is that the helium, which is a much lighter gas than oxygen, can act as a carrier to try and get around that foreign body and aerate and oxygenate that child while we think about how we can affect that foreign body that's obstructing the airway. This could be a bridge while we think about either doing a needle crike on the child or even performing a trach on the child. Hopefully it won't come down to that, but that is certainly a trick that can be utilized. Aspiration versus swallowed. I don't need to go through this with you guys. You're all experts. It is imperative, though, to understand what it is that was aspirated or swallowed. If we look at this chest x-ray closer, we can see that round foreign body in the upper airway, right? Or at least in the neck area. If we enhance it, we can see this double silhouette sign, and that is telltale that this is not a coin, that this is actually a button battery, which is absolutely a surgical imperative to get this out sooner rather than later. Button batteries are a true emergency. They can cause mucosal damage. They can cause pressure necroses. They actually can be, the electrical charge can be charged from just saliva alone, which will lead to a burn necrosis of the upper airway, which could absolutely lead to issues with scarring later on and affect that way that patient breathes for the rest of their life. So it is absolutely imperative that we are cognizant of what we're dealing with. So that's all I have to talk about. I really appreciate your time and I look forward to any questions you might have. I do think that these are very important statements that we all can take some knowledge and some wisdom from. Success is not final. Failure is not fatal. It is the courage to continue that counts. It always seems impossible until it's done. And I look forward to hearing from you in any way, shape, or form that I can help continue to educate you. Thank you so much for your time and your patience today. Be well.
Thank you, Dr. Shane Fox, for the nice lectures. Sorry, Dr. Christopher's Amato. So we're coming to now to the last lecture today about understanding brief resolved unexplained event in pediatric with Dr. Todd Chang. Welcome, Dr. Todd.
Hi, everybody. We are here to talk about understanding brief, resolved, unexplained events. I'm going to call it brew. Some people call it brewy, but it's just, for me, it's easier to call it brew. I think everyone has their own pronunciation of this relatively old entity. It's now almost 10 years old. And really thinking about how brew infants apply to emergency medicine. Our objectives are to define and recognize the historical evolution of ALTI brew and the current 2016 guidelines, which are technically almost 10 years old, and to describe the current literature that we know about in terms of brew management and in the emergency department setting. In order to do this, let's define and recognize this whole aspect of before brew even happened in 2016. Many of us know the term ALTI, apparent life-threatening event, and there's even older terms from the 1960s that I'm going to introduce as well. So most of this will come from the 2016 American Academy of Pediatrics clinical practice guidelines that talk about a brand new term at the time called brief resolved unexplained events, BREW, and the evaluation of low-risk infants and high-risk infants. Previously, it was ALTI prior to this, and this was published in 2016, which really changed the landscape of how we talk about these types of infants where something scary happens, but they seem to be okay when they come to the emergency department. So what I want to start with is in the 1960s is this idea of sudden infant death syndrome that started having a name, where very young infants typically are left alone and then are found, unfortunately, near death or at death. We know that once this syndrome was starting to be categorized, we know that there are certain associations with this syndrome, which includes making sure that the babies were placed on their back as opposed to other sleeping positions, and a few other demographic profiles as well. So we understood a lot about the associations and how to make SIDS essentially decreased in prevalence, but not too much else. But the terminology of SIDS really came about in the 1960s to talk about this phenomenon in which babies were found pretty much at death by the family or family members. In the 1960s to 1970s, these events that almost look like SIDS but actually did not lead to death did not have a name. And so the newest term at that point was something called near miss sudden infant death syndrome, also near miss SIDS. And this differentiated those patients that were dead and passed, or those patients that actually recovered, whether to completely back to normal or to some form of life. And this differentiation allowed us to really look at the difference between the patients once we knew what the ultimate outcome was. It did not really predict anything from the beginning once the event actually happened. And so the terminology in the 1960s and 1970s were all about records, death records, as well as hospital records, and really classifying which one was going to be which. In this particular example, we would obviously prefer to have near miss rather than the actual SIDS, and so a lot of research went into identifying who are most associated with this near miss sudden death syndrome. Then in 1986, the new term called apparent life-threatening event, ALT, came about that replaced the near-miss infant death syndrome for a variety of different reasons, some of which was more just to make new words and to change the way that the words were interpreted. I'm drawing this box much more large because in some ALT events, the patient was really not looking to be even close to death, but it just seemed very scary for the moment of time, and even included events where somebody thought to do CPR even though the child is otherwise doing fine. And so ALTI became this much larger definition, and it lost a lot of the definitions previously that associated with the term death. So what they did not want is to call it near miss sudden infant death syndrome, because the consensus was that the term SIDS and term death was not really the appropriate terminology. It provided a lot of families with increased anxiety, et cetera, et cetera. So we decided to call it ALTI as part of the scientific and pediatric community in 1986. And this is the full text definition at that time. It's frightening to the observer, apnea, color change, change in muscle tone, choking, or gagging. And in some cases, the observer fears that the infant has died, and that's the emphasis here. So here are the four main clinical signs, clinical history rather. And this really separated ALTI from SIDS. So we're moving away from the different age groups, different causations and causalities, and moving towards a different terminology altogether, and allows us to really think about being able to define and look for associations and risk factors for ALTI. The problems that were identified in the 80s and 90s and the early 2000s is that the definition made it much more open. So it made it really difficult, again, to discern abnormal or normal infant physiologies from the events that were being presented to the family or the caregivers. And it's much more difficult to discern whether the episode will recur, which is one of the two concerns. And then furthermore, because of the heterogeneity of all of these ALTI patients, which now has an inclusion criteria of any of these four items, it was really difficult to make recommendations on evaluation and management. The other problem was that it still emphasizes life-threatening as a terminology, which by just those words increases the testing and admission rates, which itself contains risk. And the word life-threatening, once the parents know what that means, increases their anxiety as well. So once these problems were identified, then the newest term that we see in 2016 was termed, where we now have this idea of BREW, brief resolved unexplained event. The key is that it's unexplained, we don't know why it happened, and that it's resolved, it was brief, and it is not necessarily life-threatening. So the definition has changed a little bit, in which the age is now a cutoff, so ALTI never had an age cutoff. The recommendation for however long it seems to have lasted was less than 1 minute. And then you must already have a reassuring history, physical exam, and vital signs appropriate for their age group. And there cannot be an obvious explanation that's already found either by history or by physical exam. So BREW really is a safety catch. Well, otherwise a well-appearing infant, something had happened, and all of these risks, all of these inclusion criteria have been met. So if we look at the difference between ALTI and BREW and the 2016 changes, there are several things that have happened. Number one, breathing definitions have expanded. So BREW could be any sort of breathing problems, not just apnea. It does narrow the amount of color change, so it's either blue or white or pale, and turning red is no longer an inclusion criteria. If you're turning red, that's more likely to be normal physiology and therefore not really worthy of even calling it a diagnosis. Tone changes was amplified. It has to be marked tone changes, either up or down, not just a little bit of tone or a little bit of jitteriness. They completely removed choking or gagging because it was felt that in the BREW definition, if there's choking or gagging, then a gastrointestinal cause was likely suspected and therefore no longer unexplained. You now have a direction to do a workup if you choose, or a subspecialty consult if you choose. It did add an altered level of responsiveness, altered mental status, I suppose, under the BREW definition, which was not necessarily present in ALTI. And then again, because of the unexplained part, you cannot have any other explanation after a good history of physical examination. So you're left with a reasonably healthy looking infant that something terrible had happened very briefly and that we can't tell what's going to happen next. So the clinical algorithm essentially that was proposed was to really go from a undifferentiated infant that otherwise could meet inclusion criteria, and then really moving towards this final diagnosis of BREW because you've really exhausted everything else before any testing has taken place. So again, the 4 clinical markers as well as the age definition have to be met. So this could be BREW at this point. You first check in the emergency department if the patient is stable or not, especially if their altered mental status is happening right now, that's probably not stable. So they have to be a yes on the stability question in order to progress to a diagnosis of BREW. If they're not stable, then please do whatever you need to do. This is not a BREW, this is real. Second, you take your history and exam, which there's some recommendations in terms of what to look out for or what kinds of organ systems to look for in the history and exam findings, but essentially you should not find anything remarkable in terms of history or exam findings to help you. If you do find something, a big rash, upper respiratory item issues, vital sign changes like fever, then you're not dealing with BREW. You're dealing with an actual entity. Please go pursue that entity as is. And then finally, you can't really have a good explanation of what happened. For example, the patient actually choked on something, in which case that's a history finding and there's an explanation. You're no longer a BREW. So essentially, in order to be classified as BREW, it's actually a very, very narrow definition. Once you have that BREW classification, then you find out if they're low risk or high risk based on the 2016 guidelines. Essentially, every BREW is high risk unless you can meet the low risk criteria. And these are the low risk criteria that we've seen here. They're different than the ALTI guidelines back in the day. But greater than 2 months of age, gestational age greater than 32 weeks, so can't be any preemie before that. You must have a total post-conceptual age of 45 weeks or higher. This has to be their first brew, otherwise any brew events thereafter are always considered high-risk brew or not a brew at all. The duration has to still be brief, just like the inclusion criteria, and the prior definition of ALTI of any CPR attempted is no longer the case. As we also know in the CPR literature, people are not that great at either performing quality CPR or recognizing when to do bystander CPR. So using a CPR by any bystander is no longer an appropriate method of determining low risk or high risk. So if it's CPR by a trained medical provider, like a paramedic, physician, nurse, then you got to move to high risk brew. And then obviously no concerning history or physical. So even if the history and physical are reassuring, you can still make brew. If there's any concern about the history that you might suspect, for example, suspicion for abuse, even though you can't prove it otherwise in the history and physical, then you no longer can move from low risk. You no longer can stay in low risk brew. And the reason for doing this is that the recommendations are simple. There are no recommendations for management for high risk brew. Please act accordingly to your clinical suspicion. The only recommendations that this AAP document had is for low risk brew, in which case there is weak to moderate recommendations to very much do very little, including discharge home with nothing, with recommendations of 2 possible tests that might be of the highest yield, which are pertussis testing, depending on the local prevalence of pertussis, and electrocardiograms to look for cardiac lesions. And that's pretty much it. High risk brew, please manage on your own. No recommendations from the AAP. Most likely, if you're high risk or definitely not low risk, then people are ordering things. People are starting to think about observation and admission. Whereas low risk, there's some optional testing and pretty much you're going home. Cool. So once these guidelines came out with a fair amount of evidence, but still not a complete set of evidence, we can review a few articles just to give a glimpse of what has really happened since this 2016 set of guidelines. Here's a study on diagnostic testing in brew. This is a single center just looking at characterized hospitalized brew infants and what happens if you decide to admit to them. What's known about this group is that if the decision was made to hospitalize for whatever reason, more than 3/4, 76%, had persistent brew episodes or repeat brew episodes, which is one of the concerning problems with brew that makes you want to admit as a high risk. 15% of the kids, once discharged, repeated a hospitalization for whatever reason, but we do know that quite a few of them, more than almost a third, 34% required some level of acid suppression that was prescribed, and about 10%, 1 out of 10, had some sort of abnormal test once it was decided to do testing. So the decision to hospitalize these 155 actually seems to have yielded something happening 75% of 76% of the time, with at least another episode that was seen, repeat hospitalization requiring H2 blockade, or with some sort of abnormal test that now brought you out of the brew diagnosis and into whatever the abnormal test is. All this is a mean of $15,000 US dollars per patient. So it's not without its costs, and 11,000-ish of the 15,000 were used for the hospitalization itself. Looking at a multi-center cohort, this is a multi-center study that was done in 2015 through 2018 for all brew ED visits. So this is no longer the hospitalized population. And in this case, this was an administrative database from 2,036 kids that were found in this database. So with this, sorry, I think these are clinical chart reviews, sorry, not administrative database. So this clinical chart review allowed the chart reviewers to determine whether the brew classification should be high risk or low risk based on what we know. And most of the kids are going to be high risk based on this case. 63% of these were hospitalized. So even though some of them are high risk, not all of them went to the hospital or as an inpatient. And 45% over the course of their stay had an additional final diagnosis that took them out of the brew diagnosis. Of these, 3% had a test that supported this final diagnosis. Just over 1% of the laboratory tests supported the final diagnosis. And of all the imaging or ancillary testing that didn't require any needles, only 1.5% actually supported the final diagnosis. So the chance of your test yielding the diagnosis or yielding a diagnosis on a patient are particularly low, 3% or less. So, which leads us to say that 97 to 99% of the tests per patient or tests overall are actually not going to yield a positive result. Of the ones that they found, of the laboratory tests, about 33 of the near 2897 tests, which is about 1% positivity, they found electrolyte disturbance in 3 LFTs and positive assays and cultures, as you see there. In this cohort, none of the infants had bacterial meningitis. For imaging and ancillary tests, there's another 33, so 1.5% positivity. The most common thing that was ordered, the 683 out of those, so a little over 25%, was a chest X-ray infiltrate, which was found in only 0.3% of all the kids that had a chest X-ray with a diagnosis of pneumonia, which is fairly low. For whatever reason, 226, so 10% of these tests were an electroencephalogram, an EEG. And 3.5% of these actually showed a seizure disorder. So we don't know why these physicians asked for an EEG or asked for a neurological consult. And then for neuroimaging, 3 out of 248, 1.2% actually showed either a stroke signs or abusive head trauma. You'll see a number of gastrointestinal items that seem to have a highest yield: pH probe studies, upper GI, video fluoroscopy, swallow study. Those are all positive in this particular multi-center review. And of note, contrary to the recommendation that we should be doing an ECG, patients with low risk brew, 0 out of 861 of low or high risk brews in this cohort that got an ECG had any abnormalities that was worthy. So the prevalence of cardiac diseases, at least in this multi-center cohort, was pretty much 0, at least identified by ECG. So when we look at a much larger cohort, but from an administrative database, the previous one was the clinical chart review, this goes way back again, pre-COVID, 2012 to 2019, either with the diagnosis of ALTI, which was more prevalent 2016 and before, or BRU after 2016 in the emergency department. And they looked at the differences between general emergency departments where there was no pediatric emergency presence necessarily, but they were qualified to take care of regular pediatric patients, and then a specialized pediatric emergency department visit. Because this was an administrative database in the US, this was about 20% of all ED visits across the United States in the ESO database. And then you see the distribution, 107,000 versus 26,000. Well, what's interesting is that on the left-hand side is in blue are general emergency department facts. On the orange, on the right-hand side, are pediatric emergency departments. What we're seeing is that this gray bar that's vertical in 2016 was about the time when the article was disseminated about the new terminology brew and the recommendations for low risk and high risk brew. And the good news is that even before this was being published in 2016, there was improving trend towards decreasing admission rates that appeared not to be affected and continue to decrease for at least 4 years based on the measurements since the publications in general emergency departments. What we then see on the graph B, the orange graph, is that we had been slightly increasing the admission rates in pediatrics emergency departments, but then sharply declined and continued that decline after these 2016 guidelines. So the 2016 guidelines seems to not really hit the general EDs in terms of admission rates, but it definitely improved admission rates for pediatric emergency departments. The counterbalancing measure was transfer rates, just in case that community emergency departments were transferring patients more to avoid an admission or as a reciprocal to admission. And we see that the transfer rates have not really been affected through this process. Looking specifically at ECG rates, because that was an optional recommendation for low-risk brew testing, the actual number of ECGs being ordered was really not affected by the article at all in general emergency departments, and it continues to enjoy just a steady increase with apropos to nothing. In the orange pediatric emergency departments, there was a slight decrease over time with a sharp increase in the 2016 guidelines by the AAP. Essentially, pediatric emergency departments seem to use the AAP guidelines much more heartedly, and it rapidly changes the practice patterns. That was a bit of a quick run through the definitions as well as the current recommendations. But essentially, the classification into brew requires an age, requires a history and exam that's relatively reassuring, and at least one of the 4 changes that are relatively specific, which includes tone changes that are markedly up or down, color changes which are either pallor or cyanosis and nothing else, changes in breathing, which includes diminished breathing, apnea, as well as hypopnea, and then it removes the choking and gagging, and it adds altered level of responsiveness as well. You must also not have had any other explanations that you can think of, otherwise it would be explained and not unexplained. From there, you're going to move to low risk and high risk based on the gestational age, post-conceptual age, and the total age as well, that no CPR was attempted by a trained professional, and that the patient otherwise looks well and has no concerning signs and symptoms. We now also saw the current literature on brew management, that these guidelines have affected especially pediatric emergency departments with relatively minimal change towards adult emergency departments, but a gradual trend towards less and less testing. However, if you do testing about 1 to 3% of the time, you may catch something that are relatively important to catch, but that's pretty much it. So we still have a fairly high number of kids who absolutely need nothing, and further research is required to really predict those kids in the high risk group to try and straddle it into a middle risk group. And that's where the literature lies right now. Thank you very much. I hope to see you in person at some point, but if you have any other questions, please write by email, and I'll be happy to get back to you with our brew working groups. Thank you.
Thanks a lot, Dr. Fang. I think so we are coming now to the end of our second day. Hopefully, inshallah, we'll meet tomorrow at 8 o'clock sharply, inshallah. All your questions, we will send it tomorrow, inshallah, with the answer, inshallah.